मेरा वो चला दो पीछे, डॉक्टर साहिल मृगपुरी जो पिछले कल का था ना, वेलकम एड्रेस। सीवी चला दे, सीवी चला दे। इनके सर्टिफिकेट्स आ गए बच्चों के सर्टिफिकेट्स आ गए बच्चों के। लिख रहे हैं अच्छा हैंड राइटिंग में। लिख लो, एक दो मिनट रुकते। नहीं, वो मेरी बात हो गई। We'll announce, we'll give the certificate and we will collect the cash of it. We have 3 winners, na? 1, 2, 3, 2. Okay. They are lucky to win the cash. बोला था सिंपल इसको यहीं पे आसपास में रखो। लेकिन आज स्टेज में भी देखेंगे। अच्छी साइंटिफिक प्रोग्राम दो, आज चाहे नहीं हैंडल करो। थोड़ा So you need this. I don't need this. I just need this. वो सब आपने करना है। मैं अभी स्टार्ट करूंगा क्विज और गुड मॉर्निंग एक वेलकम दूंगा एड्रेस टू डे 2. We had a wonderful day 1 long workshops. So I'm really excited. All it is Sunday. अभी पहले मैं कुछ और करता हूँ। उसको होने के बाद वो लिस्ट मैम के पास रखते हैं। क्विज वन को सर्टिफिकेट दिलवाने आप सबसे सीनियर अभी क्या सकते हैं लाइव अभी भी 8:45 मेरा लाइव और स्टेज पे मुझे डॉक्टर सुकेश को ऑनर करना है। check 1 check Good morning, everyone. So, welcome to day 2 of SODC. After a fantastic day 1 with in house more than 300 delegates and a faculty of 60, we rocked the all learning. It was followed by a gala night where everyone interacted and we had fun learning everything. So it is a relaxing Sunday, and I welcome all of you as well, those sitting at home and relaxing and want to learn things from home. Those of you who don't know me, I'm Dr. Sahil Mrekpuri. So just before coming live, we had a quiz session. So first of all, I invite here Dr. Sukesh MS, who was our quiz master. Dr. Sukesh. So Dr. Sukesh MS is a leading hair transplant surgeon from Bangalore and more like a brother to me. So we had a wonderful quiz session in the morning and we are just about to release the results. But first of all, I want to honor Dr. Sukesh. So can I have the mementos for Dr. Sukesh? So we have canvas painting for Dr. Sukesh. So now I would request Suniti ma'am to announce the list of the winners. And I request Dr. Sukesh and Dr. Madhuri to please hand over the prizes to them.
Good morning, everyone. Now, the world is full of diamonds and gems, and we are having some of them here today. With this note, I would like to give my heartiest welcome to one and all present here today. SODC aims to equip all honorable members present today with the best professional experience. Today is a platform for all of us to learn and share our expertise.
I welcome Dr. Madhuri Agarwal, Dr. Sukesh MS, and Dr. Amit Luthra on stage.
Now, we had a fantastic quiz session in the morning. Well, announcing the results now. The team that has won the second prize, Dr. Priyansh Gupta and Dr. Divya Bhatia from PGI Chandigarh.
Can Dr. Padmavati also join on the stage?
Now, the team that has won the first prize, that's Dr. Pratiksha Reddy and Dr. Vignesh Narayan, are again from PGI Chandigarh.
So we have a cash prize of 10,000 for the first prize and a cash prize of 5,000 for the second prize. That is sponsored by KLM Pharma. So now I request Dr. Madhuri to please stay on the stage. I would request Dr. Padmavati to please come on the stage and please facilitate Dr. Madhuri. Dr. Madhuri. So we have a canvas painting for Dr. Madhuri. So we'll take a short break now and within 5 minutes, we're going to start the session. I think KLM people are here or no? Oh, can I request Luthra sir to please come on the stage and we can facilitate, Dr. Madhuri can facilitate him. Can I request Dr. Padmavati on stage? I would request Dr. Amit Luthra and Dr. Madhuri Agarwal to please facilitate her with the canvas painting from SUTC. So we'll take 5 minutes break, and after that, exact on our starting time, we'll go live again. So you can take a tea break for 5 minutes and we'll go live again. Thank you so much.
squeeze it for you.
not to worry, I understand. Good morning and a very warm welcome to one and all. Now is the time to begin with the first session on Adapt and Master the Art of Advanced Botulinum Toxin. I request the chairpersons, Dr. Rohit Bansal, Dr. S.T. Mehta, and Dr. G.P. Thamai to come on stage and preside over the session.
Thanks for inviting me here. First of all, I want to thank Sahil and organizing committee for giving me this honor to share this session. And in this session, we are going to have discussion on adapt and master the art of advanced botulinum toxin. It's a session of 1 hour 45 minutes. First, there is a session 9 to 9:15 by Dr. Padmavati, botulinum toxin for lower face and neck, and it will be followed by panel discussion 9:15 to 9:35. It's 20-minute duration, and then after that we will have hands-on session for 1 hour. And I would like to invite Dr. Padmavati for the session botulinum toxin for lower face and neck. And Dr. Padmavati is dermatologist and into practice since 20 years, and she is founder of Pragna Skin and Laser Clinic, Hyderabad. And she having interest in injectables, lasers, and body contouring. And now over to Dr. Padmavati.
Good morning, everyone. First of all, I want to thank Dr. Sahil and Dr. Madri for inviting me and giving me this opportunity. Today, we'll discuss on botulinum toxin, lower face and neck, advanced indications. So botulinum neurotoxin is produced by the bacterium Clostridium botulinum. There are 8 major serotypes, A to H, and only botulinum toxin A, which has the longest duration, is used for the aesthetic treatments. And a Clostridium botulinum produces a complex of 150 kilodalton core neurotoxin complexing proteins surrounding the core. The core neurotoxin is similar in all botulinum toxin A's. It consists of 2 parts, a heavy chain to target and enter the nerve terminals and the lighter chain to inhibit the interaction between the nerve and muscle. The core neurotoxin is free from complexing proteins at physiological pH. The role of the complexing protein is to protect the 150 kilodalton protein in acidic environments. So normal functioning of neuromuscular junction is the vesicle with acetylcholine. It docks with the nerve membrane and acetylcholine is released into the synaptic cleft. It binds to the receptors on the muscle cell and the muscle contracts. So what botulinum toxin does, it temporarily blocks the nerve to the muscle communication. It blocks the presynaptic release of the acetylcholine. So there are many different varieties of botulinum toxin now available in the market. 3 types are approved and available now in India. On a botulinum toxin, that's a Botox from Allergan. Above botulinum toxin, that's a Dysport from Galderma. And incobotulinum toxin, that's Viomin, which is with MERS. So these are the manufacturing details. They come with the different units like 50 and 100 and 300, 150. The dilutions and all we'll discuss in the workstation. And if you want to have the comparison, the onabotulinum and incobotulinum, 1 unit is equal to 2.5 units of abobotulinum toxin, that is Dysport. So coming to the lower face and the neck, we have to treat it as a one cosmetic unit. Orbicularis oris interdistate with the upper lip elevators above. You can see it interdistate with the elevators above and the depressors below. So we cannot target one single muscle. You have to treat it as a one unit, and then you have to know the anatomy very well. The muscles are laid also, so how deep we have to inject also, you have to be very sure. And platysma is the major lower face depressor and interdistate with the various depressors of the lower face. So you have to know the functional anatomy and inject very low volumes, minimal dose into the belly of the muscle to avoid diffusion. Inject symmetrical volumes on the both sides to avoid complications and asymmetries. What do we do when we do the lower face and neck? The major indications are the gummy smile, mouth fine, smoker's lines, and asymmetric smile. And then the jawline definition, you have to treat the chin, DAO, and the very famous Nefertiti neck lift. And for facial countering, you can address masseter, parotid, and platysma. Neck vertical bands, horizontal lines, and we can do neck rejuvenation also with the Botox. So I'll discuss only the few major indications because the time is less. So coming to the mouth front, it is because of the overactive DAO. It pulls the corners of the mouth down, as you can see here. So it gives a negative expression of sadness and unpleasantness. So origin of the muzzle is, it's a triangular muzzle, you can see. It's a triangular muzzle. So it originates from the mental tubercle all along the body of the mandible. It goes up and it inserts into the modulus. It is lateral. It's very lateral and superficial to the DLI. And so it narrows as it travels up and inserts in the skin and modulus, interdisdating with the risorius, orbicularis oris, LAO, zygomatic major, and buccinator. Its action is depresses the oral commissure laterally and downwards. So how to mark it? Draw a vertical line from the nasolabial fold to through the corner of the mouth to the mandible and anterior border of the masseter, just 1 centimeter above the mandibular margin. This is the point where you can give an injection. Otherwise, you can palpate the DAO while contracting actively the corners of the mouth down. The lower part, that is 1 centimeter above the mandible border, is the safest point to inject. You have to inject superficially, just below the subcute to avoid the DLI. Inject 1 centimeter above the mandibular border. Don't inject high as the DAO interdistate there with the other muscles. And you can inject 2 to 5 units. Coming to the complications, injecting very high may relax the orbicularis oris. You can see this. If you inject high, it can relax this orbicularis oculi, and then it can cause incompetence and closure of the mouth. Injecting medially can relax the DLI and cause an asymmetric smile. Injecting higher doses may also seep into the surrounding muscles and cause the above side effects. These are a few before and after pictures. is another one. I think we have to do a bit of fillers also in the marionette lines. Next, coming to the gummy smile, this excessive display of the maxillary gingival tissue. It's more than 3 mm is termed as gummy smile. The causes can be dentoalveolar extrusion, vertical maxillary excess, which is a dental procedure, and can be because of hyperactive lip elevators, where we can treat with the botulinum toxin. I'm sorry. So these are the muscles of the upper lip elevators, elevator labis superioris and aliquinaceae, zygomatic major, minor, and the depressor septi. There are types of gummy smile. Anterior one means the central canines are majorly exposed because of the hyperactivity of LLSAN and LLS. Posterior is major exposure of the posterior to the canines. That is because of the hyperactivity of major and minor. In mixed, you can see both anterior and posterior gummy smile. In anterior gummy smile, that is to address the levator labiae and the aliquinaceae. Inject a point at the bulge of the nasolabial fold. The site is determined by the animation smile and palpation or contraction. That is at the apex of the nasolabial fold. This is the point where the aliquinaceae and superioris will interact. And for the posterior gummy smile, 1 centimeter inferior and lateral, that's the overlap of levator labiae superioris and zygomaticus minor. But in a few studies, it was shown that if you do this point, if the levator labiae superioris aliquinaceae was not treated, or the gummy smile was not totally corrected. So then comes the famous Yonsei point, that is the center of the triangle formed by the 3 muscles, LLS, LLSAN, and then zygomaticus minor. It is a 1 centimeter lateral to the ala and 3 centimeters above the corner of the lips. This is the point. So if you do this, all the 3 muscles which act for the gummy smile are addressed. So this is the point. Now everybody approved, and it is easier for us to inject. So this is one of my patient, the before and after pictures. Coming to the complications, lip ptosis, lower lip protrusion, asymmetries, and then excessive lengthening of the upper lip. Coming to the mentalis, and we can treat popliteal and the mental crease. It's a hyperkinetic mentalis can cause involuntary localized dimpling and overall puckering of the chin. Ask the client to push her bottom lip up against the upper lip. Puckering will be visible. If the client have oral incompetence issues or protruding teeth, the client may compensate with an overactive mentalis to force the bottom lip. So you have to be careful in these patients. So coming to the anatomy of the mentalis, it's a short 2-bellied muscle. Origin is an anterior aspect of the mandible on either side of the midline at the level of the lower lateral canines. And the 2 bellies converge at the midline to insert interdigitating with the skin, the chin. And it lies deep to DLI. If you can see, it is deep to the DLI. So injection technique is 4 to 6 units depending on the bulk of the muscle. I can take it as a 1 injection point in the midline or 2 injection sites, 1 point on each side of the midline, vertical if they have a vertical mental cleft or a wide square chin. Inject deep at the bone mentum. Inject far below the mental crease to avoid orbicularis oris. Aim is to relax the superficial fibers. These are the 3 points where you can do single, 2, or if you can take a small injections, 4 points also. So coming to the complications, avoid injecting above the mental crease because orbicularis oris can cause oral incompetence and difficulty in articulating certain letters. And diffusion of DLI can cause an asymmetric smile. Coming to the masseter, indications for masseter is a facial contouring. It can be because of benign masseteric hypertrophy or racial, like East Asians, and for bruxism also. So coming to the anatomy, the superficial portion arises from the zygomatic process of the maxilla, anterior 2/3 of the lower portion of the zygomatic arch, and the posterior originates from the medial surface of the zygomatic arch. It descends posteriorly and ends at the mandibular angle and mandibular ramus. See, coming to the marking, the parotid gland covers the posterior aspect of the masseter muscle, and in some cases it can overlap the whole anterior portion. Parotid duct has its core superficial to the muscle, usually located on or above the reference line, connecting the tragus and the corner of the mouth. The marginal branch of the facial nerve has been shown to locate at least 7.5 mm above the inferior mandibular margin. So this a bit above this, and the facial artery and vein run usually anterior to the muscle with the facial vein on the surface of the muscle. So when we have to avoid all these structures, so the safe point to inject is the anterior border of the masseter, posterior border, and the line traversing through the tragus and the corner of the mouth and the mandibular border. You can give 3 injections in a triangular fashion, or you can give 4 injections if the muscle is more bulky. So 15 to 30 units of botulinum toxin on each side. It should be a deep injection. You have to use a 13 mm needle, 3 injection points or 4. Repeat every 3 to 6 months. Complications. The common complications are bruising, hematoma, pain, headache, chewing weakness and pain. It will be very temporary. Poor or no effect if you do a lesser dose of the toxin. Jowling and sagging due to substantial volume loss. Sunken lateral cheeks due to muscle volume loss. Asymmetry in smile if the toxin seeps into the risorius. Paradoxical bulging if you give more on the anterior and leave the posterior masseter. Xerostomia if the parotid is involved. So these are a few before-after pictures. You can see the oval narrowing of the lower face to give the good oval contouring of the face. And this is one of my other patients. So coming to the jawline and neck, the platysma is a depressor of the lower face. It is hyperactive to support the ptotic lower face in the aging individuals, and loss of tone leads to loss of jaw contour and vertical bands, commonly told as turkey neck. Horizontal necklines are formed due to increased skin laxity. Coming to the anatomy, it originates from the superficial fascia of the upper chest and then inserts medially into the mentum, centrally into the periosteum of the rami of the mandible, laterally into the depressor muscles. Its contraction pulls the skin to the center, forming a horizontal lines. So the famous Nefertiti neck lift, it causes a remarkable contouring of the mandible, elevation of the skin in the mandibular line, and elevation of the corners of the mouth. So the points to be injected for Nefertiti lift are along the inferior mandibular border. This is the one. 2 to 3 centimeters apart, posterior to the line which traverses the nasolabial fold and the angle of the mouth. To the mandible, anterior to the sternocleidomastoid muscle, all along the prominent vertical bands. So 2 to 3 units each point, 3 to 4 points along the bands, total 15 to 20 units on each side. For the horizontal necklines, 1 to 2 units along the horizontal necklines, 2 to 3 centimeters apart intradermally. And you can do a microbotox, that is hyperdiluted small amounts in the intradermal plane to avoid diffusion. Aim is to achieve mandible elevation, cervicomental contour and softening. You can inject all over these lines to relax the mandible for the microbotox, so that you can get a good elevation of the lip and the jaw contouring and relaxing of the platysma. So coming to the complications, lip incontinence and smile asymmetry if the DLI and orbicularis oris are involved. Difficulty in neck rotation and raising from supine position if the sternocleidomastoid is involved. Higher doses diffusion into the deeper muscles may affect and cause dysphagia, dysarthria, and dysphonia. These are a few before and after pictures. This is day 1, and then we give a buttocks. This is the result. And then after she came for after 2 weeks, and then I injected a filler for the necklines, whatever is remaining. This is the result. I think for the neck, you should combine all the procedures. A single one may not help. A bad picture, but I want to see the platysmal bands, how they decreased after treating with the botulinum toxin. This is for the jaw contouring. She have a little bit of, submental fullness. So this is after I did the Botox and she was not happy. I had to add a filler for her. This is the other side of her day one Botox and after the filler. Thank you.
Thanks, Dr. Padmavati, for nice presentation. Now we can have questions from audience.
Thank you for a wonderful talk, Dr. Padmavati. May I request Dr. Madhuri Agarwal and Dr. Amit Luthra to please facilitate Dr. Rohit Bansal. I would request Dr. Madhuri and Dr. Luthra to please stay on the stage. I would request Dr. Anurag Tiwari to also please join us on the stage. I would request now our three stalwart faculties to please facilitate Dr. Sudha Vani. So we have a canvas painting for the beautiful lady. Now may I request Dr. All our three faculties to please facilitate Dr. Sejal Shah. Thank you so much. So now I'll hand over the mic to Dr. Rohit Bansal, and
I would like to invite Dr. Anurag to moderate the panel discussion. Dr. Anurag, please come on.
Thank you very much. A very good morning to one and all. It has been can I have the slide, please? Slide on. Yeah. So I request the team, Madhuri, Amit, Padmavati, Sudha, and Dr. Sejal to come over. Now we are going to have a discussion about what Dr. Padmavati has already talked about. And we'll discuss a little bit the final points, how to go about doing it. We have a mic, and I would love you all to participate, ask your queries, and let's give a really tough time to these able injectors and find out about how the best results, what they show us, are possible. A very good morning to you all. Madhuri, I want to start with you. I promised I will not start, but then I have to. This is not working. So the topic was advanced botulinum toxin. So what does it say? Like, what do you mean by advanced? And when should an individual start doing that?
Hello.
Yeah.
Can you hear me? I'm audible? Yeah. Good morning, friends. And good morning, my dear Anurag. Thank you for starting with me. See, my interpretation of advanced, I would say it's a learning journey. So for me, when I mean basic, it's, I think along the lines we have developed that, which is easy anatomy, easy muscles like your upper face is a basic thing to do. Once you get the confidence, then you can move over the entire face.
Right.
Advanced can be, any muscle of your face, of your neck. In fact, we go to axilla, we do palms and soles. So it is like any other machine or device. Even injectables, we evolve and start doing different indication once we gain a little bit of confidence and mastery over it.
Right. So you'd like to start with the basics as the upper face because muscles are relatively easier to identify.
And less of nerve supply.
And so that you can mature onto other ones. So this is just what the advanced and the basic means. Now, in advanced Botox, Amit, let me get you here. when we talk about advanced Botox, the lower face, I am a basic injector. Now, which would be a relatively safer advanced version where I start and then mature on to other areas?
I think platysma would be the easiest one amongst the 4 indications that we're talking here.
Right.
And the only thing is, as Dr. Padmavati has already mentioned how to go about it, it's easy to inject. And it's very easy if you see the platysmal bands. So you just hold the platysmal bands and inject. So that would be the area.
And the toughest in your...
the one fraught with complications would be probably DAO injections. So
right.
That's the risky thing.
Yes. So DAO is one of the most risky areas. Start with platysma, go on to the DAOs and others. How do you decide the dose for each area? Sudha?
So first we need to assess the muscle action in rest and in animation and muscle. Some areas we need to feel the muscle bulk also. Depending upon that, we need to decide the dose.
Okay. So there are some ballpark figures which you talk about and you go with that?
Just to add that there are consensus guidelines which have come in both for India and Asia, which is a quick reference for us to know which doses.
Right.
And I think when you interact with expert trainers like Dr. Amit, Dr. Sejal, Dr. Padma, they will also, with their experience, share that this is the minimum dose which I find result with, and this is the maximum you can go. So again, we have both algorithms as well as trainers to help us decide the dose.
And isn't it better sometimes to do a little bit of underdosing and call the patient back and then re-inject a little bit? Dr. Padma, what is your take on this particular thought process?
I totally agree with you. As Dr. Madhuri said, we have a fixed, this area you can treat this much. And I always love to go with the lower dose. And then I ask them to come after 2 weeks and then I can do a correction later.
After 2 days, you call them after
2 weeks.
2 weeks. All right. Fine. So this is what is something like a basic framework on which you can start injecting these particular. Now, Sejal, in case, like when you're doing any other areas, in case you inject intravenous, you have times when you just hit the vessel and sometimes you inject. Is there something which happens or it just goes off?
So the commonest is obviously you hit a vessel, you will have bruising as a complication. Right. Luckily, most cosmetic indications, the dose that you use is very little.
Right.
So any kind of vascular spread otherwise causing any kind of toxicity, the chances are very rare.
Okay.
It's only when you have to use it in a higher dose, maybe say for some therapeutic indication, that's when the chances of toxicity with the molecule can happen.
Right.
So otherwise, bruising is the main complication.
Bruising is the main complication. You would have to really worry about what we are worried in fillers, etc. So is there a maximum dose per person? Anybody can take it. If I'm doing a trapezius, if I'm doing a platysma, if I'm doing the Nefertiti, so a patient wants it all. So would there be a maximum dose, Amit? Like 100 units, 200 units? On a single session or what?
So if you're combining your face and neck, you can go up to around 130, 140. If you're combining the face and the neck together, even the masseters, you might even go up to 150.
Right.
I don't think there's any issue with the number of units.
So the number of units should not matter. You can go ahead and inject as per our experts here.
Just to add, what I read in one of the papers is 300 is the maximum you should inject, not beyond that.
Sorry?
One of the papers mentioned you cannot inject more than 300 units. It's 300. Not advisable.
That's a huge.
That's huge.
200 to 300 units at the maximum we can give.
So that's well below what Dr. Amit said, 150 units.
The only issue is if you inject around 300 units, you tend to get a kind of flu-like illness. And it's quite common in people who are doing for the neurological complications. So there you tend to have more of flu-like illnesses and headaches. Doesn't happen in the cosmetic.
So that goes off. You don't have to really treat it and it will go off in a couple of days.
Yeah, antibiotics would do the trick.
Okay. Dr. Padma, you wanted to add something here?
No, I don't want to confuse the young injectors that what they're talking, the total dose is not for our cosmetic indications. 200, 300 is when they do the skeletal muscles for the neurological complications.
Even the palms, when you're injecting two palms you're using 100 units. When you're doing axilla, along with that. So we hit around 150 odd units is something which is possible in your practice. Not 300 as you rightly said. Well, a very, very interesting diagram. Now, I'm just going to ask the expert panelists once again to point out the various indications, the amount of injection which they use, and the exact way you go about it. Like you go in vertically, you go in horizontally, and what can happen, what wrong. So you can choose your indication. I'll start with you, Sejal, and the pointer is here. You can use the pointer. Any you choose yours. See, I told you that I'll help you. You're on my side. No, it's not one. The pointer is not one. You can just go in. You come here and show. Okay. This one. So take one indication of your choice.
Start with the bulkiest one, that's the masseter.
All right. So show us the muscle and how do you go about it?
That's the muscle. You feel for the muscle first. Gauge the strength of the
Mike.
Gauge the strength of the muscle. Feel for it. When you mark it, you take a line from the corner of the mouth to the tragus. So
Right.
that's your upper limit. You ask the patient to clench the muscle, mark the anterior border and the posterior border. The mandible acts as your inferior border then. I usually do a 3-point injection. So take the first point, which is the point of maximum contraction. So when you feel it, the point where the muscle hits your finger, the maximum, that's your first point. And then I take 2 other points, which are in a triangle to the first point. Approximately, I use around tentatively say 50 to 60 units, both the sides, depending on the size of the muscle. So about say 25 to 30 units each side.
And
it's injected deep. I use usually
which needle? Yeah.
8 mm insulin syringe, that's a BD syringe. And I give a deeper dose. If the muscle is really very, very bulky, then sometimes I also give a little superficial into the superficial belly of the muscle. But otherwise, mostly it's an 8 mm deep injection.
Right. So it's a conventional insulin syringe. Some people say that you should use a tuberculin syringe also. So what's your take about it?
I am very comfortable with the insulin syringe. So
All right.
8
So-
mm usually works well for me.
Very fine. You hold the muscle up and then inject?
So you ask them to contract the muscle. So this is one of the injections which is done with the muscle in contraction.
Right.
You inject in. The moment your needle is in, you can then start injecting and ask them to relax the muscle post that.
Right. Thank you. Thank you. Yes, Madhuri?
Okay, so I'll go with the neighbor, mentalis. So this is what we're talking of. As Padma showed the muscle beautifully, it is a small muscle and it causes the pebbly chin or retrusion of chin with
Right.
age. Like most of us see the chin going inward. So if it's a small chin, you just go in the midline and perpendicular injection of 5 to 6 units is what I give. And if it's a broad muscle wherein you can see that, diversion, then I would go and inject again perpendicular directly by asking the patient to again, clench and make the muscle prominent and go in and inject around 4 to 5 units each side, again, depending on the bulk of the muscle. So maximum is 6 units each side. I don't go beyond that.
All right. So the important point here is that they are identifying the muscle, they are contracting the muscle, they're holding the muscle, and then going in directly in the muscle. Amit?
Okay, the toughest one probably would be the depressor angular oris, as we
Right.
discussed.
Right.
This is that muscle, as Dr. Padmavati already mentioned, it's kind of inserts in the modulus here. The muscle is a fan-shaped muscle, so it becomes a little easier for us to inject. As she showed, you should take the nasolabial fold as the landmark, draw a line which goes and hits the mandibular margin, and then you inject a little medial to it so that you hit the muscle here. So don't try and do the injections up here. Some
Right.
of the plastic surgeons advise that you should be injecting here because the main bulk, according to them, is here. This is a safer place to inject your DAO, and it has to be very superficial. So you just prick the skin and inject, unlike when you're injecting mentalis, which has to be a little deeper. The common culprit in both these cases is the depressor labii inferioris, which is right here, this muscle here. and you might end up with an asymmetric smile if you hit the DA line.
Right. So the point here is that you need to inject superficially for the DAO. And all right. Yes, Sudha?
So I'll take up this platysma muscle,
Right.
which is a very superficial muscle. First, before injecting here, it causes necklines. So first we need to assess the muscle, because sometimes it may be a diffuse bands will be there, multiple bands will be there. Sometimes it is a diffuse thing, because here the muscle decussets from one side to other. So we need to assess the patient first, whether there are bands, multiple bands are there or diffuse. Accordingly, we need to inject 2 units per injection, 2 centimeters apart. When the bands are visible into the muscle, we need to inject. When it is diffuse superficially, we need to inject, and maximum dose is 40 units, 30 to 40. We should not give more than that. Otherwise, dysphagia and the
Any points to avoid? Any areas where you would be more careful about injecting?
While injecting, we should not inject into sternocleidomastoid muscles.
Right.
And if it should not be very superficial, which diffuses into depressor labii muscles, which causes liptosis.
Yeah. Madhuri, you would like to add something?
Yeah, in the lower half of the neck, because you have hired another vital structures there.
Right.
So at the beginning, I would say keep yourself to the upper neck. And
Right.
then as you are more confident, then go to the lower part.
Then go to the lower. Yes. Padma? Gummy?
When a gum
We want you to show the point. We want you to show the point here. The Yossian point. And there is a lot of controversy about this point, I guess. Yeah, but first let us learn what point she mentioned about the gummy smile, and then we'll talk about it later.
So this is the levator labii aliquenesi, and this is the levator labii superioris, and this is the zygomaticus minor. So they say the anterior, like, if you're showing the 2 incisors, this is the 2 muscles which are hyperactive. And if you're showing like posterior to that, these 2 muscles are more active.
Right.
So a few people, they inject here just where these 2 muscles are interacting, just besides the nasolabial fold when they smile and contract. And if there is a mix, they say you inject a bit here where these 2 muscles are interacting. So this is a bit confusing. When they did this for the posterior, they say that there is a little bit of anterior. If you don't address the aliquenesi, the gummy smile was not totally corrected. So this is the point where all the 3 muscles are interacting. So 1 centimeter just lateral to the nasolabial fold and 3 centimeters above the lip. This is the area where all the 3 muscles are interacting. So this point is the best point to correct both anterior and posterior gummy smile.
Amit, you'd like to add something here?
Okay, though in theory it kind of sounds pretty good to inject there, but practically I would say it's not a great idea because we've seen a lot of complications. Can I just point it out?
Padma, can you pass me?
I think a good point, a safe point would be probably to inject in the nasolabial fold. You go in and just hit the LL sun. More often than not, if you hit the LL sun, it would somewhere here, if you're injecting, it will diffuse into your the other muscles, the levator labii superioris as well.
Right.
So more or less, it tackles a gummy smile. This would be a risk because you're getting into orbicularis oris territory, and there would be some lip drop and other such issues would be there.
I agree. The safety point would be in this particular. Of course, Dr. Padma is a very experienced injector, so she would be probably more easily able to discern the muscles. So while you're starting off if you're starting your gummy smile, then Amit's way would be the initiator, and then possibly if you want more science to it about the lateral or the medial side being more elevated, you can start injecting any other way. Well, Amit, one of the indications which I wanted to talk to you about is the latest, which trapezius. We're seeing a lot of trapezius injections happening.
Okay, so trapezius basically is a bulky muscle on the back, and you would use it to kind of get the hump that.
And first, tell us what indication.
Okay, so
what kind of patients do they come? What complaints do they like?
People, especially if you see a lot of ladies have this hump on the back, and there are a lot of people who are exercising too much, so they also have this trapezius, which is hyperactive.
Right.
And there are people who have neck pains. They do tend to have unilateral neck pains as well. So you knock off the trapezius. Now that this muscle is huge, so you can't really knock it off. So what you inject is roughly in the upper 1/3. So it's the injections are roughly, if I have a figure, I can probably show you on the posterior side, but the injections are 3 injections in the upper part, 3 injections in the shoulder portion. And that's how you inject 3 units per injection, roughly around 15 to 18 units per side. So that adds up to around 40 odd units. You can go up to 100 units as well. I mean, that's what the South Koreans are kind of talking about. It gives you a long neck as well. So it's a good indication for brides to be. So when they want to wear the jewelry and the neck is short, you can actually increase the relative neck appearance.
Yeah. So this is one of the cosmetic indications, the newer cosmetic indications, which has seeped into the. All right. We'll not talk about this. We'll just briefly touch about hyperhidrosis, axillary, and palmoplantar. Quickly. We'll start again with you, Sejal. Axillary.
Axillary hyperhidrosis. So in fact, it's a very good indication for botulinum toxin.
Sejal, can you just hold it close?
Yeah. So a very good indication for hyperhidrosis. So using a botulinum toxin for that, you see results almost instantly, and they do last for a good 3 to 4 months. You do a iodide test first. Mark the area that has the maximum amount of sweating. We use the toxin in the regular dilution. It's injected intradermally. You raise a small papule. Around 50 units is usually what's needed. So you do about 25 to 30 each side, 50 to 60 units. And you more or less see the action in about 7 to 10 days to max up to 2 weeks.
Any complications that you would like to
So dryness, if you over-inject, sometimes you could see a little more excessive dryness. Otherwise, when it's injected in the right plane, I haven't come across any complications as such.
All right. Madhuri?
So I'll talk about palmoplantar.
Palmoplantar, yeah.
Basically, palmoplantar is again a little difficult because the skin is very thick out there.
Very thick. Yeah.
And the numbing cream or the anesthesia doesn't always work the local. So sometimes experts recommend that under the guidance of an anesthetist, you can do nerve blocks.
Right.
And then do it the radial and ulnar. So yes, I have tried that. But I found my patients are more comfortable doing it under topical because they lose that sensation of hand with the blocks. So again, the same way we apply the do the starched iodide testing, figure out which is the maximum area of sweat. And then I use my insulin syringes and inject. It's anywhere between 60, 80 or even 100 dose per palm actually.
Per palm.
And patients are very happy because socially it is very embarrassing to sweat when they are interacting.
Do you go up to the fingertips?
I generally avoid. I
yeah.
stick to the palm. I generally avoid.
Stick to the palm.
Yeah.
Amit, would you like to add anything to what has already been discussed?
I think axilla, you'll have to go up slightly higher. Sejal mentioned 25 to 30. Yeah. We go up to 50 units per side.
Per side, yeah.
Palms also, you'll have to do the fingers because what happens if you just do the palmar aspect and forget about the fingers, it will sweat.
It will sweat more.
It will sweat more.
It sweats more sometimes.
So you have to do the fingers, and it's always better to do the palms under a regional block, the median and the ulnar, as she mentioned.
Yes.
Topical doesn't work, honestly. It's very painful. And
very painful. Very, very painful. Okay, one final question. We are out of time. That age-old
discussion. This is like an excellent session.
Oh,
and,
okay.
We all would love to listen more of it for about 10 minutes.
Oh, that's fantastic. Then we can discuss it further. All right. So, what about the plantar aspect? Has any one of you tried about it? And what is the dose? Once again, the anesthesia you use. It's a tough place to do.
You have to do a posterior.
And what is the needle you use? Because it's a tough place. So whether you go in with the insulin or
you can use an insulin syringe, but again, a nerve block is required. A posterior tibial, I think, is what we use. And it can be a little cumbersome for a dermatologist, but I mean, if you just read the thing and do it, it's fairly okay. I've done 4-5 cases of the soles as well.
Mm-hmm.
I do ask my patients post the blocks to remain in the clinic for an hour or so that the weakness bit is taken care of a little bit.
Right.
It's fairly easy as long as you get over that hitch of doing the blocks. That's the only issue.
So in fact, a dermatologist is also okay with doing blocks. We do blocks of the face. So you can easily learn the blocks of the hands, the feet, which will help you possibly in your vitiligo surgeries or any other surgeries which you intend to plan for these patients. One question which I wanted to ask, which is almost with everybody, how long can you actually keep the reconstituted toxin? I'm opening up the Pandora's box here because Sahil has given me 10 more minutes. So yes, I need to ask these a few things. Yes, Padma.
Nowadays, they say 4 weeks we can keep it.
4 weeks.
4 weeks, but stored in a refrigerator, 2 to 4 degrees.
And is sedimentation in the toxin bottle, if the toxin bottle has got a little bit of sedimentation, is that a strict no-no for reconstitution? Or is it okay to get sometimes a little bit of whitish sedimentation there? No. The fresh bottle?
I didn't get you. I think if somebody else can take it.
I think it should be a clear solution. You cannot have anything floating around.
Right.
It has to be a clear solution. Once you reconstitute, that's what you
No,
need.
no, before that, if you have a, if
You have
sometimes-
that
powder will be
It's a powder anyways.
Yeah.
No?
So that's
It's
okay.
normal.
Yep. Yeah. Sometimes it clumps actually instead of being around the things. So any other questions from you guys? Yes, please go ahead. Right. DAO, Amit, Gummy Smile, Padmavati.
DO, you got to go conservative. So 2 units per side is good enough. Sometimes rarely 3 units. So 2 to 3 units per side.
Gummy Smile also the same, I think. 2 to 3 units per side, and then you can again call them back and do it.
Yeah, please go ahead.
I don't think so. It will cause the lip ptosis, but few injectors does, and I studied in a few, but I don't follow that.
That's more for the depressor septa. If
Yes.
you want to lift up the tip of the nose.
Tip of the nose. And while we are at it, there are a lot of people who come with a flared nose. So that is also an indication which a lot of you are injecting. So what is the anatomical landmark and where do you inject for the flared nose? Yep, please go ahead. Use the mic.
In the center of the alley is where we do.
Yeah.
And 1 to 2 units, not more than
1 to 2 units. So the flared nose can be made a little bit leaner, the lean machine. So it could be like that. Trapezius we have done. Okay, keloids.
So yes, I have been trying it out and I find quite gratifying results because the principle is the muscle is contributing to the contractures.
Right.
And what I like to do is I like to do my intralesional steroids and I also combine the toxin in the same injection on the same day.
Okay.
As in I do my intralesional steroid first and then I do my toxin. And it gives great results and the results are more longer lasting. So somewhere I think there are new papers coming up which are showing the merit of it.
Yes.
In the use of keloids and multiple indications. Anyone else?
So you inject.
Anurag, your experience with it?
Injection of botulinum toxin should be around the
yeah.
keloid instead of the center of
Yes,
the keloid.
it should not be into the keloid. It's around the keloid because we want the muscle to relax. We're not, and you're hitting the keloid with the intralesional steroid 5FU combination, whatever you have, and you just relax the surrounding muscle. Of course, combined with the laser hair reduction also in case you're doing the chest. So that this kind of becomes a holistic kind of a treatment so that recurrences become slightly lesser and the patients are more comfortable. Same session. You inject in the center and the surrounding area, you do the toxin. What is the dose you use?
Again, it depends on the keloid size and the area. I think that's what I decide by. I don't have like a...
There's no fixed dose related criteria. It all depends on the bulk and it all depends on how thick the surrounding skin is. So you can see those skin which is patching up, going up the towards the keloid. That is where you start injecting 1 to 2 units on those particular areas. Go around the keloid. Let's say around 5 to 10 units would be the max you'd inject. Well,
I find in my experience, the results are better when you're doing on your trunk areas.
Right.
Bigger areas, thicker muscles, little
Yes.
difficult, or
Yes.
very large keloids.
Well, this is something which can happen. So while you're injected, Amit, please take us through it.
Okay, this is a patient wherein we tried to do the DAO.
You can use you have the pointer, please.
Okay.
Yeah.
So this is, we tried to get rid of, okay, so we tried to get rid of the DAO, and this is how she's after the treatment at rest. But the moment she's trying to smile, you see the deviation happening. It's because the DLI has been hit. Now, the DLI has been hit on the left side. That's why you see the mouth going this side. Now, what is the treatment option? The treatment option would be to probably knock off the DLI on the other side. So there's a symmetrical smile. Or you wait it out for 2 to 3 months. Those are the two solutions that you have. Again, the reason was we probably went a little too deep and hit the DLI while injecting the
And
DLI.
how long after does this complication come across to you?
I mean, it come in as early as 7 to 10 days.
7 to 10 days, the moment it starts.
I think there are also variations, right, in anatomy. I mean,
Yes.
sometimes in
Exactly.
certain individuals, you may be in the right plane, but the muscle is behaving in a different way there.
You have multiple heads, and that's why the importance of learning your anat. And particularly what Madhuri said, this is what the advancement is all about. This is what makes it an advanced botulinum toxin. So, yes.
Okay, this is a case, I know Sejal mentioned that 8 millimeter. This is what happens if you're injecting very superficially into the masseter. This is called the chipmunk facies, wherein only the superficial head has been treated and the patient is now contracting. So you have the deep head coming out, projecting out. So you need to knock off both the superficial and the deep head of the masseters when you're doing your treatment. A good way of injecting would be to inject with 8 mm superficially and go 13 mm for the deeper bulk. Or what you can do is when you're injecting, you ask the patient, as Sejal mentioned, to contract, inject at the apex. The rest of the 2 points can be injected as the patient is relaxing. So you're trying to hit the deeper head. That is one way of doing. Or you use a tuberculin syringe.
Tuberculin syringe also. And there was earlier a point, 1 point, 3 point, 5 point, 7 points also. So are you all okay with the 3-point technique, as in the triangle happening, and that would be probably the safest and giving the better results?
Yeah, so I think we started with the 5 and 7 points when we were initially learning, but we moved to the 3-point. I also go by the muscle, again, that's where, as you said,
yes,
your learning comes in. So if it's a broader face, bigger muscle, I may stretch to the 5 points, but I find 3 points works beautifully. And I always call the patient, in masseters, you see the results after 3 to 4 weeks. So I call the patient back if required. I do a top up of another, maybe additional 5-10 units. So I can go up to 60 also at times.
Right. So all of them are telling you that it's okay to call the patient back. You don't have to be a perfectionist in the first go. You can call them back. You can re-inject. You can always tell the patient that I don't want to create a complications. I don't want your muscle to be weakened a lot so that you end up with a complications or a problem. Because Botox, we cannot reverse the effects of Botox. You just have to wait. And how do you tackle it? Sudha, the patient having a complication comes to you. What is your counseling then? Something has gone wrong. What do you do?
So here I think we cannot reverse, because here the botulinum toxin acts for 6 to 8 months in case of masseter. So counseling is what I do.
Have you ever returned the money to the patient?
Sometimes.
Okay. So yes, Amit.
No, this is treatable. This is treatable.
Yeah, no, I'm talking about in general. This you can re-inject.
Yeah.
You can do the smile. You can sort of correct. But then in general, I'm talking about if something happens to the patient. Yes, Madhuri?
I think it's all about reassurance, gritting your teeth as a doctor and learning that this patient is going to every second they call you and make your life miserable, and you have to live that journey of 3-4 months.
Yes.
But it teaches you to be wiser, and at times you are more careful. So I think it's a learning again.
Yeah. So we've been all through with our complications. The more you inject, the more your chances of getting complications, but more your chances of learning how to tackle the complications and how to avoid complications. So don't be afraid to inject. And I'm sure you all will come to this level our advanced injectors are. I thank you very much for being here with us this morning. Thank you.
I would request Dr. Anurag, please join all the panelists on the stage.
Isko switch off kar do.
Can we switch off the lights?
Nahi, main Sajal
I
ko
also
bogla-
invite Dr. Vivek Malhotra to chair the session. Can we switch off the lights?
How to drink water bhi even kar rahe.
One of the dream moment of my life. There are very few moments when you can actually bestow some moments for your teachers. So some people we meet in our life and we continue the way. And there are some people who are not even from as your teachers from your college, but from some other places, from all around. And then you meet them and they give you opportunities and you grow. And the way you grow, you even don't realize that who are the strong pillars behind them. And certainly you see a shadow that is always supporting you. So this session is the most important session of SODC 2021. We announced the Lifetime Achievement Award for SODC 2021. SODC 2021 labels Dr. Rashmi Sarkar as Superwoman of Dermatology. Can we have a huge round of applause? So she has a message for all the young postgraduates.
Rashmi Sarkar has been a special person, and she has been a constant guiding force throughout many of our dermatology careers. And I did my residency from Maulana Azad Medical College, where she was a professor at that time. And she was a pioneering person in resident connect programs. And she was the one who initiated under her tenure secretary or general secretary of IDL. She started the periodic journal by the name of Reciters on the founding editorial board, and I was also one of the guest editors of one of the editions of that journal. Happy memories, all thanks to ma'am. And even after my residence was complete, she helped me get in touch with some of the pioneering names in the field of vitiligo surgery, which is my area of interest and passion. And all thanks to her, I was able to learn from them and also go and observe them, how they do their craft. Dr. Rashmi Sarkar is a great person, great mentor, a person with amazing networking skills and amazing leadership skills. And
I was really impressed by ma'am and her position among various global leaders. That was the time I interacted with her for the first time, yet I have found her to be so approachable, so welcoming. I was really touched, and I have immense respect for ma'am for that. Though I'm not from the same institute as ma'am, yet she has guided me and encouraged me for whenever I approach her for any collaborative work. And not coming from a metropolitan city, it's a boon to learn from her and get amalgamated in the mainstream. She has also inspired me to get involved in national and international organizations to work in. All in all, she's a true leader and a true mentor. Ma'am has that God-given wisdom, patience of the saint, and such a big heart. I sincerely thank ma'am for everything.
I've known Rashmi ma'am since 2015. Despite the fact that that motivated me to apply for business and dermatology. Next year, I was taken as an education. And since then, I've been to speak personally as well as the ability to take people along, and also, of course, the way she balances work and home. So I really wish all the best to you, ma'am. Thank you.
From the very first day of our post-graduation, we were very much surprised to have a consultant as approachable as Rashmi ma'am. She made sure whether it was a personal problem or a professional problem or anything related to academics. She all open hearts and very listening ears and gave us again after post-graduation, though we lost touch for quite some time. But when I reached her for some help, she helped me wholeheartedly and I'm very grateful to her. She has always given me a gentle nudge to achieve my true potential, and I'm really very lucky to have Rashmi ma'am as a mentor and as a guide throughout my post-graduation and even now. Thank you, ma'am.
Humble and down to earth and a loving mother hen to all of us. Even after completing my PG, she's knowledge become a part of the IAD will through Resi and the National Resident Connect Committee. She's just been a shining light for me and my co-PGs throughout our residency and beyond. And I just want to say that we all love you, ma'am, and we care for you.
May I request Dr. Sunil Doga and Dr. Vikram Mahajan to please facilitate ma'am for honors, and I request ma'am to please be on the stage.
I think everything has been said about Dr. Rashmi. I also share a few moments of my past memories, especially when I joined PGI as a resident. She was 1 year senior to me and have a lot of memories of that time. To start with, I must say she had been very helpful for the juniors, especially. And I still remember one of the days when we had dinner at her place in the teachers' flats, and definitely it was cherishable memories. And today I'm very happy, and I think after seeing the long list of her achievements, I think is a role model, should be a role model for all of us. I wish. Thank you.
I request everyone on the stage to please join. So now I would request the superwomen of dermatology to please share a few words.
Good morning, everyone. So I'm truly overwhelmed. In fact, I asked Sahil, I was wondering because I missed the inauguration yesterday that do I have to say a few words? But he said that everything is a surprise. I had asked Sahil. I just want to say one thing. I was very touched to see he had put across, a long list of achievements. But the most important thing, I think, in this journey, my journey hasn't been very smooth, as you can see. I lost my father at a very, we lost him very early in our life. And we lost practically everybody in our family, actually, to some or other unfortunate thing, last being my mother. But, today when I look back through my journey, I don't think that, we were alone because we built many family members along the way. In a very short span, what happens is these days, relationships have a very short shelf life. I think you all agree. Those of us who have children, we all know that friendships are not what they were before. Neither are the relations that you build. But I think along this journey, however sad, however unfortunate at times it was, what was the best part was the people. What makes a difference is whenever we did something, we wrote a paper, we stayed in touch. Whenever there was a student, we stayed in touch. And it's a pleasure to see so many of them, through different stages of life. How did I meet Sahil? I'll give an example. He was introduced by one of the residumites, that was Ishad Agarwal, if you remember Sahil. And he said that this is a guy who's quite bright and he's in PGI. And he was there, It's not somebody I knew or I have taught. So it started from there. The Karwa, as you can say, it starts from there, way back somewhere in 2013 or 2014. And they need not have been students, but what was important is that they all kept in touch. We all kept in touch with each other over the years. Every one of you out here, so many of you I see faces, I met along the way, and we've stayed in touch. Because at the end of the day, I think whenever you climb up the ladder, I've always told people there's only one way, and that is down. On your journey down, what you will have is actually your family and friends. So I think it's very important to keep the inner circle very close, very extremely close, to your heart. Invest in yourself, invest in your family time, but also invest in some kind of hobbies. This is what I'd like to tell the younger people who are there. Yes, it is about private practice. It may be about the loss of some amount of money that may have happened during the COVID times, but you will recover. If you have the skills, you're going to recover. Nobody can take it away. It won't be a quack. It won't be your next door neighbor. It's only going to be you. So I think it's very important. Invest in yourself, invest in good people, keep negative people away. That's one very important thing. Surround yourself with those few positive people. When I have to thank all of you because I'm meeting you face to face. Last year, I won the elections, but more than winning, it was a phenomenal number of votes that were cast. So that shows a lot of participation, whether it was for me or whether it was for the other candidates. Maybe it brought out something in the people that they have to vote. It was a vigorous campaigning. You have to choose your leaders. You are a part, of the future which you're going to build. That is what I would like to tell everybody. Next year in the IITVL is going to be 365 days only. When somebody asks me it is 365 days only, we have to make it something like 750 days. And we can just do it, by working. And if each of you comes forward, does what is the best, we can make it just multiply. With that, I'd like to thank so many people out here. I cannot take names, but yes, there are wonderful people. I see like Sahil, there is Madhuri, whom I met through another different, maybe some other incident. Then there is Sunil Dogra. There is Dr. Vikram Mahajan. There is, I can't remember right now, but I think there's Vivek Malhotra, there is Rohit. There are just many people. I would not fail to, take all their names. But I'd like to say that it is Chandigarh that has given me a lot. I've grown up here. It's the school that has brought out the introvert, made an introvert, speak out in public. Public speaking used to be a dream actually, but you can do it. And the college, PGI Chandigarh, it's not always been the best. And I don't really think I was the best student at that point of time. But I think it's not being the best or right on the top. It is your consistency. I'd like to tell all those people out here who have not got a scholarship or a fellowship, but have been telling me that I haven't got a fellowship. It's not the end of the world. You can do your fellowship any point in your life, whether it is today, whether it is 10 years down the line. You would be able to give something back to the profession. Start from wherever you are comfortable. It's your journey. You may write it at the age of 30. You can begin writing at 40, even at 50. Dr. Sanjeev Molekar, a shining example, says that he started writing his papers at the age of nearly 49 or 50. You can do it, if he can do it. So with those few words, I'm very overwhelmed. Although I'd have seen these pictures, but seeing them today on the screen was a very different experience. Thank you so much, Sahil. Thanks for believing in me. Thanks for all the progress that you've made. And I hope that you keep on, progressing more. Thank you for the audience, for being there with me in this journey. Thank you so much.
Thank you very much, ma'am, and congratulations once again. This brings us to the end of this session, and those who are registered for the hands-on workshop, they are.
Yes, you can continue now.
And those who wish to see the hands-on workshop from here, they are most welcome to stay back and have the experience on the screen.
Come, Shankar.
इसके बाद हमने हैप्पी बर्थडे भी गाना दीजिए
बोलो Just take it from the center a little bit, can you please? Yeah. Vignesh is very low.
So all the candidates who have registered for hands-on can move on to the hands-on stations. Other ones, please keep seated in the hall. There will be live preview of the hands-on, which will be starting soon. So I would request Dr. Vineet Rehan to come on the stage.
So how many do we have? 1, 2,
So Shankar will go with the map. Let's go. That's it. Sorry. Actually, it was more overwhelming. Shankar still had to see pictures and make me look out for my pictures actually. Actually, that it was very impromptu because I asked him. That's the truth. I don't feel happy.
So I would request Dr. Vineet Rehan to please honor Dr. Vivek Malhotra. नहीं नहीं सर ऐसे सर अरे रुक सर एक तो वो तो बाद में ले लेंगे ना
उसके ऊपर डॉक्टर रोहित कंसल लिखा हुआ है इसके ऊपर तो उसके वाले से कितना ये आपका
So I would request Dr. Vineet to please honor Dr. Vineet Rehan. So I would request Dr. Sunil Dogra to please come on stage. I would request Sir to please facilitate Dr. Vivek Malhotra. Now I would request Dr. Vineet Rehan to please. Thank you so much. So we're gonna start the live streaming of the hands-on session soon. Please keep seated on your seats.
चीज ज्यादा खराब लगती है ये तो क्या लगता है कालापन है नहीं, कालापन तो अलग हो गया और कुछ प्रॉब्लम so she's very happy with it. Okay. Sahil, can you hear me?
Yes, sir. Yes, sir. We can hear.
We'll start.
Sure, sir.
Okay, what we are going to do is before we start injecting, we'll discuss with the patient, or rather we'll see the patient, examine what is to be done, and then probably mark out the points and start injecting. So since it's the lower face and the platysma and the perioral area, we are going to talk about basically the chin, as in the mentalis that we discussed in the panel, as well as the DAO, as well as the platysma and the masseter for this patient. Now, thankfully, this patient does not have major concerns. She's quite happy with the face. And what she's really worried about is the pigmentation, which we're not treating here. But when you lift up her face, obviously, there's a kind of a better feel to the patient, right? So let's just mark out, marking pencil, marking pencil. Huh? Okay. Now, let's start with one thing at a time. Mentalis in the patient, how do you make it prominent? You ask the patient to evert the lower lip. Notice there's hardly any activity that you can appreciate in the mentalis. So may not be a good candidate for the mentalis. She has a prominent DAO. So, छोड़ दीजिए. So your DAO, as was discussed earlier, is a kind of a fan-like muscle. This is your fan-like muscle, which is coming up. Okay, so that's your DAO. And then you have this muscle, which is down below, which is basically your DLI. So I'm marking that in a different color. And then you have your mentalis somewhere here in the center. So that's your architecture of the muscle. So DAO, deeper down DLI, deeper down and more medial is the mentalis. Now, in our case, what we plan to do is to do the DAO. So as Dr. Padmavati mentioned, you take the nasolabial fold and you take it down to the mandibular line and inject medial to it a little, but it should be on the border or a centimeter above. I usually inject on the mandibular margin to be on the safer side. And this has to be a superficial injection. You just prick the skin and enter. That's your DAO injection. Moving to the masseters. How do you inject? So you take the angle of the mouth, the oral commissure, you draw a line up to the tragus. Yes, you draw a line up to the tragus. So that's your upper limit. Then you ask the patient to contract the muscle, clench kariye, daant piisiye, kaske. So actually the anterior is all here. Daant piisiye fir se. and the posterior is somewhere here. So that's your anterior border of the masseter, the posterior border. What do you have behind this? Sometimes people have parotid swelling as well. Now, the lower margin would be your mandibular line that you see there. Yeah, but you mark out the mandibular line. We're talking about 1 centimeter above is for the DAO. When we're doing the masseter injections, you actually have to take the first point as the point of maximal impact. फिर से दांत पीसिए कस के. So that's your point of the maximal impact. So I'll inject my first point here. And the second point comes lower down. And the third point comes here. So these are 3 points. I'll just mark it out in the darker color so that all of you can see on the screen. So those are the 3 points that we are injecting. Now, what you have to keep in mind when you're injecting, you should never go anterior to this, the anterior border. You do not go posterior to it, though it's not very unsafe there, but it's definitely unsafe here. If you come here, you'll hit the modulus here. The risorius is the muscle which is very close, and the patient would have a kind of inhibited smile. She'll say, I'm not able to smile properly. So remember to inject in this anterior and the posterior margins that you have. Moving to the platysma, mandibular, yes. The mandibular thing is the inferior border. Now your platysma is a big muscle here. We ask the patient to animate. फिर से E बोलिए कस के. दांत ऐसे. E. It's not very apparent in the case. See, she's got this band happening here. कस के करिए E. E. So you have this band here. Now, in our case, suppose you do not have very too many bands visible, you can actually inject in this band here around 5 odd units, or rather 5 points with 2 units each. And then you can take your DAO point and mark out 5 points inferior to the mandibular margin. You go to the angle of mandible. So those are your 5 points. So this is a kind of a Nefertiti lift that we're doing. So 2, 2, 2, 2, that's 10. Another 2 here, a row of 2s, that's 20. So we do 20 per side. What it does is the platysma is pulling down your jawline, the lower face. So the moment you inject the platysma, there's a lifting effect that you see. And all these muscles of the neck, the perioral, are kind of interdigitating. So if you're injecting your platysma, you should be injecting your DAO because they work in a concert. They are configured in an M-like pattern. So all of them have to be injected. You may leave out the mentalis if the activity is not too much. You can take a call on the masseter depending on the activity of the masseter. In our case, we do the DAO today, we do the masseter and the neck muscles. Okay? So platysmal injections are superficial. These are intradermal shots. The shots here are intradermal. You should have blebs visible there. This has to be deep injection. The apex of the triangle, which you see here, this should be fairly deep. This has to be deeper. This has to be deeper. So this one is probably going to target superficial head and a little bit of the deep. This definitely has to target the deep head. Some people have this masseter which is long, going up to here. Don't try and chase the upper margin there. You may end up with issues there because you have the other muscles working in this plane. You might even hit the zygomaticus at times. So be extra careful there. So these 3 points are safer. Sometimes we use a single point. So this apex of the triangle can be used as a single point injection. Suppose I just want to contour the face, I'll do just 15 units in this single point. Ideally, it should be 15, 5, 5. That's the best configuration. So 25 units per side of the face. Okay? Any other questions? Yeah. Okay, just for a repetition. So we had this platysmal bands, which we noticed. So we marked out the platysmal band. What is important is this is a no-go zone for us. Why? Because you have the sternocleidomastoid happening. Turn around, Esikari. See this? This is your sternocleidomastoid. So when you're injecting here, just be very careful. It has to be superficial. The moment you go down deep, you'll hit the sternocleidomastoid. Will make it prominent. You ask her to clench. Yeah, that as a stretch kari neck kas ke. E boli E. Yeah. See this? That's your band. So you trace down the band all along. Ideal patient is who do not has too much of fat on the neck and you can see the visible bands. Those are easy to inject. In our case, we'll do intradermal shots so that it's easy for us. This is basically around a centimeter below the mandibular bone, the mandibular margin, and it has to start from your DAO point, the posterior to the DA point, and to the angle of the mandible. So if this much area is there, you divide it into 5 equal distant points, 1 centimeter apart, 2 units each. This is all platysma. These points are targeting platysma. That's your masseter that we're targeting, and the DAO. Maximum number of? Okay, so the maximum. Yeah, so this will give you a contouring of the face, a thinning of the face. If somebody has a broad face, especially people from the Northeast, they have those broad faces and very strong masseters, you can give them a good oval contouring. So instead of a square profile, you get an oval profile. No, but a facial artery is down on the bone here. It's at the anterior border of the masseter. It climbs up here. You're not going in that, you're not crossing the anterior border. It is on the anterior side of the masseter. You're hitting this area. Sorry? Parotid duct, yes, if you're going too posterior. The parotid is here with the duct coming in here. So if you're going higher up and more posterior, you're hitting the parotid or the duct. Sometimes you want to hit the parotid. Now, how do you inject the parotid? You would probably inject here. That's your parotid zone. You would inject 1, 2, 3, a row of 3 points here, or you can do a double row. Sometimes we do double rows as well, depending on the parotid enlargement. Just have a look. Sorry? I mean, if it's fairly prominent, the parotid gland is enlarged. Patient sometimes have other issues, like they have bruxism issues, so they tends to stand out as well, the parotid. It's basically for male patients, they have this issue of parotid being very enlarged. So there you can do it. Medical reasons, I'm not sure what reasons would be to do it. No. It's not required that you have to do every time this here. If you see the platysmal bands, just inject the platysmal bands. So this, we are trying to give her the optimal result. See that there's a little jowling happening here. We want to give her a slightly straightish jawline. So that's my prerequisite before I get into fillers. So I'll try and do the Botox, relax the muscles so that there's no muscle activity, and then start working with a filler along the jawline. Okay. So mentalis, if you have to mark out, ask the patient to evert the lower lip. If she can't do that, you to take the central line, which would be in line with the tip of the upper lip. So this is your line. So that's your central line. You can inject either in the center, or you can inject either side of the center. And or as Dr. Padmavati said, you can do 4 points here. Safer to do only 2 points, 1 and 2. This should be just either side of the midline. Yeah, so you have to inject. The mentalis is coming here like this, like this. Point is to go deeper down, almost needle length. Sometimes you do half needle length. The point is it should not go lateral. If you go too lateral to it, then the DLI is there. Here, if you go too medial, the DLI is there. In mentalis, if it go too lateral, the DLI is there. In DAO, it has to be really superficial. In this case, you have to be a little deeper. Okay? Okay, so for the DAO, what we do is, you want to do it that side. So that's your nasolabial fold. You take that as the reference. You inject at the tip of the, or rather where this line meets the mandibular line. So you draw a line straight across where it hits the mandibular margin around a centimeter medial to it. But it has to be as low as possible. Don't try and come up. That's not a good area to inject. Just 1.2 to 3 units on either side. Superficial. Gummy smile, as we discussed in the panel discussion, the point of injection would be in the, sorry? Yeah. So that's your ala of the nose. You have this nasolabial fold, which is there. So you kind of make this triangle go in and inject. So that's your point of injection. I do not do more than 1 unit usually. 1 unit for me is good enough. Sometimes if the gummy smile is too much, I would probably do 2 units. Sort of, yes. So NL1 is deeper down. Up late Joram. NL1 would be probably on the bone. We're talking about hitting the muscle here, right? Don't try and overdo the gummy smile. If you start injecting 3 units, it's not a great idea, I think. You'll invariably have a crooked smile, invariably have a lip drop. It's called the Mona Lisa smile. So the lip really drops and it doesn't look good. If you're, yeah. Smokers lines, if you want to do, the smokers lines are basically barcodes that you see all across. So if you have to target these, you ask the patient to do a whistling sound. Yeah, acid. Yes. CTC. Yeah. So see that, sit up. You see these mountains here. So injection comes in right at the margin of the pink, or rather on the white roll. 1 and 2, 1 and 2. It should be 0.5, 0.5, 0.5, 0.5. So roughly 2 units for the upper lip. फिर से वैसा करिए जैसे बिस्ल करते हैं. If you want to inject here, it is 1 unit here, or rather half a unit here, half a unit here. Just 1 point on the lower lip, either side, 2 points on the upper lip. That's your smoker's line. Okay. Anything else? Sorry. Okay. Marionette lines is basically the DAO that you're injecting. When we talk of marionette lines, we're talking about the fillers later on. Okay. Nasalis is mid-phase, but if you want to discuss, you have to raise your nose. Nose upar uthaiye. Naak aise. This is smell gandi aa rahi hai. Naak utho, naak utho, naak utho. So you basically ask the patient to lift up the nose, the crunch up the nose, and the nasalis is a muscle which is going right across, right? This way. So you target it on the nose. So it has to be on the nose injection. It should not seep down. Why? Exactly. So it should not seep down into the LL sound. If it goes there, it will probably again drop the lip maybe. Right? Yeah. Okay, there's a question as to how should we do the lateral brow lift if you have to do it, though it's a basic indication, but still we'll cover that. If you're doing the crow's feet, ek baar hasiye khul ke hasiye. Okay. So what you can do is you can do your normal crow's feet, which would be this point, which is maximal wrinkling, 1 point down here, 1 point here. You can take this point closer to the tail of the eyebrow. So you can inject here. I normally do, suppose I don't have to do the crow's feet, I do 2 units here and 1 unit a centimeter medial to it, making sure that these two definitely have to be intradermal. I should see the bleb. If I don't see the bleb, I'm in trouble. Okay? So 2 units, 1 unit. So this will kind of give her a lateral flare to the eyebrows. So when you're injecting, you don't inject this way, you inject flat, flush to the surface so that you kind of raise a bleb. I mean, you can trace it down. If you want to lift up the middle of the eyebrow like this, then you can do 2, 2, 1. If you just want a lateral flare, just do 2 and 1. If you want a kind of a lift from the middle portion, then do 2, 2, 1. Again, fraught with danger, it might seep down. You'll have a ptosis. Lid ptosis is a possibility. You can do that, but again, you have to be careful. Like in her case, the under eye bags are fairly prominent. The elasticity, the snap test is not good. So you should be careful. If you're injecting here, you might actually make this a little more prominent. The bags may become suddenly more prominent. That's a pseudo fat pad herniation that you can see in that case. So in her case, no, I would not. I would just stay lateral to the orbital the orbital line, or rather the pupillary line, the mid-pupillary line, and inject very superficially if I have to get rid of these wrinkles that I see here. I'm not going to go too kind of close to the mid-pupillary line in her case. You have to take the mid-pupillary line as a reference, try and stay lateral to it. You can't go medial to it. I mean, the point is you should not be crossing the zygomatic arch, which is coming here. You can't go inferior and hit the zygomaticus. No? So you have to stay as superficial, or rather as superior as possible. Exactly. So you do the orbital part and the tarsal part. That's what you're trying to treat, right? Mostly it is the orbital part that we're trying to treat. एक बार clean कर लो, आप लेट जाओ आराम से. So let's start injecting. How much time do we have? Sahil, can you hear me? So what we'll do is all of you wear your gloves so that each of you gets a chance to inject, okay? Don't inject the DAO, I'll do the DAO for the demonstration. You all can do the platysma injection, those are easier to do. Masseter also some of you can inject, okay? I'll show the masseter on one side and then you can start doing it on the other side. Well, this one. आप लोग very important also to talk about pricing. How do you price the patient? As in how do you kind of tell them the cost for the injections? We have been doing it per unit. I mean, that's been the accepted norm all along. You can also go area wise. Like now these days, we're kind of getting into an SOP of standardizing the upper face. So we just kind of quote a standard figure. Sometimes in the clinic, it's difficult for your practitioners or your assistants when they get their calls to talk about what is the cost like. So you can have a broad figure. Like suppose I have to do the neck, my average is around 30 units. I can take an average of say 300, 350 or 400, whatever you want to charge, give them an average of 10,000 for the neck. You might lose some units, you might gain some units, that's okay. So that balances it out. So if I have to do the masseter, I'll quote a price of 15, ballpark figure. Platysma, it can be 10,000. DAO, it's a simple thing. I can probably, I mean, charging is not an issue here because you're just using around 3-4 units. It's the technique or the skill that you're going to charge for. So you might want to charge 4,000, 5,000 for that area. So we'll redo the marking when you're injecting so that you get a hang of it. I'll do one side of the masseter, I'll do the DAO, and then we can start marking and doing it again. So then you can take the 50 unit vial. So take the 50 unit and you can share between 2 doctors that way if you want. You can have if you don't get the 50, 100, you want to share between 2 people. The question was, how long can you keep it? The company does not recommend more than 24 hours, but we've been using it for ages for 4 weeks, up to 4 weeks. These days, we're cutting down the time. I try and finish it off in the next 24 hours so that I don't get any issues. Yeah, you can. I mean, it's your conversion skills, how you want to talk to the patient or you want to convert. Or you can share it amongst the patient. You can have 2 patients at the same time inject. Sorry? She is actually, if you look at it, yes, you can inject even the mentalis just to drop this. Again, remember when you're doing your fillers, you should be doing your Botox first, or you should be using the toxin first. We don't take Botox because that's the trade name. It's the botulinum toxin that you should be using first before you get into fillers. So if I have to do her chin and the jawline shaping, I'll probably do the injection in the mentalis as well. And then that will also drop it down. It will not kind of give her that kind of a puckery feel that you see. And then I'll work on the platysma and then start injecting with the fillers. Okay. Again, if we'll discuss the fillers later on, but if you have to treat a jawline like this, you should start in the mid face. Pull up the mid face and then you can really work in this area. Okay? That we can discuss in the next session. So let's start. Reconstitution. We have this toxin called Xeomin. It's a German toxin. So it is basically a toxin, and as Dr. Anurag was mentioning, sometimes you see this, the powder is a little clumpy, yeah? I mean, it's here, but if you take the other injections, the other companies, the Allergan, you'll see the kind of rim here. Sometimes it is also on the top. So in Xeomin, you have to really kind of go up and down. With Botox, you have to reconstitute and shake it this way or rather move it this way. With Xeomin, you go up and down so that there's a proper reconstitution. How much should you use? You use 2.5 ml to reconstitute a 100 unit vial. This is 100 units of Xeomin. And how do you calculate now? You got 100 units in this, which is 2.5 ml. So if I take an insulin syringe, which is 1 ml, that would be equal to 100 divided by 2.5, which is 40 units. So each marking on the insulin syringe is equal to 1 unit. So it's a simple maths for you. Again, 100 units with 2.5 ml dilution. So 2.5 ml is equal to 100 units. 1 ml of insulin syringe is equal to 100 divided by 2.5, which is 40. So if you have full insulin syringe, it is 40 units. Markings, thankfully, are of 40. So every unit is every marking. Simple maths. Yeah, you can, if you have to fill up, you'll have 2.5 syringes, but you probably would use less. Again, important point, when you're injecting your toxin, use 1 syringe for 3 pricks, because the needle tends to become blunt and it's painful for the patient. That's very valid when you're doing the glabellar lines. This is probably one of the most painful, sometimes on the neck as well. Yeah, man. 20 minutes. Okay. So let's go quick. Reconstitution. So that's your 2.5. Or go. No. So you take this as your reference. Nasolabial goes straight down. You hit the mandible. Just go half a centimeter medial to it. But you have to stay on the mandibular line. Don't try and come up too much. So this is the fan, beta. Yes, it's lower down on the mandibular. Try and go a little medial, but don't go superior. That is important. Single injection, 2 units on either side. So that's my 2.5 ml normal saline. I go in. I don't try and hit the toxin. I hit the walls so that I do not kind of damage the toxins or denaturate, as it is called, because vigorous movement, vigorous hitting might kind of denaturate it. Go gentle and reconstitute. It goes drop by drop in. I take out the syringe, and that gives me some air in. And then I go up and down to reconstitute it. That's my Xeomin, gently up and down. And then kind of rotate it a little. So that is a clear solution. You should be able to see a clear solution. And as Dr. Anurag was talking in the panel discussion, there should not be any kind of material down below. So you can do a little bit more to get a clear solution again. If you see any sort of contaminants, in the sense you see any particulate matter, please discard the vial. Anytime you see that the vacuum is not good, as it's not sucking in the syringe, please discard the vial. That means the cold chain was not respected. So just important fact there. Okay, so now we are ready. Load karke dena. We'll do the masseters. We have 25, एक syringe 25, एक 25. DA के लिए एक syringe में 4 unit और platisma के लिए 6 के करा. And mentalis 4. What? The results are pretty good, yeah. See, we have all gone through a journey. Earlier we were taught the nasolabial folds, then we went to the cheek, but then we realized lower face agar karna, you have to take care of the platysma. If you don't do the platysma, straight away I do the filler may not be the required improvement. Because you have this particular muscle which is pulling down your face. So ideally you should do your toxin first, followed by the filler. That's the best way to do it. Okay, let's go quickly because we have a limit on the time. Let's inject quickly and finish it off. एक दे दो मेरे को पहले. 2 weeks is the ideal gap. एक gauze दे दो और एक alcohol swab दे दो बेटा. Okay, ऐसे कर लीजिए. वहाँ कैमरा आ रहा है इधर. इधर आना focus बेटा. No, it should be broad enough and strong enough. If you can't feel the masseter, there's no point in doing it बेटा. हाँ, आप एक काम करो, उठ के बैठो, ऐसे turn कर जाओ ज्योति उस साइड, ऐसे उधर की तरफ. हाँ, so it becomes easier for the people sitting in the audience. अब clench करो, दांत. See this? Feel, you all wearing gloves, so feel it. Relax करो ज्योति एक बार. अब clench करो, दांत पीसो. छू बेटा. Okay? चलो. So that's why I said don't chase that. ऐसे करो बेटा मेरी तरफ. You'll have to leave out that. That's a little risky. Clench karo fir se, or you can do a little superficial injection. So that's my anterior border, and that's my posterior border. Okay? I'll ask her to relax. Relax kar lo. I put my thumb there. Relax karo beta. फिर से clench करो, दांत पीसो. आप ऐसे लेट के ऐसे करो, तो easy हो जाएगा. हाँ, अब दांत पीसो, कस के relax करो. Clench, relax करो, ढीला छोड़ो. Relax करो, छोड़ दीजिए. अब दांत पीसिए. So that's my point of maximal ring. अब clench करके रखिएगा, relax नहीं करना. You go in, you inject around 15 units. Okay, that's roughly 15 units while she's clenching. Now what I do is, अब relax कर लीजिए. फिर से clench करिए. आप still raw. I go lower down, clench करिए कस के. अब relax करिए. ढीला छोड़िए, ढीला छोड़िए, ढीला छोड़ो. 5 units there. I've given actually more. फिर से clench करो. छोड़ दीजिए, and you go in. See, this is fairly short needle. So you run the risk of that thing that I showed, the chipmunk faces. There's a possibility that deep head might pop up. That's why you use a 13 mm. This is probably around 6 mm. So you should, I mean, this is a trick to use in practice, or you get hold of a tuberculin syringe and use that. Okay? एक बार DAO के लिए दे दो 4 points, I'll demonstrate, and then everybody can start injecting. So you take the tragus. So anterior border, posterior border, and the superior margin, you stay. The first point is the point of maximal impact of the masseter. The second and the third are just inferior and on either side of the, there's a kind of a triangle that you're forming. So here we have 4 units. आप उठ के बैठ जाओ ज्योति एक बार please. Sorry, आपको तो exercise करा रहे हैं. हाँ, relax करिए, कैमरे की तरफ देखते रहिए बस. Now this is DAO coming in. That's my nasolabial fold. I go down. I enter. See that? Just pricking the skin, and I'm injecting 2 units. Okay? Dard to nahi hua beta? Okay? Now similarly on the other side, that's my nasolabial fold. I go down. I go. So that's my line going down there. I'll inject a little medial to it. Just prick it and come out. Okay? Not going very deep. Just prick. That's not a variation. That's the normal thing. The DLI is medial. I mean, if you have a rare case, you would have a complication. That's a fact. But medial to DAO is the DLI. That's the normal anatomy. Variation would be if the DLI is probably extending right below the DAO, so it might kind of seep down from the DAO into the DLI. Here, if you're injecting in this particular plane, the DLI is further medial to it. If it goes lateral, that's your hard luck. Just prick it, inject 2 units, come out. Simple. Mentalis ke liye beta 4 units de do. So that's what you do it on the mandibular line or just a little above it. See, the point is the muscle is there. If you inject here, this will take care of the muscle. The toxin is fairly good. Remember, I'm injecting 2 units. Even that 2 units, if it goes into the DLI, is going to alter the smile. So understand the potency. Even if you're injecting 2 units here, it's good enough for her. Now, I'll do the mentalis as well for her. So, ek wo swab de do beta, alcohol swab. Fairly risky, yeah. You can't again go very deep. It has to be superficial. Sometimes we use it to evert the lips. Some people have this enrolling of the lips and they don't like it. So you can't only do it with the fillers. You inject along the white roll and the lip kind of opens up from either side. But that's fairly risky. You run the risk of targeting the orbicularis oris and having difficulty in speaking at times. Now we go into the mentalis, midline. Okay, so that's my midline here. I go either side. This would be a little deeper, half needle length is what I usually use. Inject 2 units. And then I go on the other side, another 2 units. So that's I'm injecting on the puckering as you were noticing there. Now, suppose I have to chase this puckering down here. I can at times in the midline do another shot here for her. Okay, so that is also a possibility to really get this strong mentalis going off for some people. In our case, yeah. You do not cross the mental crease. You can use, yeah, that's what she said, no, Dr. Padmavati, that 4 points can be done. If I have to treat really this well, I'll do another 2 units here. But I don't want to do it at one go. I'll do 4 units, call the patient back and see how she comes out. Chalo, start injecting guys up. Or platysma ek mein dikhaya tha. वो दिखा दो मेरे को platysma के 6 units. लेट जाए आप आराम से इस पे. What are the important precautions post procedure? What should you do? So post toxin, the patient does not lie down for 4 hours. Ask them not to stoop. They can go straight down and pick stuff. They should not be exercising on that day or the day after. They should not be doing facials or massages for at least 7 to 10 days. Ask them to be gentle with the face. Though these are small things, sometimes patients are really kind of wrong in the head and they end up rubbing their faces and then you might have complications. Now we'll do the platysma. I'll demonstrate how to do it on one side. Again, marking pencil ek de de beta. No, I'm doing the Nefertiti bit. So, aap relax kar. So this is my point. Remember the DAO I've injected here. I'll go a centimeter below it, and that's my first point. A centimeter apart, I keep on injecting till I reach the angle. So that's my angle is my last point. Okay, ye pakdo beta. So how do I inject? I stretch the muscle. I'm going not this way, but flush. And I enter, just enter and inject 2 units. See the bleb? Again, enter, inject. I mean, the bleb is there, beta. You can see the bleb, na? That should be your thing. It's not a great bleb here, but these 2 are good. So we can do another 2. Ajo, come start injecting. You can do it along with the platysmal bands. If you have platysmal bands, you only do this, you may not get results. So target your platysmal bands first. So then you can do 2 rows of it. That's called a modified Nefertiti. This is a Nefertiti wherein you inject this way and this way. A modified would be just do 2 rows of this. Parallel. So the second row comes a centimeter lower down here. Yeah. Huh? Hey, वो तो masseter है. ना platysma करा लेना. 6 कर दो. The horizontal lines can be injected either side of the ऐसे रखिए. You can inject either side of the lines in a zigzag pattern like this, but does not give very gratifying result. Central area you always avoid because of the esophagus and the trachea, the material seeping down. So intradermal, like what we did just now. Don't go through the marking because otherwise there'll be a tattoo there. Stretch the skin, stretch karo. Go in, bas, prick. No, deep nahi jana beta. Bas prick karo, inject 2 units. We got 6 here. ठीक है? चलो next. Stretch करो बेटा. Lower down. हाँ. Just prick it. Inject 2 units. Good. Perfect. Give it to me. Let's just see the bands. अब आप एक बार जैसे खाना निगलते वैसे निगलो, उठ के बैठो, खाना जैसे निगलते निगलो, कस के ई करो, ई, कस के. See, it's not very apparent again. You can probably see a little band here. So how do I inject? I hold the band here, again prick it and inject my 2 points. There should be a little bit of blebbing, not too much. Okay? Slightly deeper than this. Yeah, slightly deeper, but again, you should prick it. And even if you do the same method, that's not a problem because it's going to seep down into the muscle. 6. Chal. Ask her to say E, make the bands prominent. You can see this, na? So hold karo. Go in. Just below. Prick karo. Bus. Inject 2 units. You have 6 there. Or karo. Perfect. Now, if you have a band, you can just trace down the injections down like this. I mean, you can go up to the pectoralis major also. These days we are injecting the trapezius and the pectoralis major as well.
We should not go beyond the sternocleidomastoid muscle.
No, sternocleido is here, beta.
Yes,
So
sir.
how do you make it prominent? You ask the patient, आप सीधे रहिए मैम, आप उधर face उधर turn करी, एक मिनट मेरे हाथ के against कस की करी. So this is your sternocleidomastoid. ये ऐसे जाएगी ना बेटा, ये.
So 5 points that we are going to do is all the 5 points will be anterior to this bottle, huh?
So the purpose is even if you have to inject on that area, it has to be really superficial, right? चलिए ठीक है. Next. Who wants to do it? एक बार करो prominent करके, कस के. So here you inject here, hold it. यहाँ नहीं बेटा, ये नहीं है, ये इसको पकड़ो, ऊपर. हाँ करो, hold this and inject. Just enter, बस. पूरा नहीं जाओ बेटा, नहीं वापस आओ. Now inject 2 units. करो, डालो. Keep जा रहे बेटा. So it has to be like this. अगर आपको करना है ना, practice it on this area, probably on the other side. ये ऐसे prick किया, and ये that should be a classical bleb. Okay, लेट जाइए. Okay, दूसरी side पे दे दो. 6 करके 2 बना दो. Let's do this pattern here on the other side as well. 3 days, 72 hours, the effect starts. Full effect is around 10 to 14 days. Masseter would take more time. It's around 3 to 4 weeks. This is intradermal, the same way as the bleb that I showed here. It has to be intradermal there as well. 6 और बना दो. चलो. So remember again, आपने ये लिया the nasolabial fold. That's your DAO point. You go a little inferior to it and a little posterior. Start here. 1, 2, 3, 4, 5. You want to mark it? You can mark it. Stretch करो चलो. Here नीचे जाओ. Inject. बस prick करो. Inject 2 units. और करो और perfect. चलो अब तो he's done it ना, तो इसके पीछे आप कर सकते हो. That's not a problem. इसके 1 centimeter पीछे जा सकते हो. करो. It would be difficult to do it here because थोड़ा सा posterior हो गया. Anyways, चलो करो यार, finish it. You should be starting यहाँ पे, but ठीक है चलो कोई नहीं, आप पीछे वाला कर लो. Lower down, perfect. 2 units. ठीक है, perfect. Some people would tell you that you should do it on the jawline. I don't think it's a great idea because the moment I come here, it might diffuse into the other muscle. I have my risk of the DLI, so I don't want to touch that area. The muscle is anyways all across. It is coming up and getting inserted on the mandibular margin. So you can even do it a little lower down. Doesn't make a huge difference. करो, हो गया? और हाँ, prick करके बस inject करो बेटा. ठीक. और दो 6. Who else wants to inject? You want to do the mass? 6. Look. Stretch it. Here. And ये angle है ना बेटा, इसके यहाँ नीचे करो. आगे आ जाओ. हाँ. बस यहाँ prick करो. बस prick करके inject 2 units. और बस. And now let's see if you can make the by E-field से बोलिए कसके. You can't see anything else, right? So anyways, we'll do a second row in that case. So we do a second row. आप कौन करना चाहते हैं? कर लिया आप? You do it. Praveen, just go a little lower down, a centimeter lower down, and try and follow the same pattern. Huh? Oh, okay. Wear your gloves, doc. Wear your gloves, please. 2 units. Perfect. Like somebody else inject further ahead. You've done it? Carlo? Sorry? You can do, you can do two units per shot. You can do a row of 2, or if you want to kind of go conservative, you can do 10 units also. But it depends on the loss here, as in if you see the sag. If you really want to get a good effect, it has to be 15 to 20 units per side, please. Okay? Let's do the master 25 units, and then you're done with this. आपने इसके बाद 4 घंटे लेटना नहीं है, झुक के कोई चीज नहीं उठानी है, और आपने इन मसल्स को एक्सरसाइज करना है, मतलब ऐसे करेंगे, ये ऐसे, ये, और क्लेंच करेंगे, बार बार हर 15-20 मिनट में करेंगे. आपने एक्सरसाइज आज और कल नहीं करना, उधर से जाओ बेटा, एक्सरसाइज नहीं करना है, और कोई फेशियल्स नहीं कराएंगे अभी आप 10 दिन एटलीस्ट, ठीक है? फेस को हल्के हाथ से टच करेंगे, कस के रगड़िएगा नहीं. मार्क इट आउट बेटा, मार्क इट आउट, मार्क इट आउट. So you don't want to get marking pencil there. Every time that you do masseter in the beginning, please mark it out. It's a great idea. Tragus to the oral commission. Straight line, perfect. That's your superior. Mark out the mandibular line. It's very important to understand the anterior and the posterior. Now, ek minute, ruk jao. Daant fir se piso. Perfect. That's the right thing. So first would be relax करिए, relax करो, ढीला छोड़ो इसको, दांत मत पीसो, हाँ, फिर आप clench करो, दांत पीसो, कस के. See this, my hand. So that's my point, first point. Second would be either side, not going very lower down, huh? Yeah. So this is on either side, perfect. So that's my triangle. This is the apex which takes in the maximum number of units, which would be 15. This would take in 5. You can have different permutation and combination. Now, suppose I have somebody who's got a long muscle. I'll change my permutation. I would not make it 15-5-5. I'll make this probably a little more as well. I'll do maybe 20 here and 5 here, because the diffusion is important. I have somebody with a bulk major down here. I'll change the permutation. But average 15-5-5 does the trick for most of the patients. Okay? You can go up to 30 units also in this, but don't overdo the masseter, because sometimes the patient would have really a big flattening and the skin would become loose. So beyond 30, it's a risky proposition again. You can do 4 points. Yeah, that's your call, but so that's what we discussed. You have to use a long needle, or you do it the trick we devised here. Clench करके रखिएगा, relax मत करिए. Clench करिए, go straight in, perpendicular. Push it down a little because you got a short needle. Put in around 15 units. Go straight it down. Or perfect. Stop. Let somebody else inject. आपने नहीं करा, उधर आओ. You've done it. Let her also do it. But 8 point. Chal. So she's injected the apex. Now, isko kaise inject karoge? You'll ask the patient to clench. And then you tell her to relax. And while she's relaxing, you push the thing in so that you're going to target the deeper head. Clench kariye, please, kaske. Go in there. Pura jao pehle andar, pehle pura. Now, dhila chodo beta. Relax karo, Jyoti, chhod do. Push it in. 5 units. Push karo. Perfect. Ab ye do the other point. Who wants to do it? When it's not a great shake, beta, you'll understand. You have to do it, beta. नहीं ये तो कर चुके हैं. DAO we have done it. दांत पीसिए. हाँ ये. नहीं. You go in first. While she's contracting, you go in straight in, perpendicular आओ. ऐसे जाओ. Go in. पूरा जाओ अंदर. अब relax करिए. Push करो अंदर. Perfect. ठीक है? Simple. Important thing in this is to mark your anterior, posterior, and the superior margins. That's it. It's no great shake injecting this. If you can get a tuberculin syringe, use that. It's got a 13 mm thing. It's easier to target this. Okay. Sorry. Rhizoris, you don't do it. What the rhizoris would be anterior to this. Rhizoris is part of the modulus that you have. Then you can just use 13 mm and you can inject half a needle for one of the superficial heads as well. That way. Right, Propose? Thank you. Any questions? Okay, we'll do that. I'll recommend one more thing. When you start practicing, do a hands-on workshop, do a 1-to-1, 3-4 people can get together, do a hands-on workshop. A lot of these companies arrange these workshops, do those. Because I know it's easy that way, but especially when you do fillers, you should at least practice 3-4 patients per, and then you start injecting. Get hold of your own relatives, आसपास जो भी है, inject करो. Use some of the syringes as samples, use them. Because when you get into the lower phase, the advanced Botox or advanced toxin, and the advanced fillers, is fairly tricky. It's not easy. Especially when you start doing the fillers come with a cost, and you have to really use a lot of it. Now, if I have to do her case, I'll do at least 1 ml here. I'll do a half a ml here, half a ml here, 2 ml. I'll do in the post. हो गया खत्म. ठीक है, done. Okay, I'll use another 1 ml here, posterior margin. I might even use it along this area as well. So I'll end up using 4 ml at least. Then this has to be preceded by the mid phase, which is again another 4 ml, 2 ml here, 2 ml here. So imagine the amount of investment that is going on, right? So practice.
We are starting the main session in the big hall. We are starting the main session in the big hall.
Now, our next session is Algorithm for Advanced Dermal Fillers. I call upon the chairpersons, Dr. B.B. Mahajan, Dr. Jasleen Kaur, Dr. Dimple Chopra, and Dr. Tejinder Kaur to come on stage and preside over the session.
We are starting with the session in the main hall. Delegates are requested to please come in for the main sessions. The workshops are closed. Please, the delegates come in for the main session in the big hall.
All the speakers have come? Okay. I think we should call the first speaker. Okay. Okay. Doctor. Very good morning and welcome to all senior dermatologists and my colleagues and dear friends. I, along with my co-chairperson, Dr. Jasleen, head of department from Medical College Amritsar, we are going to start very important session on advanced derm fillers. And in this, the first speaker is Dr. Anju Manthil, who will be deliberating on techniques of injections for jawline treatment. Now I invite Dr. Anju to deliberate and share her personal experiences, how to put the injections for jawline refinement. Dr. Anju, please.
Hello. We all know that a good painting needs to be framed well in order to make it more beautiful. Similarly, I believe the face needs to be framed with a good jawline in order to make it look more prettier and better. Good morning, everyone. I'm Dr. Anju Methan, and I'm going to be talking about jawline contouring. So what makes a great jaw? A good angular symmetrical frame, well-defined contours, proper volume of fat, and healthy supple skin. From time immemorial, the jawline has got its importance. The jawline is best appreciated both in profile as well as in oblique view. We as Indians have different ethnicity and we present with different types of faces. Also, the chin being an important part of jawline is different in different ethnicity. So while injecting, we need to keep this in mind and inject accordingly. As far as the jawline is concerned, the foundation is made with the bone, which is the mandible. The contour is made with the muscle, especially the platysma, masseter, mentalis, and the digastric muscle, and the deep fat pad. The refinement is carried out by the superficial fat pad and the skin. In order to plan a therapy for a good jawline, we can go through multiple methods. As dermatologists, we would opt for non-surgical methods like botulinum toxin, fillers, threads. In case the bony involvement is there and if the jaw is too wide, then we may need to go for surgical options like genioplasty. Many a time in our practice, we come across patients who are worried with a jowl fat pad. So for that, and if it is very, very subtle, then we can probably do injection lipolysis in that area, or we can contour the jawline with the help of the toxin, the fillers, the threads, and also the HIFU. Many a time you'll find a young individual coming into your practice with a very heavy jawline. So that's because of the excessive soft tissue and the fat present over there, which we can also take care with the help of HIFU. The jowl fat part can be taken care with the help of injection lipolysis, threads, as well as fillers. And the other option is HIFU, or the surgical option like a liposuction or a facelift would help as far as jawline contouring is concerned. Now, coming to the anatomy, the mandible is the most important part of the lower face. It is the largest and the strongest bone in the face. And also the mental protuberance is important because that's what gives the anterior projection of the chin in the lower jaw. The platysmal muscle is another important muscle of the lower face. It is a very thin muscle which extends from the clavicle, goes up to the lower jaw. And you will find that as we age, there's a change in the platysmal tone, and which leads to changes in the appearance of the neck and the cervicofacial contour. The retaining ligament is again important. We have the true retaining ligaments and we have the false retaining ligaments. The mandibular cutaneous ligament is the only true ligament in the lower jaw. It is a ligament which extends from the bone and it gets inserted into the skin. This is of importance because this is the ligament, when it becomes lax, is what leads to the jowls. The other ligaments which are of importance in the lower face is the mesenteric cutaneous ligament as well as the mandibular septum. We all have superficial fat pad on our face. And as we know, as we age, these fat pads basically become lesser and gets displaced from its area. So the prime fat pads, which basically become lesser or is the malar fat pad and as well as the temporal fat pads, especially the lateral temporal fat pads and the lateral malar fat pads, leading to basically the fat pads in the middle malar region becoming more heavier. So the fat pads are of importance. Also, as we age, the mental fat pads is the one which is losing its volume. While injecting, it is very, very important to know the anatomy, especially of the vascular structures. The main important vessel over here is the facial artery, which is a branch of external carotid artery and which moves upwards towards the face. You will find it coming to the face at the anterior border of the masseter. And this is the artery which you need to be most careful about while injecting because you don't want any vascular complications happening. Coming to the aesthetic part of the lower face, an attractive facial shape which is universal in all races is the oval shape. Now, we need to know the angle of beauty as far as the lower face is concerned, which is supposed to be 9 to 12 degrees. So this is an angle. If you draw a vertical line from the angle of the mandible straight upwards and also an oblique line from the angle of the mandible to the lateral part of the cheek, it needs to be around 9 to 12 degrees. A good jawline, how do we know it's a good one? There should be a sharp demarcation between the lower face and the neck, as well as the horizontal and the vertical outline should be connected with a smooth or a sharp curve at the angle of the mandible. There should be a gentle silo just below the jaw into the neck. Also, it should be continuous. Chin forms an important part of the face, and the chin should be oval in shape and resembling to a tapering of the egg. The tapered egg should lie within the oval, and there should be an anterior projection of the chin, as well as an inferior projection. Now, certain things we need to know while injecting to the lower face is basically the projection. Always remember the upper lip should be projecting 2 mm more than the lower lip. Also, if you draw a line from the tip of the nose to the tip of the chin, the lower lip should be around 2 mm away from the line and the upper lip should be about 4 mm away from the line. The male jawline is a little different as compared to the female jawline. It is more square as compared to the female, which is oval, and it appears to be box-like. However, with the recent idolization of the pop culture, feminine faces have also gained popularity, and these guys are basically considered to be less aggressive, and that's why more like a good husband material. Effects of aging on the lower face. As we age, the fat pads basically decrease, and also there is a the central part of the face becomes more heavy. The malar fat pad, the lateral malar fat pad, as well as the lateral temporal fat pad loses its volume. The mid-lateral part is the one which accumulates the fat and becomes more heavy, and leading to the gravitational descent of the face. The jowls in the lower face, when the jowls develop, it makes the lower face look more heavy, and when the firmness of the jawline is lost because of the sagging of the skin, as well as weakening of the retaining ligament, as well as because of the bony resolvement. Platysma plays an important role because that's the muscle which pulls the lower face downwards by depressing the smas and depresses the lower lip. Ultimately, as we age, we will find that the face becomes more square-like. Also, there's blunting of the jawline, and there's an indentation created between the chin and the jawline. This is a scale which can show how the jawline aging occurs. You will look at the sharp jawline initially in the first grade, and gradually if you see this blunting of the jawline which is occurring, and as well as the jowls coming up over there. The chin also undergoes changes over a period of time. Initially, the chin, which is supposed to be like a ball shape and with a clear projection, clear anterior and inferior projection. As we age, you will find that there's a loss of roundness of the chin, and as well as there's a severe retraction of the chin, which is occurring. Now, the injection technique is basically devised by Mauricio, and we have a jawline technique where we have a 5-point injection in the jawline. Now, for the jawline, these are the 5 points. That is the JW1, which is at the mandibular angle. I would like to mention over here the jawline. In my practice, I like to inject with a cannula because I find it much more easier. But however, we can inject with both the needle as well as the cannula. The JW1 is a mandibular angle. Now, the mandibular angle, the site of injection for a male and a female, it differs a little bit. Because the male jawline, you need it more square and more broader, I would directly go and reach up to the supraperiosteal level and inject with the help of a needle, making it look much more wider. As far as the female is concerned, I would rather inject at the posterior border of the mandible rather than at the center, because we don't want a broader face jawline for a female. This is carried out better with a needle. GW2 is basically injecting into the preauricular area, which is carried out very well with a cannula. GW3 is where we inject into the mandibular body. Now, this is the area where you need to be a little careful about because of the presence of the facial artery over there, and it is best carried out with a cannula. GW4 is injecting into the prejowl sulcus, and GW5 is basically injecting into the chin apex. So again, here just showing the danger zones, especially JW3, because of the presence of the facial artery at the anterior border of the masseter. This is how you inject. I'm just going to show a small video of injection of a jawline, courtesy Dr. Viral Desai. Entry point is made with a needle. The cannula used could be either 22 number. I prefer not using a very thin cannula because then it acts like a needle. See the entries made with the help of a cannula, and see how the cannula moves very smoothly. There's no resistance. And if you find a resistance, then you know that you are not in the right plane. Just inject. The injection is carried out in JW4, JW3 in a linear retrograde manner. This is the easiest way to inject as far as the jaw is concerned. You can see the sharpness developing. Just be careful when you go towards the anterior border of the masseter. Now, linear retrograde technique is used for injection, and here the JW1 is being injected directly with the help of cannula itself. Now, coming to the JW1, as I mentioned, for me, it's a little different. We inject directly with a 90-degree angle of the needle and into the mandibular angle. It can be done very well with a needle and with a bolus technique. And the site of injection is basically supraperiosteal. It helps in widening the face. JW1 is again for the female, which is injected at the posterior border of the mandible. Now, GW2 is the preauricular area, which can be injected either with the cannula or with a needle. And it is a fan-shaped technique which we use, and it is done at a subcutaneous level. You have to be careful of the parotid gland here. And what it helps in doing is basically lifts the chin up and reduces the jawline sagginess. Many a time, you might feel that injecting in this area, the face will tend to look broader, but actually it's the vice versa. When you inject in that area, the lifting makes the overall face look much more narrower than broader. GW3 is into the mandibular body, where we can easily inject with the help of a cannula, linear retrograde technique into the subcutaneous layer, and be careful of the facial artery. This improves the definition of the jawline. GW4 is basically injecting into the prejowl sulcus. Again, can be carried out with a needle or with a cannula. It can be a bolus technique or a fan shape. And depending upon how you're injecting with a needle, then supraperiosteal, if cannula, then subcutaneous. It helps in reducing the prominence of prejowl sulcus. This is a video. This is done with the help of a needle. So the injection is carried out directly in the prejowl area at the supraperiosteal region. Injecting at the chin apex, GW5 here. So GW5 is the chin apex, preferably done with a needle, a bolus, supraperiosteal, and it helps in improving the vertical dimension as well as the chin height. Now, I think chin plays a major role as far as the jawline contouring is concerned. It gives a good, sharper jawline, and we use the 6-point chin reshaping technique, and these are the points for it. The C1 is basically injecting into the mental crease. It also improves the length of the chin, and this is carried out with the help of a cannula. Initially, we used to just give a bolus around that area with a linear retrograde technique. Nowadays, we prefer to fan it with a cannula. C2 is basically injecting at this chin apex. It increases the vertical length of the chin. C3 is basically to improve the anterior projection into the anterior part of the chin. C4 is submental region, again for increasing the anterior projection as well as the length. C5 is injected mainly into the males to make the chin more broader into the lateral part of the chin. And C6 is injecting directly into the prejowl sulcus. So here we have to be careful about the mental artery, which is coming from the mental foramen, especially when we are injecting into the C3 area. This is the way we inject. So just running through mental crease with the help of a cannula, fanning technique, increases the chin length. C2 is basically injecting the vertical dimension of the chin, supraperiosteal delivery with a needle, a bolus technique. C3 is anterior chin, basically improving the projection, anterior projection. Be careful of the mental artery over here. C4 is basically into the submental region, inject bolus. C5 is basically done more in males to make the chin more broader. And C6 is injected in the prejowl sulcus. So this is how you inject. Nowadays, recent trend has come up of the 7-point shape of the jawline. This is involvement of the midface along with involvement of the lower face. The areas which we are injecting over here is CK1, which is a midface point, CK4, which is at this just below above the parotid region, and C1, which is to improve the chin, and C2 area to improve the vertical dimension of the thing, and the jowls area. That is, and the jaw basically, which is the JW1, JW4, and JW5. As far as males is concerned, you add 2 more points to it, which is JW2 and C5 to make the chin look much more broader. So this is how we go around injecting into the lower face. And thank you.
Thank you very much, Dr. Anju, for sharing your clinical experiences of shaping and reshaping the jawline. I think that is the most important landmark on the face. And I thank you very much once again. Now I call the...
Okay, our next speaker is Dr. Amit Luthra, and he'll be talking on fillers for forehead, temples, and nose, which are considered difficult areas for injection, and he would be enlightening us on how to be safe in these areas.
Good morning, everybody. While he gets the laptop going, it's a great conference. Thank you, Madhuri, and thank you, Sahil, for inviting me here. What I'll be talking about are 3 areas, which would be the temples, the forehead, and the nose. Fairly complicated areas in the sense that you have more complications happening in this area than probably other areas as compared. Nose is one single area which leads to a lot of vascular complications and cases of blindness. Then you have the nasolabial fold, the temples, and even the forehead. So fairly risky. These are meant for advanced injectors. So I would recommend, as Anju mentioned, start using a cannula for these areas. It's safer. Needle can be a little tricky at times. This would be a short presentation. I'll just give you some salient features, not too much into the anatomy aspect of it, but basic injection techniques of these 3 areas. Okay, perfect. Okay, so we'll start with fillers for the forehead, temples, and nose. Why should we be treating the temples in the first place? The question arises. We started with the mid-face. There was a certain shift from nasolabial folds to mid-face somewhere around 5 years back. And we started getting patients like these who were full on the mid-face. But if you notice, relatively the forehead and the temples look as if there's a hollow. So this was a typical peanut face, as you would call it. Ladies full on the cheeks, but nothing in the temples, and the lower jaw wasn't very great. So in order to avoid that, we started doing corrective temple injections, which was basically to kind of blunt the effect of this. So this should not stand out. We don't dissolve this, but it looks as if it's become less obvious and more symmetric. So these were corrective temple injections, and that's how everybody started injecting into the temples. Now, we've talked about the anatomy. Anju has mentioned about the fat compartments. You have to realize that the fat compartments on the face are aging at different times. There's a sharing between adjacent fat compartments. And you have the deep fat compartments which tend to atrophy with age, and that's why there is a hollow. And there is a clinical trend. There have been papers which mentioned that the periorbital and the malar fat pads are the first one to go. And then you have the temple fat pad which is going. Ironically, when you gain weight, and a lot of us experience this, it affects all compartments equally. And that's why when you've noticed yourself also, when you gain weight, you suddenly become ballooned and full moon-like, because all the compartments start gaining weight equally. So just to revise, this is the infraorbital fat pad and the supraorbital. This is the malar fat pad, and this is the temporal, buccotemporal as we call it. So you start aging in this area, the eye area, then your malar area goes, and then the temple goes. So the normal sequence follows that you should be treating your midface first, then come into the temples, then go down to the jawline. So that should be your normal sequence to follow when you're doing your fillers. Now, how do we do it right, and that too with minimal risk? And that is very important. You have to know the anatomy of the vessels, understand when you're working in the temples, this is the superficial temporal artery which is coming in. So you're working in this zone. And then you have the supratrochlear and the supraorbital. Remember, there are vascular complications that we are worried about. And as I mentioned, nose probably is the number one along with the glabellar. And then you have the other ones which are coming in. The temporal area is also known to lead to a lot of vascular complications. You might even end up with a case of blindness because there is anastomosis with the supraorbital and the superficial temporal. So you can have those issues as well. When we're talking about injecting in the temples, where should we inject? There are two ways of injecting. One is with a needle, wherein you inject on the bone. This figure that you see here, a coronal transection, this is the bone, that's your skin. Now, if I have to inject the temples with a needle, I'll go straight in perpendicular and hit the bone to get rid of the hollowness. If I have to do a superficial refinement, I'll just inject below the skin with the cannula. Some patients, you have to combine the two techniques. So you go with the needle on the bone, fill up that area, and then you do a superficial refinement with a thinner material. You use a volumizing material in the temple on the bone and use a thinner material on the top to give a sheet of coverage. Again, going back to the vascular supply, the superficial temporal artery is the most important artery in this area. It comes in anterior to the tragus, a centimeter, goes up, gives off the anterior branch and the posterior branch which goes into the scalp. It is this anterior branch which is bothering us because this is the zone that we are injecting in. So when you're injecting with a needle on the bone, it's always mandatory that you should be aspirating. Aspirate and hold for around 5 seconds. You don't see any blood there, go ahead and inject. So superficial temporal artery, as I mentioned, is the terminal branch of the external carotid artery, and it basically is 1 centimeter anterior to the tragus. And this is a video to show the area which is full of vessels. This is not only the superficial temporal, this is the veins. I'll go back again. Just look at the blood supply there happening. Remember, this is a landmine. If you're injecting in this area, you have to be careful. There are arteries, there are veins as well coming into play. You obviously would end up bruising the patient at times, but more than that, it's the intravascular injections that you have to worry about. This is injection of the temples. How do you inject? You make an entry point. This is with the cannula. So I've made an entry point first by giving anesthesia and going with the needle. And then I'm using a cannula to go into the temple. I find this easier to do in patients who do not have major hollowing. This is a good technique to do superficial refinement, but your material has to be something which is fluid in the sense it cannot give you lumps. If you use a thicker material, at times the patients have lumps in this area. Again, it's a simple technique. Once you practice your cannula injections on the midface, this should be quite easy to inject. You really have to mold the area because at times it becomes, as I mentioned, a little lumpy and there can be nodule formation as well later on. So optimal injections would be fanning in the zone, and I'll show you in the pictorial diagrams later on how to inject. So this is a classical example of how you inject. This is from one of our books wherein we've talked about the temples and the forehead. This is your point. It is called the swift point. If you're using a needle, you mark out your temporal crest, mark out the lateral orbital rim, mark out the zygomatic arch. You go 1 centimeter posterior to the temporal crest and 1 centimeter superior to the lateral orbital rim. Where these two lines intersect is your swift point, as it is called. go onto the bone, aspirate, inject a bolus of around 0.3 to 0.5 ml. This would be a point, as I've shown here, which can be used to get your cannula in and fill it up and do a superficial refinement. So you can mix and match depending on the patient's requirement. So when you're doing the temple with a needle, hyaluronic acid is deposited deep below the temporalis muscle at the level of the periosteum of the bone in the temporal fossa. And this correction lifts up your muscle, fat and soft tissue en masse for an even appearance. You have increased chances of severe side effects. And that's why you can prefer a cannula as well. The filler is placed just below the dermis in the subcutaneous tissue. Imperfections caused by uneven placement will be more visible in this case, and you can have more bruising at the time of the entry point, or rather at the site of the entry point. A classical example of a lady who has this major hollowness here. Now, in her case, I would prefer to use a needle and a cannula both. I've marked out my the supratemporal crest, and this is the way to inject with the cannula, and this is the way to go in with the needle. That's my swift point, and this is the point to kind of fill up with the cannula as well. This is an example of a lady before and after. There's a subtle improvement that you can appreciate in the temple before and after. These are another 4 pictures of patients who were really hollow in the temples before and after. This is again before and slightly more better improvement here that you see after. Point is to not to overdo it. In a lady, you don't want the temples to jut out like a male. It is more of a feminine thing that should be plain. It should not be convex. In a male, you can actually have a little convexity that is okay. Sometimes you have ladies who are exercising a lot and they have this temporalis muscle which projects out. Be careful in those patients, because if you're injecting superficially, it might actually jut out when they contract the temporalis. So in those cases, you definitely need to go on the bone and inject. This is the type of bruising that you can expect if you're using a cannula at times, because this area, you're manipulating it a lot, and there can be issues with this. Risk are bleeding and bruising, infection. There can be unevenness, unsatisfactory results, need for more filler. You can have vascular compromises, including necrosis and blindness. So what happens with blindness? There have been 190 cases reported in the literature. Most common filler has been fat, thankfully. Occlusion of the retinal artery is the key. Filler makes it to this area because of the naturally occurring anastomosis between the external carotid and the internal carotid branches. How do you minimize blindness? Slow injection of the filler, which prevents the retrograde of the flow of the filler. Use a larger size needle and cannula. Cannula is more safe. Constantly move the needle or cannula to avoid bolus at one place, and aspirate prior to injection in case of a needle. What should we do if things go wrong? Suppose you have a retinal artery occlusion. There is a window of 60 to 90 minutes before blindness is irreversible. It is advisable to transfer the patient to an eye specialist. Don't go in for a non-specialist emergency department. You can reduce the intraocular pressure, administer timolol 0.5%, 1 to 2 drops in the affected eye only. And this will basically reduce the intraocular pressure and reduce the aqueous humor production. The patient should be allowed, or rather should be asked, to re-breathe in a paper bag to increase the carbon dioxide levels, which will basically cause the retinal arteries to vasodilate, and this could help dislodge the blockage. Or you can look at massaging the globe to increase repeated increasing pressure so that the ambuli can be dislodged again. Or you can administer hyaluronidase, and this can be administered as per this ACE group guidelines. You can use retrobulbar injections of hyaluronidase, and this is something that has been done, but we are not really comfortable. You should get an ophthalmologist involved in this. Moving on to forehead injections. Again, this is an up-and-coming thing. A lot of people are now asking even for the forehead injections. You have to look at some of the patients from the Northeast who have this kind of a hollowness in the forehead and the temples. They're good candidates. You can use these 6 injection points with a 30-gauge needle, and you have to give 0.1 ml per side. But be careful of your supratrochlear and the supraorbital. The same issues are there as I discussed with the temples. Vascular supply, you have to know your anatomy really well. How do you inject? So if you're injecting with a needle, you go a centimeter to 1.5 centimeter above the eyebrows. You can give linear 6 injections. The angle of the needle should be at 45 degrees, or you can use a cannula in the manner which is depicted here. I find this easier to do and safer. It gives me, doesn't give me nightmares. So that's the way to do it. This is just a video. You mark out your temporal crest as you marked it for the temples. And that's my finger coming in between. The points are a finger breadth at least up. I'm using 5 points in this particular patient. You can use 6 points as well. Injection should always be at 45 degrees. In the video, you'll see the injections going in at 90 degrees. We used to do it earlier, but now recommendation is to do it at 45 degrees with your bevel facing down. Because what they have done in the cadaveric workshop, they've realized if you do it 90 degrees, sometimes the filler tends to travel vertically up along the steel margins of the needle. So this is a technique, an old technique. We're not using it again. Aspiration is important. You see me not aspirating, that's the wrong way to do it. You should be aspirating, because the moment you see blood, you're in trouble, or you miss out, or rather you don't inject in the supratrochlear and the supraorbital areas. If you know your anatomy well, you can probably play safe that way. You leave little boluses there, and then you got to really massage it well, because leaving those boluses would not be a great idea. So the important part comes in after the injection. Now you really have to massage the boluses really well, so that it doesn't kind of show too much. You don't use a volumizing filler unless the patient has a major deficit there. You can use something which is more fluid and kind of is easily moldable. And then you can give the patient a uniform forehead, which is better sloping in a female case. Moving on to nose. Now, nose, again, you should know the terminologies. When we do the nose, we're trying to treat the dorsum and the tip of the nose at times. Some ladies have this supra-tip kind of break. They have a hump in the bridge area, and then you have a supra-tip break. So you need to treat both these areas in such cases. Example, a young lady who has this kind of a deviated nose, and if you notice, she has this supra-tip break, and there's a break at the nasal bridge. So she probably requires both these. These are the tip of the nose. Make an entry point with the cannula, go in. The cannula can't go right up to the bridge. So you have to come up to this point, make another opening and go up to the bridge. You can turn the cannula and go down to the columella. This is your columella, which is going down. If you inject in the columella, it lifts up the nose as well. So you get the proper shape by injecting along the dorsum and the ridge and the columella as well. This is the patient before and after. She had this kind of a hooked nose, and she's got a fairly straight nose, and she's quite happy with it. Nose, as I mentioned, where do we inject? You remember that the tip only has cartilage. The bone starts a little posterior to it. So when you're injecting, you're trying to reach the bone with your cannula. So you go deep down and you slide it initially on the cartilage, and then you go on to the bone when you're injecting. Again, important is the arterial supply in the tree, gives off your lateral nasal. And then if you see up here, you have the dorsal nasal. So by mistake, if you're using a needle in this area, this particular bolus can travel in a retrograde manner, go into the supratrochlear, get into the retinal artery, and you have issue of blindness happening there. So be careful on the nose. In patients who've done rhinoplasty, they are risky patients. A virgin nose is always a better option for you. If somebody has done rhinoplasty, please do not touch it. It can alter the structure, alter the anatomy. The vessels can be pushed to one side, and you might end up with a little trouble there. So in conclusion, fillers for the temples and forehead along with the cheeks leads to a more natural result. And that was my premise in the first case. Treating the temples can be a little risky, but the results are worth doing them later on. Cannula is safer than a needle, but needle is more site specific. So if you have to inject on the bone, you'll use a needle. And nose should ideally be treated with a cannula. Don't hit above your weight. Don't try and kind of be very adventurous. Don't say that I only use needles, I don't want to use cannulas. Please use your cannula, and that's going to save you from all the hassles later on. Thank you very much. And I invite you to the next conference, which is in Hyderabad. This is DISCD. It's called Dialogues in Clinical Dermatology, and the theme is Innovations in Dermatology. Welcome all of you. Thank you very much.
Thank you, Dr. Luthra, for your enlightening presentation.
And now it's my pleasure to invite Dr. Preeti Shenoy for her talk on skin boosters and biomodulators. Dr. Preeti, please.
Good afternoon, everyone. Thank you, Dr. Madhuri, Dr. Sahil, for inviting me here. I think you'll have put up a great, spectacular show, and it's been a great academic fest. So after an in-depth discussion on fillers for the temples and lower face. My topic for today is skin boosters and biomodulators. We all agree that there's been such a great social media hype and everybody wants to have a natural look and glow without using any makeup and filters. Hence, it's important to understand skin quality. What does it communicate? It communicates a sense of well-being, fitness and health, and psychological balance and happiness. So what are the indicators of a healthy skin? How it looks, whether it looks vibrant, glowing, natural, how it feels nourished or clean, how it acts, whether it's well-functioning, non-reactive, and how it makes one person feel about itself, whether it's the person feels fit, happy, and healthy. Factors that affect skin quality are age and genetics, individual habits, lifestyle choices, and personal circumstances can confer a positive or a negative effect on skin quality. As clinicians, we assess skin quality under these three main components. We look for color, whether there's any hyperpigmentation or redness, texture, whether there are any acne blemishes and the pore size, and elasticity to check for laxity and firmness. A poorly hydrated skin is characterized by rough, flaky, or scaly surface, and this happens because of low humidity conditions, mainly attributed to reduction in sebum secretion and consequent loss of water from the stratum corneum, which results in loss of elasticity and itching. Skin elasticity consistently declines with age, possibly due to combination of decreased epidermal cell turnover and increased collagen crosslinks. So the factors that can age skin prematurely, reducing the skin quality are sun damage, smoking, and diet. All this while, whatever procedures that we did, like microdermabrasion, peels, mesotherapy, microneedling RF, or PRP, they only addressed the texture-related skin quality concerns and had very minimal effect on hydration or lifting and volumizing. Hence came the need of injectable hyaluronic acid fillers. So we have injectable fillers like for volumizing and lifting, we have skin boosters, and now the new kid is Profilo, which is biomodulators. Can we compare these three? No, we cannot. So fillers are basically for lifting and filling effects. So they fill wrinkles and restore your volume, whereas skin boosters work on deep hydration and improve the quality of skin. Hence, it has an hydrating effect. And biomodulators, that is your Profilo, helps in tissue restoration, biological activation, which I will be discussing in detail in some time. So how do these gels behave? So when you inject fillers for lifting and volumizing, you are injecting in the mid-dermis and periosteum or subcute plane. Your skin boosters, you're injecting in the superficial dermis, whereas Profilo can be injected in the superficial dermis or deep in the subcute also. So let's discuss about skin boosters. What are they? It improves the hydrobalance of our skin by providing a long-lasting, intensified hydration from within and improves brightening. It nourishes and rejuvenates the skin by promoting the production of collagen and elastin and stimulates your own skin's metabolism. We all know that the hyaluronic acid absorbs up to 1,000 times its own weight in water, so it keeps all that moisture under the skin, giving it a natural, smoother and healthier feel. Where can these be placed? We can inject them into face, and we had very limited options to work on neck, décolleté, and hands. So these are very promising. A right selection of patient is important. Look for any roughness, fine lines, dehydrated or smoker's skin. Who can undergo this treatment? Anybody can undergo this treatment. It's suitable, especially patients who are not pregnant or breastfeeding and who want to improve the overall quality and degree of hydration of their skin. It is not intended to fill lines and wrinkles. Instead, it is used to hydrate the skin and promotes the formation of collagen and elastin. And patients get a more dewy and firmer appearance. It's a natural Instagram filter for patients. Types of skin boosters. The first one to enter the Indian market is Restylane Vital. It has an innovative therapy to restore the hydrobalance. It holds water into the skin's dermal layer to increase elasticity, decrease the skin roughness, reduce the fine lines, and lessen skin imperfections. So what's unique? A partially cross-linked hyaluronic acid, and it has a very high concentration of 20 milligram per ml, available as a 1 ml syringe. It has a unique smart click injection system, which allows the injector to deliver 0.01 ml of the product in the area of the skin to be treated. And the protocol is 3 sessions once a month, which lasts for 12 months. But in my practice, I do 2 ml, that is 2 ml of skin boosters in the first sitting. And then after 1 month, I give 1 ml. So I've seen patients getting better result. How do we inject? I'm sorry, my one video is not going to be able to play. So basically, it is deep dermis. You give linear. Okay, so you give multiple linear injections along the mandible. And as I said, there's a smart click system. So every click, you'll get 0.01 ml of the product in each area. So ideally, you need 1 ml for one side of the face and the second syringe for the second side of the face. So 2 ml in one session is good. The second booster is Volite. It has 12 milligram of per ml of cross-linked hyaluronic acid. It has unique cross-link technology, the patented Y-cross technology. And they say that one session can give you a lasting result up to 9 months. How do we inject this? Stretch the skin to increase the tension. Use oblique injections. Inject intradermally, very slowly, microaliquoir, and stop the injection before retreating the needle backwards, or you'll inject too superficially, and that may lead to lumps. So this is one of my patients in whom I did skin booster Vital. I did 2 sessions, 1 month apart. If you see, she's a young lady, around 30 years old, and she just wanted a natural glow and more hydrated look. So if you see the before and after, in the after you see a more of light reflection on her face, and even there's slight improvement in her shadowing on the forehead and around the perioral area. How to reduce the risk of complications? We should know our facial anatomy very well, and a comprehensive medical history needs to be taken for any allergies. Assess the face both in dynamic and resting conditions, and use proper aseptic measures. And the post-care treatment advise patients not to do any steam or sauna for at least 2 weeks, because the intense heat can alter the ingredients of the skin boosters, which is necessary. Even cleanups, facials should be avoided for 2 weeks. Avoid alcohol and exercise for first 24 hours, because that when you exercise, it can clog your pores and that can reduce the action of skin boosters. And even actives like alpha hydroxy acids and retinol creams. Complications are very minimal and they're very temporary. So you may come to synthesis of collagen and elastin, and it also preserves and encourages the viability of adipocytes that affect the quality of adipose tissue. So what's unique about this product? Basically, it has a NICO technology, and there are 2 chains of hyaluronic acids. We have the low molecular weight and high molecular weight, each in a concentration of 32 milligrams. So a total of 64 milligram of HA is seen in a 2 ml syringe. It has a multi-level dynamic remodeling action, because it remodels the extracellular matrix in terms of elasticity, support, and promotes and maintains the viability of keratinocytes in epidermis, fibroblasts in dermis, and adipocytes. Hence, it has not only a hydrating effect, but also a mild firming and lifting effect. So the special characteristic that it differentiates from our other skin boosters are that because it has high concentration of HA, which is 64 milligram, unlike skin boosters, which was 20 and 12, slow release of high and low molecular weight, high stability. So it does not go any degradation with the enzymes, and hence the results last longer. High flowability like your water, so it can go and rest underneath the skin, and hence it helps in firming and lifting. It not only provides hydration, but also helps in firming and lifting. How do we inject? So I told you in skin boosters, we give multiple injections. But whereas in Profilo, it has this specific injection points called as the bioaesthetic points. So there are only 5 points which are given on either side of the face. So in your, the first point is at the zygomatic arch, which is 2 centimeters from the corner of the eye. The second point is the nasal base. So you draw a line connecting the nostril to the tragus, and then you draw a vertical perpendicular line from the pupil. And the intersection of this point is the nasal point. The tragus point is 1 centimeter ahead of the lower border of the tragus. Then you have a chin point, which is 0.4. There you draw a line in the midline of the chin, and you draw a vertical line perpendicular to that horizontal line, and 1.5 centimeter away from the intersection is the chin point. And mandible point is 1 centimeter above the mandible angle. So this will play. So you stretch the skin, you give, just introduce half a bevel tip of the needle, and you can be, even if you're superficial or deep, it doesn't matter here because of the flowability of the product, and you raise a bleb, and 0.2 ml of the product is given in every point. So it's a 2 ml syringe, 1 ml will work on one side of the face and the second ml on the second side. So this is a before after of a patient. It's not my patient. I've got it from the company. This, if you see, she's a ideally profiler. When you're choosing your patients for profiler, you should choose. It's good for people who are above 45, 50 years of age, and people also who do not want to too much volumize or lift their face or contour their face with lifting and volumizing fillers. So this will give good hydration and also have a mild lifting and firming, giving them that natural look. The next, it's an amazing product for the neck. I mean, all this while we saw that we had nothing for neck treatments. Even skin boosters work mainly on hydration. But here, because of the laxity being the main concern in neck, this product works very well. Again, it has unique 10-point technique in the neck. So the first point is your midline between the sternal border and the hyoid bone. The second point is midline between the apex of the Adam's apple and bottom of thyroid cartilage. The third point is midline between the base of the thyroid cartilage and the sternal notch. So everything in the vertical area like this. The fourth point is midline at the apex of the sternal notch. The fifth point is horizontal line with mandibular angle and 0.5 centimeter lateral. 6th point is the middle border of the sternocleidomastoid. 7th point is horizontal line between the apex of Adam's apple. And 8th point is the bottom of thyroid cartilage. So the 9th point, is between the base of the thyroid cartilage, and the 10th point is the sternal notch. So again, this is a before after of a patient. If you see here, the laxity is improved and also it looks quite hydrated. So when we are discussing about so many different products available in the market, it's always confusing to understand which product to use for which patient and what is the indication. You should know the rheology of the product. So when we look for volumizing or lifting, we will look for a high G prime product with good cohesiveness. So we use volumizing fillers. But when we want hydration, so we look for the and low moldability, we look for skin boosters. But if we want flowability, that means we want hydration as well as lifting, then the tan delta flow, which is with Profilo, which is close to your water with being 2, and this is 1.36. It gives you more of lifting, firming, as well as hydration. How do we combine these products with other procedures? So in case if you're doing toxins of the upper face and skin boosters, you can do it in the same sitting. But if you're doing lower face toxins, then I usually do it after a week. Energy-based devices, either you finish an energy-based device like HIFU or radio frequency first, and after maybe 3 weeks or 4 weeks, you can place your skin boosters and Profilo. Though Profilo, they say that you can do the HIFU and the Profilo on the same day, but after HIFU, you give cool pack for half an hour, 1 hour, let the skin cool down, and then you do the Profilo in the same sitting, which I haven't tried yet. And peels, Q-switch lasers, you can place them after 15 days of doing the treatment. So to conclude, overall, it gives skin rejuvenation. It increases the firmness and elasticity of the skin, improves skin complexion and radiance, prevents wrinkles and rejuvenates dull and tired looking skin, improves the tone and elasticity of the wrinkles, and treats all skin types safely. Thank you.
Thank you, Dr. Preeti, for enlightening us with the latest in skin fillers. The session is now closed, and I think I'll ask the event managers to take over. Thank you.
Thank you so much to our kind chairpersons. So we are starting with a hands-on workshop for the advanced fillers. I request the faculty and delegates to move towards the workstations, please. Thank you.
Can you hear me? Okay. Okay. Okay, good afternoon, everybody. We'll be moving on to the hands-on session for advanced fillers. And we have this young patient here, and we'll clean the face and then look at her and then try and examine and try and determine what all is required in her case. It's important to understand when you're doing your advanced fillers, especially for the jawline and the chin, you should do the mid face first for all patients, unless of course a very young patient who's already quite full and tight, right? For an older patient, you should always do your mid face, try and do your toxin for the neck and the perioral area, or the DAO rather, and then you can get into the lower face. That's the optimum way of doing it. But sometimes the budgets come into the pictures and you have to kind of do your minor alterations as well. I would not want to mix the toxin and the filler at the same area or the same site, because sometimes because of the inflammation, the toxin can travel. As it is, it's fairly risky. I would like to split it into two. I might do my lower face toxin and the mid face with fillers at one go, call the patient back after 15 odd days or maybe 20 days, then do the lower face with the fillers. What's your age there? Remember, when you're using your fillers, make sure that the area, it should be an aseptic technique, because with fillers, you always run the risk of infection, run the risk of a biofilm formation. And that can be troublesome. The biofilm can kick in sometime later and might trouble you unless you give major antibiotics for around, say, almost a month. So make sure that you clean it properly, and there should not be any makeup, no creams on the face. Keep on cleaning it again and again if required. With the toxin, there would not be a major issue, but here you'll definitely land up in a troublesome situation. Okay, so we are again kind of cleaning this area. See this? It's always better to do it yourself as well. Now, we'll first examine the patient and try and understand the requirement. Sit up. I didn't catch any Manushri. No? Kuhu. That's easy. Okay, we have this young patient, Kuhu, here. We'll ask her to sit up and face the camera, Kuhu. Okay, so let's look at her face and try and understand the ratios here. Very important that you follow your facial anatomy and the facial ratios. As Dr. Anju mentioned in the beginning, when you're talking about the lower jawline or the chin or the lips, they should be in sync. So you take a pencil and put it here. A pencil, then plain white pencil. So you have to look at the proportion. So put it on the tip or the chin for that matter. And your lower lip should be 4 millimeter behind. If I turn around for the camera, it should be 4 millimeter behind. The upper lip, or rather 2 millimeter, the upper lip should be slightly behind. So that's 4 millimeter. In our case, if you notice, the lower lip is projecting forward, right? And it's quite prominent if you look at the lower lip, right? The ratio between the upper and the lower lip should be 1:1.6. Her ratio probably is 1:2 almost. So she does require a little bit of upper lip just to get the ratios right. You would not want to do too much in the lower lip. You can give her a little bolus here from here so that gives her a little cushion effect and takes away these lines that she has. And then she requires working in this area. So that's her area of work. And then this is the area of work for the lip. That should do the trick. For a youngish patient, you don't overdo the fillers in the lips. Sometimes ladies come and ask for the typical Priyanka Chopra look. That requires a lot of fillers, wherein you have to go a little below the muscle and try and evert the upper lip. Okay, so you can do that, but then you require 2 to 3 syringes to do that. If I have to work with one syringe, I'll probably just use a little bit, 0.1 to 0.2 here, and then concentrate on the upper lip as well. Now moving to the jawline. Her chin, if you look at the sideways position, she's fairly good, except that it's going up a little, so I would want to drop it. So I'll do a little bit in the mental crease. As Dr. Anju again mentioned, that this is your mental crease which you have to inject, or the C1 point which she was saying. So I would be doing this. Look at the chin. It's a little broad. When you have to do chins, you should understand for a lady, it should fall between the ala of the nose, the chin. Okay, and for a male, it should be with the oral commissure. For a male, it should be broader. So she is there, as in she's falling here, but she's slightly broadish and flat. So I would want to give her a little pointy chin compared to what she has now. So build her up in this area. So I'll do my injections on the bone. I'll give her a little anterior projection by coming from down below. I can give her injections on either side of the midline to give her this kind of a look. So those 4 points are good enough. And then she has this droop which is happening. So this is your area, the mentolabial area that you have to work on. And if you really want to stretch the jawline, imagine a loose string. If you stretch it from both the ends, then only it becomes tight. So you need to inject from this side and then you inject from this side so that the jawline really stretches. How do we do that? You can take the angle of the mandible as the entry point. You can inject in this direction. So that's your posterior border of the mandible. So inject in this direction. The injection has to be in this area. So that's your injection area. So you fill it up in this area. So make a line like this. For a lady, there should always be a curve. And you should not inject too much at the angle of the mandible. Otherwise, there'll be squaring of the jaw. For a male patient, this is the ideal point. You inject a bolus of 0.3 to 0.5. For a female, you do not inject too much unless somebody asks for a square look, which is a Texas look as we call it for ladies. You can use this entry point, go in with the cannula. The same entry point can be used and you can go right across here. So you can go as it was shown in the video, a linear thread. Remember, some ladies have this area, the jowl. If you see a jowl, you do not inject into the jowl, you inject pre-jowl and post-jowl. Okay? Now, injecting from this area takes away the risk that you might have at the anterior border of the masseter. Sometimes we use that entry point, but there you have the facial artery. That's why the facial artery being on the bone, you use a subcutaneous injection. Here, there's no risk at the angle of mandible, you go on the bone and inject. If you have to do the chins in the center, there would not be any risk, but either side of the midline, you have the mental artery coming in. That's why we use a cannula in this area. So understand where we are using it. We are using cannula more in those areas where we have the risk. Where we have less of risk, we might as well use a needle to go site-specific injections, right? Okay, so let's start doing it. So in her case, what we propose is to use a volumizing filler in the center. We'll use a kind of a filler which is more stout or more lifting filler, which is the Bolitero Intense. If I have to give a line on the jawline, I'll use Bolitero Intense again. Posteriorly, also, I'll use Bolitero Intense. Okay, so volume, Bolitero volume here, intense here, intense here, intense here. I can use a volumizing Bolitero here as well, but in her case, being young, I do not want to drop it too much. I do not give her volume here. If I inject too much, it tends to swell up a little, and then she puts her tongue from inside, you can actually see the material. Now you have to understand that every area requires a certain amount. If I have to really drop this, it has to be 0.3 to 0.6. I'll do around 0.2, maybe this side, 0.2 this side. I'll show you how to do it. It is a spanning method so that this whole zone gets filled up. It's not a linear thread that we're talking about. This is probably a little linear thread that we're talking about. This is a proper fanning that we do. This is a bolus that we do. These are different techniques that you get comfortable with. Okay? Chalo. First volume de do. And मेरे को वो alcohol swab पिक्चर लिया हुआ मेरे कैमरे से फोन ले भाई चलना पड़ा रुक जा मेरे needle pill. Okay, cool. You need to get a bit. So always a good idea to document whatever you're doing. So try and take pictures, both in the front and then from the sides. Sanitizer first. 27th. Go back. I'll just demonstrate one shot and then you can start injecting. Or rather, I'll demonstrate one each of the needle and the cannula and then you guys can start. Yeah, we'll do it. Alcohol surface. Okay. So you prime the needle before. You get the air out so that the filler is just there. Get the filler off. And can you turn towards me, Kool? Okay, now what we do is you have to mark out your midline. So my midline is always from the upper lip is when I follow. So this is your Cupid's bow, the center of the Cupid's bow. That's your midline. You go straight in. This is, I'm going straight into the chin. I touch the bone. I aspirate and hold. And I see there's no blood in here. And then I go gently, I put my finger down there because I don't want the material traveling too much. Start injecting. How much should I inject? I look at the tissue as well, but a rough guideline is around 0.3 ml that I normally inject per area. See the change that is happening there? Look at the chin. It's getting rounded, right? Sorry? So every time that you change your needle direction, you should aspirate again. So something like that. You could have done this first, the mental crease, and follow this up, but I'm trying to finish off the work of the needle and then get it to the canvas. So that makes my life a little easy. Let's see the patient. How does she look? So what you've got is a little anterior projection that we've done here. Lengthening also, but lengthening would more come with this. So the moment you do this, it will drop the chin for her. And this is fair enough. I can do a little bit more just to make it more kind of towards the center. For a woman, I would want a little more in the center, yeah. Because then the light reflex would come here and it will look better. The moment you have light shining from here, the chin looks very good. So now I do the other point that she mentioned, wherein I go below that point, come here, and I'm going anteriorly up. Now, since I'm working in the subcutaneous plane, I'm trying to aspirate and hold again. And then I inject another 0.2. I don't want to overdo it, so another 0.2 goes in there. Okay, so that's good enough. Again in the midline. I don't want to overdo it, but if I leave it here, the problem is she'll have this chin which will precede her. Everybody would start noticing that she's done something in the chin. Now, chin injections, when you do the boluses of 0.3 or 0.2, it tends to be a little uncomfortable for the patient for 48 hours. So you have to pre-warn them. So you feel a little heavy on that area. And because you're used to nothing, moving that area easily, it might be a little difficult. There is at times a little bit of myomodulation, as in when you inject, the muscles also kind of work around that filler. Okay. So that's your chin. Lift up, sit up, and turn towards me so that you can face the camera. So what has happened is you've got anterior projection. Now we'll go with the cannula and drop this chin down a little. So it opens it up and it becomes a little straightish chin. Come back. You can give me the same thing on the cannula, so we use this 25G cannula. और साथ में xylocaine है ना आपके पास? हाँ वो दे दो, कोई दिक्कत नहीं. हाँ. I don't follow this. Some people do it. Yes, it's your call. Sometimes that will create a false picture also. So sometimes people use softwares and that becomes a little difficult. It becomes unrealistic expectation. Even saline at times when you're doing it, saline has a different consistency, might give you a false pretext. So I don't do it. You can show them before after pictures. It's fairly easy to convince people that. Remember, or the jawline, don't look at only one area. You have to work on the full area. So you have to get rid of the mental crease, do this angle of the mouth, which is going down. Lift it up as well. And I'll show you how to lift up the angle of the mouth as well. We'll get rid of this area and then lift this up as well. So that instead of having a sad face, she looks fresher and a smiley face is what she would have. So, alcohol swab भी देना. You've taken anesthesia earlier for the dental work or something? You've taken, right? Just from your lips inside. Wear your gloves so that one or two of you get an idea with the cannula here, and then you move on. Local इसमें दे दिए. Insurance सेरेमनी में देता ना यार. हाँ, बहुत मोटी है यार. Whatever points that Dr. Anju mentioned are basically by Juvidum. You need not follow those. You can follow your own way. It's just that you have to know the anatomical landmarks where you need to inject. Those are rough guidelines as to how you should be doing. It can vary from patient to patient. You don't have to exactly follow the same pattern. Okay. So remember, when you're working, the budget is a major constraint when you work in the lower phase. Because as I said, we might end up using 4 syringes. It becomes a little difficult for everybody to afford that much. Relax, relax. A white pencil dena mere ko. So I'm giving her a little anesthesia. So that's my midline. I just mark it out for reference sake so that I know I'm right in the midline when I'm injecting or either side. Now, with the cannula, depends on the length of the cannula. If I have a small cannula, my entry point can be here. With a biggish cannula, I can just do one side at one go and do the other side at one go. Kitna bada? 5 mm? Kitna? 5 mm. So we can make one entry point, but then normal human nature says that when you're injecting, you'll inject more in that side than the proximal side, more in the distal. So make sure that you're injecting properly. I want to cut down the entry points. So I'm going either side of the midline. This is roughly in line with the nose. Remember, my landmark for a lady is the ala of the nose. The chin has to be in there. I don't want to go lateral to it. So I'll inject a little anesthesia. Oh, this is just a little bit of anesthesia, okay? Just to numb that area. Now what I do is, I'll just make a little entry point there. So that's my entry point. I rotate my needle. The needle stays in there. I prime my cannula. Needle nikalo. You take it. And I go with the cannula. Now, this can be a little uncomfortable to the patient. Now, see how I work. I'll go straight in. So I'm virtually equidistant from the center. And now I start fanning. So I go up and down, I move. I'm not staying at one place. Okay? And I go up and I go down. I go straight, I go up. So I keep on moving. My purpose is to fill up the whole area, keeping a track that I'm injecting all the areas, or rather the 2 sides properly.
Whenever we're using cannula, we don't trust it.
You should not, I mean, there's no need. It's very unlikely that you can puncture a vessel with a cannula, unless of course you're using it. Yeah, I'm doing the same, yeah, from the same side. That's why I'm withdrawing and seeing. Also on the cannulas, I don't know, this cannula doesn't have it, but sometimes you have cannulas which have markings here at every centimeter. That also helps you. So I'm doing around 0.5 that I had left over. I'm withdrawing and trying to do the right side of the patient more. This is subcute, beta. Yeah, it's very cool. Come and check it out. Where's where your glass, beta? Come. You have some material left, so you'll have to inject it. Go straight, put a fan karke, start injecting. No, hold it like this way. And stretch the skin and do it. Go back and forth, back and forth. Come here, where my friend. Huh? You can take it out and go again. Chalo, go in. Go in, come here where my finger is. Now, keep on fanning, keep on fanning. Go up and down, up, down, up. Yeah, keep on injecting as you're doing this, no? So that you don't leave out a linear thread. It stands out otherwise. You have to fill up this zone. Come here. So then you can always dissolve it. Hyaluronic acid has the advantage that you have hyaluronidase, which you can use to dissolve it. Finish, huh? Hyaluronidase, you can reconstitute and keep it ready. Whenever you're doing your fillers, please have your hyaluronidase ready. It should be there. Don't reconstitute it. Keep it there at least, because you don't want to waste it every time. Huh? Is it painful, too? Okay, perfect. So you keep on going back and forth. You're fanning that area. You're injecting while you're going back and forth. So you're not leaving any linear threads. Don't cross that line. Huh? Remember, this is the line. Otherwise, she'll appear broader. Okay, come on. Okay, let us sit up. Go sit up and see how it looks. Does it look better or not better? On the time. Thank you. Okay, so let's look at her. She's fairly straight. See, you can drop it down further, but you run the risk of the chin suddenly becoming very long. You don't want to overdo it. I think this is good enough. When in time, she'll also end up getting this in another 15 to 20 days. So go slow on it. I think this is good enough. We'll go on to the Bolletero Intense, which should be in this zone. Okay, and then we'll move back into the jawline area. Come. Entry point. I'll do that as well. Intense. With candle. Or make alcohol soap too. Remember, we've just done the chin as of now. We've not done the mentolabia and the jawline. So all of you can get a hand of injecting it. So we clean this area again. Remember, cleaning again and again, because I don't want to get into that infection issues. You can, if you don't want to use anesthesia, you can just make a little entry point and go ahead. But some people are sensitive. I don't want to give pain to the patient too much, so I normally inject anesthesia. Well, xylocaine tha? What did it? So now we make an entry point. Now, where is the point for entry? It is, you take the mentolabial, the oral commissure, see the fold which is coming here. It is roughly almost where we are injecting the DAO point. I give a little anesthesia. That's give a little anesthesia. So I just give a little anesthesia there. And then I make a little entry point there. Now this point in a male can be used to give them the broadening of the chin as well. So you can come and inject here, which would be probably in line with the oral commissure. So I can give for a male injections here as well from this point. Primed. Okay, so now we have Bolletero intense here. It's not volumizing, but the Bolletero intense. So I enter this point and I turn my cannula, I'm going up. So I try and see the cannula that is going up here. My purpose is to inject medial to it. I don't want to go lateral to it. So I'll go and I'm going to do around 0.5 on one side. So I'll do 0.2, 0.2 and roughly 0.1. So we'll go in, see the movement, and I again do the same thing as I was doing earlier. Yeah, it's fanning. I'm going medial, then I'm coming back lateral, moving my cannula, injecting gently. Remember, intense is a stiff material, so you might have the filler flowing out. It takes pressure to really inject. So just be careful when you have your needles or the cannulas. They tend to fly off at times. This is quite stiff. So now my 0.2 has gone in there. I'll come down here. Somebody wants to inject? Come. Good. Yeah, so we've done this bit. Remember, there's a line here and you're working medial to it. So now your injection zone is this, 0.2. 0.2. Go back and forth.
While injecting.
Yeah, just go in first. Come up to this point where my finger is. Bas. Now go back and forth, only moving in this plane. Yeah, in this area rather, not the plane. Just keep on moving here, back and forth, and medial to that mentolabral line. That side. Don't come lateral. Angle of. I'll show you that. I'll show you the other technique. You'll have to go to 0.6. It's pretty tough to inject. You have to apply a little pressure. It's a stiff material, but it gives you a good sharpening of the area, especially the jawline. Bolletero intense is wonderful. This is 0.2 here, 0.2 here, 0.1 bottom. Again, this is subject to the requirement. Sometimes we change it around as well. Somebody has a lot of hang here. I might as well use more as well. Yeah. So you don't over inject. So it's difficult to push. So you're going very slow. You're not injecting very fast. Otherwise, the free flowing materials can flow really fast. So you're going here now. You have to be here. Feel the tip of the needle. When you're using a cannula, your left hand should be touching the tip so that you know what area you're injecting in. Keep on injecting. Okay, perfect. Just fan it. Imagine there's a hollow here. Imagine that and start injecting it in such a way. That's perfect. Come, now somebody else can do it. Come. So you do the bottom bit, 0.1 ml. Okay. Don't touch the cannula. Anytime you're not touching the cannula, the moment you touch the cannula, please clean it or replace it, because then you're introducing infection in that area. Now you have to feel the tip of the cannula. Where is it? Here. So you have to inject now. Imagine this is a line. You have to inject medial. Yeah, this is where your tip is. Perfect. Just keep on injecting in the zone. Go back and forth. I mean, you have to imagine. That's what I'm saying. If you cannula which has that 1 centimeter marks, you can make a rough guess. Either this is around 1 centimeter I've covered, now the bottom 1 centimeter that way. Keep on going back and forth, keep on injecting. Don't leave a bolus, keep on injecting. There's no harm. Even if you end up giving a bolus, you can mold it by going from inside the mouth, and bimanual molding can be done. It is quite stiff. That's why. Okay. Okay. Just hang on for a second. Now what we do is, since this is a material which is fairly stiff, I know I won't give her broadening. What I'm doing now, if you see, is my chin is here. I just want to give her a straight line. So I'm just going in and leaving a linear thread. I want to sharpen her up, really give her a good sharp area. So that's what I'm doing. This is a linear thread. And I inject, and lastly I stop and I come out. So that gives me a good straight line. It will not add volume, but give her a straight jaw. Now we've finished this bit. Now we go to the back area. Chal, ऐसे turn कर जा बेटा. Let's have anesthesia again. We have 0.5. इसको रखना, we'll use it on the other side. So we finished off 1 syringe of volume. We finished off half a syringe of the intense. Now, yeah, please sit up बेटा. आगे front से देखो. Do you see any change? There's no change. Abhi you require a little bit of molding as well. Angles are better. And the shadows will change. If you see she's kind of dark here, this side she'll look better. There'll be a better light reflex. And then last, what we'll do is we'll give her an injection to lift this up so that the angle which is drooping down looks better. Okay? Come back. Sorry? Water. Oh, sure. Water. You okay otherwise? Okay. All of you, please practice your mid-face. Get comfortable with mid-face for 6 months. Do a lot of patients. Then come down to the lower face. That way you'll really kind of be a good injector. Take this one. No, we'll take the intense one. What? This is 1 ml. Beta. All the syringes of fillers are 1 ml. So you see this 0.2, 0.4, 0.6. It means 0.2 ml, 0.4, 0.6. It's only Profilo that comes in a syringe of 2 ml. Okay. So now we go for the posterior. Posterior side. I'll come from the other side. It makes my life a little easy. Turn this side, better. And now I go at the angle of the mandible. That's my angle. I'll give her a little injection there. Sorry. And then I'll go up and do it, then go back to that side and come and do this side. Sorry. Painful, is it?
No, so from the same entry we'll go off as well.
Yeah, we'll turn it around and do it. I'll show you how to do it. So this is anesthesia, so she doesn't feel it. Intense on cannula. 1 ml दे देता ना पूरा. अच्छा चलो ठीक है. कर लेंगे. Needle. ऊपर से नहीं touch करो बेटा. So now what you do is sometimes it can be difficult if you can't see the opening. A good way to do it is to hold it like this and then stretch it. Otherwise, it becomes it's uncomfortable. Hot. Oh. You don't have a fan in you. You want to take this off and take this off. Sahil. Fan अगर है तो fan करा दो. बहुत गर्म है. I know it's pretty hot. Yes? Should we do it while they get it? Yeah, sure. Okay. So that's my entry point. I go in. It's difficult in this area because at times there are adhesions. So I'll have to push my way, but don't be super aggressive. I'm stretching my skin and trying to rotate through the thing. I'll need the needle again. Entry point. Yep. Let me just come that side, please. Okay, so that's the entry point. It can be a little lower down as well. It's your choice. but I want to be on the bone. So or rather, I want to give her a good shape. Now, what I'm trying to do is to fill up this pre-auricular area. How do I do it? I don't want to make her masculine. So my angle would be like a feminine angle. So I'll again go stretch it, go back and forth. Is it uncomfortable? Okay. Now, since it's difficult at times, I have to really kind of change the plane. I encounter resistance, I change my plane, I go superficial. Now, I'll go right up there. So this will create a jawline like this. In this case, it is Bolletero intense. So I want to give a linear thread as well to give her a shape of the jawline. Okay, so see me giving her a linear head, a linear, linear shape to it. And the Bolletero intense is a good idea. This is around 0.2 is what I've injected. Now, I also want to give her an effect of stretch. So I want to fill up now the pre-auricular. This was a straight line, just to give an illusion of a jawline. And I want to fill up this zone for her. So now I go into the pre-auricular area, and I'm trying to again negotiate because there are obstructions in between. See the adhesions that I'm trying to make? Sometimes you have patients who have acne scars, you might as well do a little subcision and go through. You can hear that cut sound. So now I'm not going right up. I'm just filling up this pre-auricular area. I do a little fan here. Now, remember the filling here is not right up to the end. It's not a distal filling. You're just trying to fill up this zone. It is like this plus this. So that's the particular jawline which we drew earlier. So I'm just trying to fill up that area. And I've done already around 0.3 is what I have done. And then I come out, and then I go from the other side now to the jawline. Needle fits a little bit. You okay? No, doesn't stay that. Okay, so now look at this. She's got a little jawline happening, right? I would inject at the JW1 point that she mentioned, which is the angle of the mandible, because if I inject, she'll look masculine, right? So I'm just, since I have anesthesia there, I'll just make a little point the other side now. Okay. And now this 0.2 goes into the jawline. I might require a little more. The only problem that I face with this point is I end up touching the ear with my cannula, which I don't want. That's why I prefer to use a point which is further ahead. Okay, but in her case, we don't want to do multiple points. So see this cannula going in? Okay, it's almost subacute. It is actually subacute, and we are following the mandibular border, or rather the inferior margin that you have. See this? So we're just trying to get that shape going. Again, a linear thread injection. So I keep on pushing and withdraw, constant pressure, and I'm coming out. Constant pressure, and I'm coming out. Putting my left finger there so it doesn't travel too much down. And I end when I come out. So that's that. So we finish this. So this was around 0.5 that we injected here. Okay, so 0.5 here, 0.5 here. This was 1 ml that we used polymer. Now we'll use another syringe that side. So we're doing as of now 3 ml for her. Sit up. So I don't know if you can appreciate, there's a sharper jawline, and then it gives you an illusion. So this basically with time will stretch further. When this pre-auricular area stretches it, she'll look better. Okay? So we do the same thing on the other side. Who wants to do it now? Come. Huh? Intense. So mentolabial, we have to do this side. No? So start. Anesthesia deke, you start. So we make an anesthesia here at the entry point. We make a needle entry, and then we use a cannula. We do 0.2, 0.2, and 0.1. because we already have that. We have the volumer lying with us. लास्ट हमने क्या यूज किया था? वॉल्यूमर यूज किया था। हाँ तो वॉल्यूमर था ना। इसमें तो इंटेंस कर रहा है 0.5 मेंटल लेवल इंटेंस करें। स्वैप चाहिए, स्वैप दे दो, अल्कोहल स्वैप। इंटेंस बस ठीक है बहुत। Here, needle entry point. Make the entry point and leave the needle there. So you can use the same point that you've used for the infiltration or the anesthesia. So when you make your tunnel, you're making a tunnel, just rotate it so it becomes a little easy. Press it. Now try and enter. This is the tricky part when you've not used a cannula. It could be a little tough. Stretch the skin or hold it, pinch it like she's doing. Either way, it is okay. So stretch it now. Stretch it and it'll be easy. Yes. Okay? First. That's the way to do it. Now go in. Perfect. Now you go along this outer limit that we have, which is the mentolabral fold, and then you inject medial to it. And keep your left index near the tip so that you feel where you're injecting.
Yeah.
You don't inject here, you have to inject medial to it. So you stretch it and go a little medial. Yeah. 10 minutes. Or आगे जाओ ना. Go right up to this way. Yeah, now you've reached. Perfect. Now go and fan medially. Don't come this side. Go back and forth and inject. Keep on fanning the areas. You have to cover that full zone. This is intense. Yeah. Is it? Come here. We do 0.2 and we reach 8 तक पहुंच गए कहाँ तक पहुंचे करो keep on doing it. No, you're not injecting. Yes, is आराम से और प्रेशर तो लगाओगे yes ठीक है you have to good have pressure is पे come somebody else come in अच्छा so you know we've done the upper bit, the upper 1/3, now middle 1/3 is where you're going to inject.
Recording stopped.
आज में इंतजाम करके आए मैं दूंगा HDMI इसको बंद कर दो
So hello everyone. So we have a sponsored session from InMode. So these are very new technologies.
Recording in progress.
And one of the special sessions, and we have almost discussed from A to Z the technologies, but there are some spectacle things and some beyond understanding. So Dr. Nitin Sethi is one of the known person in North India for the body tightening and those stuff. So I invite Dr. Nitin Sethi on stage.
Thank you, Sahil. Thank you for being here. Although it's a sponsored session, and we are not here to sell you a technology. I think the best way to know about more technologies is to just hear them out and then decide what you really think about them. So I'm going to talk to you about a very interesting device. It's called Morpheus 8. It's a global device, very new to India though, but globally it's a very popular device. It's a device that I think most high-end and exclusive dermatology, cosmetology centers do have Morpheus as part of their armamentarium. Why Morpheus over any other MNRF probably makes sense. And I think that's what we're going to talk about here. And then we'll try and do a small demo session also where we'll just show you how the shots can be fired. There are actually two basic things in this particular technology that we are that I think it's very prudent for us to try and understand. So what really is the RF energy and how does it really work? It's just a part of the spectrum of the radio frequency range, and this frequency range will vary from branch to branch. For in medicine, we are using this range between 100 kilohertz and 6 megahertz. The InMode RF, the device that we are talking about today, has a frequency of about 1 megahertz, right? So what does RF really do? If you're using it at very low energy, it is used for nerve stimulation. So if you're ever going to have an injury in your hand or anywhere and you've gone to a physiotherapist, they're the ones who are doing radio frequency on your hand, right? And trying to give you some energy to stimulate the nerve regeneration to happen in the area, okay? So, but at higher energy is where the thing gets more and more interesting. So what does it do? To be kind of boast for the technology, it's the only energy device which is US FDA approved at the depth that this device can work. So the name Morpheus 8 is called 8 because this is the only MNRF device that can go up to a penetration of 7 mm, and the energy delivered reaches about 8 millimeters. So your indications where you had a tough time getting to the depth of the lesion, for example, a scar, or for example, a cellulite treatment that you were giving to your patients, here's a device which can actually create that effect by treating even deeper structures as well. So where all do we use Morpheus 8? It can be used for, of course, for rejuvenation with fine lines and wrinkles. In our center, we are a center for facial rejuvenation is what we do the most. We're known for Botox and fillers in clinic. So we were looking for a device where we could provide our patients with jawline contouring. We can give them, a lot of these, especially the Punjabi women, are heavier women on the lower face. So you get this faces where there was no contour on the jawline and you were trying very hard with everything else to try and define them. So this is where this device kind of fit in our portfolio, in our practice, in our clinic. So what all can you treat? You can treat the fine lines and wrinkles. You can treat the scars. You can improve the skin tone. Treatment areas, every possible area of the neck of the body is treatable. The face, the neck, and even the body areas are treatable. Cellulite, the biggest challenge that we see, especially again in higher BMI groups, where it is always a challenge, and most often than not, it is a surgical treatment, right? So, and the moment you tell your patient that you have to go take anesthesia and it's a surgery, or she says, oh no, I'm not going to get it done. My husband will never allow any procedure like this for me. So that's the challenge that we were facing with our surgical procedures for treatments like cellulite. And then of course, there is some downtime with any treatment which is of this extent. So here is a treatment with minimal downtime. I wouldn't say there is zero downtime, but as you get to handle this treatment modality well, you are able to control the downtime. And today in our clinic, the downtime is only about 10 to 12 hours for most patients, okay, which is an overnight downtime. So if my client has to go to a party the same night, I don't do a Morpheus on my client. Yes, stretch marks, that's the area that I thought made a lot more sense to me. We had been using fractional CO2 lasers, ablative CO2 lasers. We had been doing PRPs. We had been doing fillers for patients for stretch marks to know much utility, in fact, futility. And, there was a time in my practice when I told my patients, you have to live with those stretch marks. I can't do anything for you. But today I have a device which I offer them. I don't promise them the world, which is very, very important. So of course, realistic expectations is very, very important, especially if you're treating the ALB type of scars, the chronic type of stretch marks, right? There we will assure them at least about a 60% improvement, which is very, very significant for a lot of women. It's the difference between being able to wear a dress, a two-piece dress versus a one-piece dress for most patients, right? And I think that's very, very critical. So just to give you a little bit of overview of what's really happening, it's about the collagen imbalance that does happen as we age, and that needs to be fixed. So quickly talking about how this product really works. So it's a device which is I like to call it fractionated RF and not MNR, the true microneedling RF, because here the needles are coated. Okay, it's a set of titanium needles. You can choose the type of head that you're using for your practice, can vary between 12 and 40 needles. All of them are coated, and only the tip of the needle is bare. Okay, so that means only the energy delivered is delivered from the tip and not from the rest of the device. The rest of the energy then travels to the recipient applicator, which is at the level of the skin of the patient. Okay, and that's how the heating effect happens. So you get heating, which is happening. So that's the kind of heating. Not firing, it's all right. The heating will happen here. This is the area of ablation, the area of coagulation, and the area of non-specific heating surrounding the area. And that's why when you penetrate a 7 mm, your heating happens to a level of about 8 mm. And that's why it's called Morpheus 8. Okay. The bigger advantage, what's the real theory? You selectively damage the tissue and then allow the surrounding normal tissue to heal and treat the area and remodel the collagen in the area, which is what theory is all about. Okay, so thermal energy induces new collagenesis and new elastogenesis, which is what is the explanation of what really is happening here. This in turn leads to improvement in laxity and the lines, the fine lines that your patient has. So not only does it improve the scars in the area, when I treat the abdomen of a woman for stretch marks, it is not only improving the scar, the stretch marks, it's also improving the quality of the skin in the area. It's also tightening the skin to some extent, as a result of which my patient is able to wear that kind of dress that she is actually dying to wear. So, the penetration and the beauty about it is that you can penetrate to different levels. You can go into different levels and then create the energy, create the treatment areas at different levels. And then as a result of healing, there will be some amount of contraction, which will facilitate the improvement in the skin, and contraction will help you improve the lines and the wrinkles. So what are the biological effects of heat? When you heat to about, doesn't point on the screen, but points everywhere else. It's all right. So when you heat on the, when you heat at about 40 to 50 degrees, that's about the subnecrotic temperature. Whenever you go higher than about 50 degrees, you are causing more coagulation to the tissue and you're causing more protein damage. And that is an irreversible damage that you are creating. So this is what the energy or the technology uses. And we are able to deliver heat to about 50 degrees at the end of the RF pulse. Needle diameter is often about 250 microns. And the uncoated tip length is about 0.5 millimeters. So this is what it happens. So when you change energy to different levels, the amount of coagulation will increase and will also result in a bigger downtime. So that was what you do. You do a layered treatment for your patient, as a result of which you create smaller areas of coagulation, smaller areas of damage. So you get a better result and a lower downtime. So the biggest challenge with any MNRF, any device that penetrates the epidermis, is the healing process of the epidermis, or the re-epithelialization time of the puncture wound that you have created. And if you do not let the heat to travel up to the epidermis, this healing is much faster. So quickly, different types of tips are named differently. It's the Morpheus 8 prime body tips. The body tip is about the 40 pin tip. Normally, the normal tip, the facial tips are programmed to penetrate to a depth of only about 4 millimeters, but the body tip can be made to penetrate to up to 7 mm. There is also another tip which is called the resurfacing tip. Now you can use a added resurfacing tip to, now these are the uncoated needles that you will use in your practice. And so this will help you resurface the superficial layers of the skin. So this is the normal interface of the screen that you get to see. You can adjust the tip. These are what you're looking at, and then it lets you choose whether you will use a cycle technology or a fixed technology. Cycle means the needles come out and they go back in, while the fixed technology means the needles will stay out every single time, right? So if you want to make the procedure less painful, you use a cyclical technique, which makes your life much easier for your patients. The different settings that can be done. The body tip can go, the energy levels can be up to 60 degrees centigrade, and you can go at the depth of about 7 millimeters. While the facial tips, the Morpheus 8 and the prime, are up to about 4 millimeters. And you use lower energies to use, but you stack up your puncture wounds, and that helps to create a better effect. So this is all of the same thing, and I'm just going to skip that. A word about the resurfacing tip, although I've already spoken about it. This is the one that will only penetrate into the epidermis and will cause much more superficial healing or rejuvenation to happen in the area by causing more contraction, even in the epidermal treatment. So what you can actually achieve is deeper treatment, deeper to the dermis, and then go and treat the more superficial dermis and the epidermis as well. Just to run through, of course, because it's a procedure which will involve penetration of needles through, you will need some sort of a topical anesthesia. And I found that use of topical prilocaine for about 40 minutes makes a lot more sense in our practice. And that's what we do in the practice. A lot of people globally do use nerve blocks or local anesthesia infiltrated into the area. There's a thought process behind it. They say that if you infiltrate the local anesthesia locally as well, it kind of stretches the fibroseptal network and it will give you a more effective treatment. Makes sense. We have not tried it in our practice, but yes, it does make sense. And that's what a lot of people do. That's why the tumescent or the IV sedation may be used for such treatments as well. So this is what you do. These are the different tips that will work. I'm going to quickly run through a small video. Now, this is the catch in the technology, right? I've been talking all along to you and saying that I can go into different depths and treat the different depths. But that means more and more punctures in the epidermis, and more punctures in the epidermis will mean more downtime, right? So that's why this technology is the most novel thing that, and probably patented to the InMode technologies, is called the burst technology. And what is the burst technology? I hope this video runs, yes. So this is what the burst technology does. Sorry, there's no volume. Can we give volume here? Sorry. नहीं है इसमें, नहीं है इसमें जैक। Yeah. This is to show you that the burst technology can be used at different depths, like depths. So you just have to set the machine to the burst mode and choose the depth that you want to start with. So it'll start at 6 millimeters, 4 millimeters, and 2 millimeters in one single prick. As an advantage of that, you get heated layers at different levels and lesser epidermal damage, which decreases the downtime of your patient. You can do it to up to 4 millimeters also, which means if you're doing your jawline contouring, you can pinch up the tissue, bulk up the tissue, and then do a burst technique for the patient as well, which is what makes sense. And that's how this contraction really helps and makes a lot more sense. So this is a technology which I found is very important, especially for stretch marks. When I want to treat deeper layers and I want to do multiple sessions and multiple passes, it's very time laborious if you have to do every single depth every single time. But if you have the burst mode, the entire procedure, the entire abdomen can be done in less than 5 minutes and you're done and dusted, right? Which makes a lot more sense. So that's why I tell the patients my anesthesia time is 40 minutes, my treatment time is 5 minutes. And that actually is a good selling point as well for me. So just to highlight all the indications of the treatment conditions, for the surgical point of view, as a surgeon, we are combining this technique when we are doing a liposuction for our patients. And we are tightening from within as well with the Embrace RF technology that we use. We can also do epidermal tightening with the Morpheus at the same time and gives very nice results. But for the clinical settings, for the non-surgical settings, it's a wonderful device for our acne scars, for rejuvenation of the skin, for jawline contouring, for treatment of the submental fat area, for the neck laxity that we want to treat. In combination with either a bipolar RF like Forma, makes a lot more sense to us. There are certain safety parameters that you must be aware of. There are certain areas that are marked in blue in this slide, are areas that you try and avoid treating to prevent tissue damage, which makes a lot more sense. This is how you would do it in the jawline. Just pinch and then treat the jawline in the burst mode, which is what I will show you in a demo in about 10 minutes time from now. This is just the video again, just to show you the volume, please. Yeah, it's just the same thing, but he's using the burst technique here. I'm just going to play it again. Small video. And that beep is telling you that the two beeps indicates that two different RF energies have been delivered at two different points in the same prick to the patient, which is actually making life of our patients very much comfortable. It's all about controlling the downtime. I'm just done. Give me just a second. Yes. So downtime is a very interesting thing, and there are a lot of people who would challenge that, and they'd say that with an MNRF, with a product like this, you would have a longer downtime. But in our practice, I think we can learn how to control the downtime. I think I control downtimes to about 10 hours to 12 hours today. Good use of topical application of, say, arnica or a topical steroid if you want to do that, or even our antibiotic ointment combined with an oral steroid for a couple of days is what my treatment protocol is to control my downtime. And I don't think there is a challenge with the downtime. So that's all about it. I think I will just stop here. I quickly run through my before and after. This is how you can improve the nasolabial folds. This is our own patients treated and the improvement in the scars. This is the stretch mark improvement. This is just 2 sessions done for the patient. Facial scars, and you can make them look better. This is after just 1 session done in the clinic. Another gentleman, acne scars, treated with about 3 sessions with Morpheus. And we are repeating sessions. These are not my pictures again. These are global pictures from the company, but you get lovely improvement in the jawline. We are still in the process of getting our own patients' improvements. I would like to see an improvement at 1 year to say that it is doing a wonderful job, but you can see how the neck and all can be made better. The arms, all possible indications. This is a good picture to suggest that skin laxity also can be treated with this particular device, and your patients who want to convert from a single piece dress to a 2-piece dress does make a lot more sense. Thank you very much. blue white color. There's another very interesting technology that I'm going to ask Dr. Asra to come up and present. I think this is more revolutionary. The biggest challenge, I think, is the price. But if Asra can convince me to buy it, I'll buy it.
Good afternoon, everyone. So on the onset, I would like to thank SODC, Team SODC for having me here and Team InMode. So starting with my journey, having me here to present my presentation, and I have a 10-month journey in body sculpting. And it's been a challenge. I have my own learning curve, which I'm here to share with you today. So I was going through a lot of devices and I set on this one when I started my body contouring journey. So tight, trim, and tone, the T3. So Evolve, the ultimate and hands-free, non-invasive thermal body and skin contouring. Multiple technologies on the same platform, saves time, allows to increase treatment time, improve efficacy. Reproducible treatment, addresses multiple problems of body contouring. So the basic science of RF is skin remodeling. Dermal aging due to degradation of collagen via intrinsic and extrinsic elastosis. Goal is to bulk heat collagen to 40 to 43 degrees centigrade to stimulate neocollagenesis, new elastogenesis, and regeneration. So basically, a 35-year-old will have a better fibroceptal network. And as we age, you can see it loosening up. And by 55, you can also see that it's really, really sagging. So what does Evolve do? We are treating multiple layers. We're addressing multiple problems in the same time. We're not just taking care of the fat layer or just taking care of lipolysis. What we're doing here is we're tightening the skin. We're trimming, so the trimming goes deep. We're going around 25 mm deep, and then we're toning the muscle beneath. So basically targets the FSN, blocks heating everything with collagen, elastin production too. The tight, that is the superficial 5 mm depth, mainly tightens the skin, but can affect superficial fat with nothing else, which nothing else actually can. The trim tightens the deeper fat up to 25 mm. And the tone, electricity stimulates a nerve and causes involuntary muscle contractions that help build muscle. So all of these three work synergistically to give us a better fibroceptal network and therefore good results. So coming to trim. This is the deeper one. We are trying to take care of the fat here. So it has 6 hands-free applicators. It's a bipolar, patented bipolar RF technology. It has vacuum, increasing the tissue temperature to stimulate collagen growth, preparing the subcutaneous fat layer to interact. Along with continuously thermal RF, high voltage energy is transmitted selectively, causing irreversible electroporation. So basically the adipose, not just by apoptosis, but by pyroptosis, because of the electroporation, it is selectively, we are destroying the fat cells. The skin becomes tightened and the fat layer becomes thinner. So how does it affect the adipocytes? Heats adipose tissue, increases metabolic rate, controlled thermal injury damages the fat cell. Vacuum improves the lymphatic drainage and increases the penetration depth of RF energy. And that's how it goes so deep. So here is the thermal imaging. You can see uniform heating. The energy is given uniformly inside. And in the last slide there, this one, you can see that even after the treatment has stopped, there is deep penetration of the energy and it is still there even after, it's very deep and it's very uniform. Therefore, uniform results. So we start by 25 degrees and we can go up to 40 degrees. The treatment time is only 10 to 15 minutes per session. We don't want to exceed that. So repeated overheating can cause necrosis. So we don't want to exceed 10 to 15 minutes. So that's a pretty short time. This would be the interface of the machine, where each electrode is controlled separately. And multiple areas can be treated together, like the abdomen, the back, arm, front, back. It works on multiple areas and it targets, you can actually use this on your target areas. 3 to 6 cycles are required, 1 week apart. Each treatment time is around 15 minutes. We go to the other superficial where we're taking care of the skin laxity, we're taking care of the skin tightness, the tight, the name suggests. So it's a non-ablative dermal and subdermal heating through bipolar radiofrequency energy. Epidermal temperature, high and low impedance and contact sensors. Maintaining optimal non-ablative heating temperatures in the dermis. So this is the bipolar technology. Improves the skin texture, production of new collagen, elastin, and ground substance. So everything gets, the smoother the skin, the texture, everything improves. You're not just taking care of the fat, but you're taking care of the person as a whole. The interface, again, multiple areas can be treated together. 3 to 6 treatments, 1 week apart. Each treatment. So like approximately in 1.5 months, 2 months, your patient actually has sustainable results. Post-treatment, here you can see transient erythema, edema. Cooling is not advised, not recommended. Moisturize the area and the patient has to use sunscreens. So you see there's no pain, no residual problems, no marks. The patient is actually very happy. So these are some evolve before and after from the company. 2 treatments, 1 week apart, 35 minutes, energy up to 40. And here you can see the tightness. You can actually see the sheen in the skin compared. It's amazing. We go down to the next tone. So we've come from the tight, the trim, and now we are on to the tone. So it's a non-invasive muscle toning technology, increases muscle strength, and has 4 hands-free applicators. Now again, I'll talk, everything is hands-free. So you actually just adjust the patient, put the probes, and you leave. The patient can call you whenever they need to. So what happens in tone? We're taking care of that. It's by electrical muscle stimulation. Mimics the body nervous system by sending safe, low-frequency electrical pulses from 4 hands-free applicators, causing the muscle to contract and increasing blood circulation. In normal muscular activity, the central and the peripheral nervous systems transmit electrical signals to the muscles, making them contract. EMS uses an external source to achieve the same effect, creating involuntary muscle contractions. So this can help improve, maintain muscle tone without actual physical activity. So you actually have around 280,000 contractions in 30 minutes. So that's like amazing. So many of the world's top athletes still use electrical muscle stimulation to enhance their training. EMS can accelerate fitness performance, build muscle strength, and strength endurance. EMS device is clinically proven, FDA cleared, and safe for weekly use. Again, the intervals, 1 week interval between the sessions, and you can go up to around 6 treatments. It depends on how much you want. I mean, you can just go beyond 6. It depends on your patient again. The interface, each one, you can actually, which one is working. You can use only 2 at a time. You can choose. Transient erythema. So there are no post, tone has nothing to consider. There's usually nothing, but a mild erythema might occur. No, cooling is not recommended and the skin needs to be moisturized. The safety profile of the machine is really nice. you have a handheld button where the patient can always anytime call you, and the machine just switches off in case they feel too hot, or if they have a problem, or if the probes, are moved a little bit. So the benefits: fixed positioning of the applicators, full contact with skin, and controlled application of energy provides consistent and uniform thermal effect over the precise treatment area. Does not depend on user skills. Addressing multiple problems like going through the entire fibroseptal network. Better RF coupling, which results in better energy and heat transfer. Diminished risk of overlapping. Therefore, post-treatment side effects are minimized. Now, the total time taken by Evolve is around 1 to 1.25 hours, because usually we use two technologies. And we're talking about three here: the trim, the tight, and the tone. So when we're talking about three, but at one time, at one session, usually in a particular area, we're using only two technologies, one after the other. Either we're trying to take care of the fat and tighten the skin, or we're trying to tighten the skin and tone the muscle. So it takes around an hour, a little plus. Now, coming to some of my before and after pictures. These are, you can see, this is a 68-year-old female. The cellulite, we could take care of the cellulite. She was so happy with the texture of her skin. She said in the last, 20 years, well, she's never seen herself like that. So this was only after 6 sessions, 1 week apart. We've given this to her in 1.5 months. The same patient, we have minimized a lot of the cellulite. This is a 45-year-old male, 2 inches loss, 2 sessions. You can actually appreciate it in the picture. It was very much appreciable on counting and everything. The basic thing when you're doing body sculpturing is that you have to see that the patient is also happy. They can see the results and you can see the results together. This is 5 sessions, a 63-year-old female. Visible inch loss, tightening of the skin, the muscle is toned. Here in this particular, in the arms and the thighs, we normally don't use the trim. We use only the tightening, the skin tightening, and we take care of the tone, the muscle tone. The same patient. Now you can see here, this is the before and after. You can see the difference. You can it's so visible. Look at this. She had almost lost it. This is 5 sessions, but considering the age, it was an amazing job for her, which was not achievable otherwise. If I take care, if I want to say that other technologies also do this, but this is like purely painless, no type of pain, no after effects, no side effects, nothing threatening. So 2 inch loss after 2 sessions. 2 sessions is like what, 15 days? Now, 5 inch loss after 6 sessions and sustainable loss. Because of Corona, I had a lot of more difficulties. I purchased my machine 10 months back, and then due to the waves of Corona, we had some patients walking in. We did a couple of sessions, and then we had to stop. And then after 2 months, when I picked up the same patients again, when they came back, we started where we left them. That was something that was new and which I did not expect. We were thinking that probably we didn't know how to place the patients again. But when we took the measurements, the results were sustainable. And I think these are my own patients. So I'm actually, you can see the difference here. Now, this is a testimonial. I don't know if I can play this. Yes. I want you to just hear what she has to say, and I'll show her before after. Can we have the volume, please?
Hi, my name is Seet, and I had lost a lot of weight last year, because of which I had gotten a lot of loose skin around my body. After that, I consulted Dr. Azra, and she introduced me to the Evolve technology, and she told me that she's the first one in India who had this technology in her clinic, and the nurses and her guided me through this technology, and they were very patient, and the technology was very helpful, and I could feel my skin get tighter even within the first session. And yeah, it was very helpful with the tightening of the skin, and my texture of the skin was better, and I could even feel like a few inches like smaller around my arms and my waist. So yeah, I would definitely recommend it, and especially with Dr. Azra, she's very sweet and very friendly. So yeah, thanks for having me out.
So that was the testimonial I wanted you to hear. Now, this patient had only 3 sessions. She is just 23 years old. She lost a lot of weight. You heard that. And she was here only like for not even a month. Then she had to, she's right now studying in Canada, so she had to go back. She sent me this testimonial a week ago from there. And we, in 3 sessions, could take care of her bat wing. The doctor said there was nothing else. She doesn't have fat there. So it was only all loose skin. So the only thing that she could do was actually go in for surgery. And she really didn't want a surgery before she was flying out. So we didn't have much time. I had only 3 weeks. In 3 weeks, we could actually reduce some inches of her, and we could reduce the bat wing, and she was really happy about it. And she promised that she'd go back to Canada, and because we have a lot of installations there in Canada with the same machine. So she's probably going to take more sessions. This is the same patient after 3 sessions. So basically, I'm a very happy user. I have seen results. I have taken the machine. The only thing what I had to say was I need to see results to pick up a machine and to understand the technology worked. And more than that, I could see sustainable results. Was very nice for me. Thank you. I think we'll be proceeding to the demos room for the demo.
Hello. Thank you so much, Dr. Asra. So we'll move to Dr. Nitin Sethi for the demo of Morpheus. Can we get the camera on for the workstation 3? So it was a great talk, Dr. Asra. Phenomenal results, very interesting. Thank you for sharing your experience. And, I also have tried this machine. It's quite a powerful machine. I really liked it. We have tried both the body contouring and, even the Morpheus microneedling. Seems quite interesting and powerful. Great contouring results, whatever initial results I've seen. So I'm really looking forward to the demo by Dr. Nitin Sethi. Over to you, Nitin. You can start, Nitin. So, can you hear me, Nitin? Is the mic on for Dr. Nitin Sethi? Somebody can check.
कैमरे वाले को बुला दो.
Yeah.
Is on.
Can you hear me now?
Yes. Hi, can you hear me?
Yes, Nitin.
Perfect. I'm just waiting for the camera guy to be here. Can we get the camera guy here?
Yeah, we can see you well. We can see InMode and Morpheus also out there.
Okay, friends, so I'm going to talk to you about the technology and the device. This is a newer platform, a different one from the one that I use in my practice. On hand? Camera?
Yes, we can see you.
Okay. Can you see the camera as well? No, mic is on.
Yes, we can see the machine too.
Perfect. Machine on है. नहीं on है यार. बोल रहे हैं on.
आप साइड में हो जाएंगे?
Okay, so about the device, this is a standalone Morpheus device. Although the technologies displayed here are all the technologies because the software is here, but these are not compatible with this particular device. If you're using the Embrace per se, then you can have other properties also attached to it. So once you've connected the device, and this is what the Morpheus looks like, a small gun in your hand. It's a beautiful device, a very, very user-friendly device. And the best part is that the software is very, very friendly and very, very accurate in what you do. So what I'm going to do is select fractional. And the moment I select fractional, it takes me to the Morpheus 8 platform. Now, this is what the platform is. I can choose tips, and I'm going to quickly show you all the tips that I have right now. So these are tips packed like this. They come in these packs. These are sterile packs, a single-use tip for a single patient. But you can reuse them either by re-sterilizing them with ETO or cleaning the tips before you use for your patient. So this is a Morpheus. This is a Morpheus 8.
We can't see the tip. Can you zoom out, please?
Which is a 24-pin tip. Then we have a resurfacing tip, which is called Morpheus 8 resurfacing tip. This is the one where the needles are only 1 mm out and they stay out once you've activated the tip. I'm going to show you when I connect them how they fire. This is the standard body tip, which is the Morpheus 840, which is for the body. So I'm going to open up the conventional Morpheus 8, and friend here has been very, very courteous. He's against all odds decided that he's going to try and test what I assured him will be a very, very comfortable shot. So I just remove the cover, and after removing the cover, I just connect my tip, right? It just locks in, very easy to place. And then I select what tip I've connected. So this is a 24 pin tip that I've connected. So I hope you can see
Yes, we can see.
The 24 pin tip. You can choose what depth you will penetrate to. So this can go up to 4 mm. So this is like 4 mm now. This is the maximum depth that is allowed with a 24 mm tip. Okay. You can choose the energy settings. The minimum energy settings here is 5. Okay. You can increase it and you can go up as you go up. You can go up to as much as you want. It goes up to 60, right? That's the maximum, but we're never going to get there. It's going to be more and more painful with more downtime if you're going to use more energy. So what I like to do is use less energy, but do it in multiple layers to make my patient more comfortable with a lesser downtime. So for today, for him, since he's just being very generous to take a few shots from us, I'm going to use a very low energy. So I'm going to just use about 18 joules of energy for him. I'm going to use a cycle mode. I'm going to show you what the difference between a cycle and a fixed mode is. So when I select cycle and I put it on ready mode, and then I fire the device, the needles will come out and they will go back in. I'm going to do that again. Needles come out and go back in. So when I choose a fixed mode, and then I can choose how much depth the energy levels, and I put them in ready, the needles come out and stay there. Needles come out and stay there for multiple rapid firing in the same area. So when I fire in a fixed mode, and if I do 4 mm, it will do a gradual pass, go from 4 mm to 4.2 mm to 4.4 mm. So you can increase the depth in that manner also if you use a fixed mode. We're going to prefer to do a cycle mode for him today, not use the fixed mode. And what I'm going to do is I want to show you the burst technology, which is what I think is the most classical thing with this technology. So I'm going to choose a 40 mm pin, 40 pin piece, although I'm using a 24, and then I can choose 4 here and then go from cycle to a burst mode, right? Because we are doing it on the face, I'm going to use lower energies here. So just stick to about 14 joules of energy here. And
So Nitin, sorry to interrupt. What is the burst mode?
Madhuri, I can't hear you very well, but I think you're talking about the burst mode. So I
Yes.
did show you a video about the burst mode. I'm going to show you what it does, right?
Okay.
So when I'm ready here, and then I fire in the mode, it gives energy in 2 different depths. So it's going to go 4 and 2, and then stop. So if I were to choose more deeper, so for example, if I set this at, so this machine is programmed only to 5 mm, but it can go up to 7. If I choose 5, it does 5, 3, and then 1.
I think that's a very interesting thing because most machines don't. I don't know of any machine which has that
3, and
function.
1. So it's going to fire at multiple levels, 5, 3, and 1. So I'm going to choose 4 because I don't want to trouble him too much. Lower energy, and I'm going to just fire. So this is very easy. It's just a single prick. I'm going to fire in this area, the area of the jowl, which I think I can treat for him with this kind of energy. You ready? It's not going to hurt you much. Okay. Okay. So firing. So pinch, lift, and just do up fire. That's a single pass that I do. I'm going to do another one here. Pinch, lift, and fire. So that's what I'm doing. Pinch, lift, and fire, so that I'm making sure that it doesn't hit the bone or hit the deeper structures in any way and doesn't hurt him much. So did it hurt you? So he's very comfortable. I'm going to do one more because I want to treat the jowl in totality. Do another one up here. And that's about it that I will do for a contouring in this area. If I want to treat this area, I can treat this area, but then I will not use the burst mode. I will come down to a fixed or a cyclical mode, use little more energy, or maybe reduce my depth of penetration, maybe go to 3 mm, and then try to do this area of the jawline, this area of the bulge here. So pinch again, and I can fire. So what is preferable is to do a crisscross treatment in the area. You can turn the head in the direction you like and just fire. Just fire. So that's what you do when you want to treat a particular area. So that's about the device and how we go and execute with the device. It's a very simple device, very user-friendly device. The only consumable is in the form of the head because it's unique to one patient. So it's going to cost you something about 47 to 5,000 rupees per patient is your cost, right? If you're going to use the head every single time, then it's a recurring cost. But normally what we do is PO the heads for our patients and then reuse them whenever it's required.
Thank you so much, Nitin. So just one quick question before you wind up. The cost sounds quite expensive. So what made you choose this machine over any other conventional micro needling available?
Okay, so Madhuri, although the answer for me is very different for what I offer to other people, the advantage with this device is that in most of these devices, you can connect multiple handpieces, right? So like I have an Embrace RF, and with the Embrace, I had the option of connecting my surgical handpieces for a bipolar tightening for my patients, for either the abdomen, for the face. So it was an endeavor to become a holistic clinic for a full face rejuvenation and even the body contouring for our patients. Now, how do I justify cost for a standalone clinic? Of course, it's a little expensive device, but the biggest advantage with the device is the fact that you are able to control precisely the amount of energy that you have delivered to the patient.
everyone else, for giving me opportunity to present today. We'll be talking about microblading. I'll be covering introduction, eyebrow mapping, and technique of eyebrow microblading. So we'll be starting with a simple, very, an example. A patient came to me, she's around 20-year-old lady, young, independent. She was planning to marry and she was suffering from lack of eyebrow since birth. This transformed into lack of confidence in her daily routine. She was on job, but as a teenager, as a youngster, she was always having lack of confidence. So she came to us, and with the help of microblading, we could give her confidence back. You can see her now. She is more confident now, and she is married also. So this is what is the importance of an eyebrow in daily routine actually. Otherwise, normally we don't see it, but when we lack it actually, there is a huge difference in our life. So we should not be underestimating the power of an eyebrow. So to start with microblading is a semi-permanent tool. It's a semi-permanent procedure which is used to create eyebrows. It is used to enhance, reshape, and create natural looking appearance of brows actually. In these, hair-like incisional strokes are created by depositing the pigment by superfine bundle of needles along the natural course of eyebrow hair. So why eyebrow microblading? There are simple statistics which shows the importance of brows actually. There are countless songs which are dedicated to the beauty of eye and eyebrows. Eyebrow pencil is the second highest selling makeup item in the world. The simple statistics shows the importance of a well-defined eyebrow. So eyebrow defines the upper border of your face, and there are very less dermatologists doing this procedure. This is a very fulfilling procedure, as you can see in the last example. Plays a very important role in facial expressions, and lack of awareness is sometimes a huge opportunity. So all of us should, use this opportunity. All of us should do microblading. As you can see, most common issues with eyebrows are thinning of eyebrows. Almost, half of the population of, mankind will have thinning of eyebrows. Lack of eyebrows sometimes rarely can be there. Post-traumatic scarring can be there. Alopecia areata, hypothyroidism. These are different problems with eyebrows actually. The answer to this is eyebrow microblading. And coming to, for that, I'll be covering first eyebrow mapping. So how you need to create an eyebrow. So basically to create an eyebrow, we need to understand different parts of eyebrow. There is head of the eyebrow, then there is body, there is arch, and there is tail actually. Head is the initial, 1/4 of the eyebrow where hair roots are straighter, then it curves in the body. Arch is something where angulation is there, and tail is a last narrower portion of your eyebrow. So there are different shapes of eyebrow, and these shapes will suit different types of face actually. So we have to devise a particular shape of eyebrow according to the face. So I'll tell you, there is an arched eyebrow. There can be a very steeply arched eyebrow, which will suit a different face. Then there can be a rounded eyebrow, and there can be a straighter eyebrow. These are different shapes which will suit, different face types. So many times we may be confused about it. So that time it's very easy, easiest way of, deciding about the face is to ask the patient that what kind of eyebrow you want. Many times patient only tell you that, doc, this is the way it suits me, and probably that would be a better option. So to tell you about which eyebrow matches which type of face actually. So as you can see in the picture, there are oval shape. There can be a face can have a longer face. It can be rounder. So you can see over here rounder face. We have an arch eyebrow, while for a longer looking face we have a straighter or more horizontal eyebrow. What this thing, what is the difference between these two faces actually? You can see the longer face. If we create an arch eyebrow, like in this first picture, if we create a high arch eyebrow, it is looking longer. But if you can create a horizontal eyebrow or more, less angulated eyebrow, the face looks little shorter.
So that way we can help to get the betterment out of the face. Similarly, for a rounder eyebrow, we need a high arched eyebrow so that it should look little elongated. So you can see the same thing over here. Here Madhuri Dixit Nene has little longer face, so she has a horizontal eyebrow. For the same thing with Kareena Kapoor Khan, we have a rounder looking face, so she has an arched eyebrow, so which is giving them a fulfilling shape to their face. So coming to after this, coming to my eyebrow mapping, actually we have 3 horizontal lines and 3 vertical lines. In case of eyebrow mapping, we have to design it for designing the eyebrow. So we generally 3 horizontal lines starts from medial, from the lateral part of the nasa and medial part of the nasa. First line we draw from medial part of the ala of the nose, and it extends upwards and joins the medial canthus of the eye. Then you can see in the picture, second line, it may start from either from lateral nasal ala or medial, depending on the type of face we have, and it passes from the mid pupillary point upwards, and that also marks the highest point of the eyebrow, which can be which also shows the angle of the eyebrow. And third line passes from lateral nasal ala lateral to the canthus. So these you can see point A, B, and C and D, we get it actually from vertical line as well as horizontal line. So horizontal lines are basically, lower line is drawn at the starting point of the brow. We can feel the muscle, basically fat pad over there, which marks the head of the eyebrow basically. That is the first horizontal line, the lowest one I'm talking about. Somehow I'm not able to point. Okay, so basically the middle line starts 3 to 5 mm. Mostly it is around 5 mm above the first line, and it is again horizontal, parallel to the first line. Third line again, similar distance is there. It is equidistant from the first line, and it goes horizontally. So on the conversion of these points, we get point A, B, and C, which can be joined to create an eyebrow shape basically. So here is a video where I am showing you how to mark an eyebrow. This is basically to get the midpoint of the face. It is not necessary, but we should have a rough idea about it. So this is the first line, first vertical line. You can see I'm starting from medial ala upwards. We can have this kind of thread, anyone will have it. Actually, we just have to use brow pencil to blacken it and we can use it. Otherwise, there are different pencils available in the threads also available in the market. So this is the third vertical line extending from lateral. This is second vertical line extending from, in her case, I have taken it from lateral ala. Mid pupillary point is there and upwards, it marks the angle of the eyebrow. Just mark it. These are vertical lines now, and then lateral part of the eye, and this is the first horizontal line at the base of the eyebrow, and the convergent points of this is 3 to 5 mm above it. Actually, both the, you can see both the horizontal lines are 3 to 5 mm above it. Sorry. So you can see these 3 horizontal lines, we get convergent points and we can join them to create a proper shape of the eyebrow. Midline point is also important so that we should know that symmetry is there. So this is how we mark the eyebrow. So do's and don'ts for the eyebrow. It is best to tell patient actually that you do your eyebrow and come with. The patient knows better than most of us which shape suits them because they have been trying it for lifetime. So definitely we should ask patient only which shape suits them. We have to draw midline point first, then vertical lines and then horizontal lines. We can, we can show a rough idea by joining the points to the patient actually how it is looking. So next thing is understanding the, once we have marked it, actually we'll go to the understanding the strokes of the microblading. There are, when we are giving strokes, actually there are main strokes and there are side strokes also. So we generally give strokes at the 45 degrees angle from the emerging point of the skin, so that it gives a natural look to the patient. This feathering is done with main strokes and supporting strokes. Main strokes basically starts from the base and extends towards the border, while supporting strokes are something which starts from midway and extends to the upper part of the eyebrow. It will converge to the main strokes also. We don't have to intersect between the strokes, because if we do that, there is a high chance that we will have a bleeding, and then we can lose the pigment. There can be blotching of pigment. So we have to make sure that all our strokes are parallel to each other. As I said, head strokes, they start from vertically from the base of the eyebrow and extend upwards to the upper border. Substroke starts from base and ends in the middle of the eyebrow. Slanting strokes, these are something which are converging towards the spine of the eyebrows, important body, creating the body of the eyebrow. And tapering strokes, they are superficially angled downwards and very important in creating the tail of the eyebrow. So this is the, you can see over here, if I can use the pointer, you can see the spine of the eyebrow here. If I can, I'm not able to, yeah. Okay, cursor only I'll do. Okay, so good. So you can see this, all these, eyebrows, all these strokes are directed up, vertically upwards. From here, it is stroked, downwards actually. So this basically is the spine of the eyebrow, we can say. And we have to align all our head and body strokes towards it. And from here, we have to align our strokes towards, tail actually. So generally, this middle portion is basically the spine of the eyebrow, you can say. Okay, this middle portion over here extending, this is the spine of the eyebrow. So this is how we do it for the head. The strokes are starting from the base of the eyebrow, extending vertically upwards. This stroke was one vertical stroke, solitary stroke upwards actually. When we're doing it on actual patients, we see a particular correct sound actually, which shows the resistance of the blade actually, and that also marks the deposition of pigment. So we should be able to hear it. Now these are converging strokes. Here we are creating the body. Again, converging strokes. Now we're marking the spine actually, directed downwards. Now, this is just a first pass of the strokes. We can obviously recreate it. We can see this is not a denser pass. A patient also did not have that, patient had good amount of hair, so we did not have to give very high density strokes also. You can so see the strokes are now directed downwards. So this is one pass. The procedure is done under local anesthesia. We can apply local anesthetic cream and then do it. I'm filling in between actually. Post this, we have to apply the pigment over there, keep it there for 10 minutes and the pigment gets absorbed. You can see the strokes are directed downwards. Now the head strokes again. Like that, you can just spread the pigment. It gets absorbed. Yeah. Okay. So while designing the eyebrow, we have to make sure that the head strokes we give it at the last, so that we should not bend with the symmetry of the eyebrows. As I said, 2 to 3 lines we can start inside, and then finally we can just touch up. In touch up, we can give head strokes. Arch designing is the key to good shape, but try to stick to the normal eyebrow design. We can, as I said, you can ask patient which shape suits them. And if patient has big forehead, we have to keep arch a little higher. So these are few pre and post. As I already shown you, this is the lady who lacked eyebrows since birth. And another patient, he was suffering from alopecia universalis basically. He was okay not having hair on the head, but eyebrow was something which was, bothering him in his social interactions. Post, microblading, he was very confident. This is my receptionist. You can see, so it's a good way to, convey patients that eyebrow microblading helps actually. You can see she has got a nicely medially defined eyebrow now post microblading. And another patient, actually we can just densify her eyebrows. Another patient. So thank you so much. Yeah, will be. Monica ma'am. Monica ma'am will be present.
Thank you, Dr. Umesh.
Thank you.
So now I'd like to invite Dr. Monica Bamru for her. So Dr. Monica for her talk.
Good afternoon, everybody. I'm honored to be here and I would like to thank the organizers for having me here. So I'm going to tell you about the instruments we require before we start with microblading. So we've already, we know what microblading is. It redefines, reconstructs and refills our eyebrows. So it's a highly meticulous, skilled process. So what we have to realize is that there is no antidote for microblading. Once you put in the pigment, you can't reverse it. And even if you want to reverse it, it's very difficult because you'll have to do Q-switch laser on the eyebrows. So before we actually go on to the patient, we must do a lot of microblading on the artificial skin. So once we are thorough with it, once we are ourselves happy with our results on the artificial skin, then we should go ahead and do it on the patients. So what we require? So microblading is done with the, first we require microblading scale. We require a flexible microblading scale because we have a arched or a contoured forehead. So you need something which is flexible. You need a marking pen to make the drawings. You need a topical anesthetic cream to numb the area. Then we need the microblades. We need a handle on which to put the blade. We need the pigment to put. And nowadays, as the procedure is becoming more and more famous and common and people are asking for it, you have some gadgets which make it easier for you to do the microblading. Like you have these pre-inked microblading threads, which are like floss. You take it out, they are already pre-inked. You can mark on the patient. It's not a cumbersome process. The ink is already there in the thread. So you just take out the thread and mark. So that is very easy. Then you have these self-adhesive scales, it's with a sticker. You put the scale on the patient's head and it just sticks. So you don't have to worry ki with one hand you are trying to hold the scale on the forehead, with the other hand you are doing a marking. No. You just put the scale, it sticks on the patient's forehead and then easily blade. So this blade, if you can see, has some pins in it. What are these pins I'll be telling you about? This purple thing that we see, this is our microblade holder. This is our holder. This is the templates of the artificial skin you can get very easily on any online site like Amazon. These are the blades. Then you have various kinds of scales. You have to decide what is comfortable. Do you want a flexible scale? You want to do the measurement with the thread? You want Verniers caliper? Then you also have this kind of caliper, which is known as a golden ratio caliper or the microblading caliper. Because you put it, you know where you have to make the arch. And then you need these holding cups in which you put a little bit of pigment, you put it in your finger, and it's easy for you. And obviously you need the pigment. So what are these blades? Now see, blades are basically pins. They have these pins and there is always a number given to them. It's 7 number, 16 number. The 7, 16, whatever the number is the number of pins that you find. If there are 7 pins, it's 7 number. If there are 16 pins, it's 16 number. And these blades can be hard and flexible. Hard means how will you recognize? The whole hard blade is metallic. And in the flexible, you will see it has a plastic end. And then you also have a straight blade and you have a U blade. I will show you. Then in the hand tool blade, you can have a single blade, like you have a blade which can hold one blade holder, which can hold one blade, or it has on the both sides you can put a blade. For example, you're not sure what blade I'm going to do, or you want to use a thinner blade, so you can put on both the ends. That way you don't have to keep taking out your blade and replacing it with the other blade. So whatever you do, mostly results are same. Only thing is that you have to decide what is comfortable for you. So that will take some amount of permutation and combination, some amount of, you will do the procedures, you will realize which one is comfortable for me. And if you want to do thinner strokes, you have to hold the pen perpendicular. And if you want a thicker stroke, you have to have it at an angle. So all this will depend on what kind of hair the client is having. What kind of hair the patient is having. If the patient is having thin hair already, you can't give her thicker strokes. The strokes will be thin. You will do the microblading with the kind of hair the patient has. So these are the kind of blades. If you see, when you talk of 7, this means 7 pins. When you talk of 21, it will be 21 pins. And U-shape is something like, so these are your hard blades. They are totally metallic. And you see they are slanting. And you can have slanting, you can have a U-shaped. The slant, usually you have one needle which is bigger and then it tapers off. What is the purpose of this tapering? This is because the pigment is sucked in by the capillary action. A bigger needle sucks in more pigment. So this bigger needle, you will start the root of the hair from the hair, and the smaller needles, you will just elongate it so that you have a 3D effect. Where the hair follicle is coming from the root, you are going to put your bigger needle. More pigment is there in the bigger needle, and then you just arch it off. It gives a 3D effect. The root is thicker and the hair tapers off to a thinner head. This is a U-shaped blade. So it is not in a slant. The results are same. Only thing is you see what you are comfortable with. The U-shaped blade gives a better curve to the hair. So if you feel this is more comfortable, you can start with this. And then there are these nano blading. Nano blading is anything where you have more than 18 needles. So they are very, very fine needles. Right? So the diameter of the needle is small and the number of needles are higher. Obviously, when you're choosing any blade, you have to see how lax the skin is. If it's very lax and you use a hard blade or multiple needles on the blade, you're going to create a lot of trauma. And you also have to decide, depending on this, you decide what type of blade are required, how many pins should be there, and what should be the hardness of the blade. Now, this is how the blade handle looks like. You have a crisscross opening, an X opening on this. And what you do is, in this opening, you put your blade, less than half of it, you put at 90 degrees. And then you tilt it little at 155 degrees from the blade handle. And then you rotate it and fix it. Once you have rotated and fixed it, you will not be able to move the blade. So this is how we insert the blade in the handle and fix it. And now it is ready for use. We have tattooing machines also, but those tattooing machines are not used for microblading. They are used more for ombre brows, where you want to give a powdered brow appearance to the patient. Now come to the pigment. So there are various kinds of pigments. You have organic pigments, inorganic pigments, and you have pigments which are used by tattoo artists, which have azo compounds. You have polycyclic aromatic compounds. So as a rule, we should always go for organic compounds. And this is iron oxide is the most commonly used and it's quite safe. And we should get a medical grade pigment, where the ingredients of the pigment are written on that pigment. So pigment is not a solution. It's a suspension. It has particles in it. It can be gel based. It can be alcohol based. So usually we use alcohol based, but if the skin is very oily, we can even use gel-based. The particle size is 6 nanometers. The pigment should be insoluble. It should be light and tissue stable. It should be inert to any immunological destruction. You put it and you have a granuloma, that should not happen. And it should be free of any toxic or mutagenic substances like cadmium, mercury, any heavy metals. They should not be there in it. And as I said, it should be a medical grade pigment. So it should be biocompatible. It should be resistant to evaporation. It should have a stable concentration. It should not change colors. You do it as a dark brown and after 6 months, the patient comes with green eyebrows. That should not happen. So these are the pigments, usually iron oxide pigments. Now there is one little about the color theory. The color theory is a very continuous learning process and it cannot be learned in a day or a month or a year. We need to basically understand what it is. It is basically about that we have this Fitzpatrick scale from 1 to 6 skin types. 1 is the one which burns and 6 is the which tans. So the undertone of the skin is the color under the skin. And normally Fitzpatrick is the color we have. Skin undertone is the color which is under the skin and it is supposed to be of 3 types. It's cool, warm and neutral. So I'll tell you what cool means. So cool means that usually the patients whose skin burns. And these are people who have light green or bluish eyes and the best way to find out is whether a patient has a cool undertone or not is to see if you consider a patient and you figure out, you imagine, will a brown eyeshadow look good on her or pink? If you feel pink eyeshadow will look better on her, she's a cool undertone. If you feel a brownish shade will look better on her, she's a warm undertone. And neutral means both are going to look good on a person. And mostly we are either neutral or we are warm. In our country, we don't have a lot of variety in eye colors, or we don't have a lot of hair colors. So usually we don't have a lot of skin undertones. We are usually warm or neutral. And we don't have a lot of skin colors. There won't be a blonde or red or all these colors coming. So mostly the patient either will have dark brown, slightly light brown, not that light brown also, and black colors. So this is more important for us when we are trying to correct an eyebrow. For example, a patient comes who has a greenish color or a bluish color. You won't do microblading with a brown color because the color will not come. You will do microblading with an orange color, with a complementary color, and that is how the color will come brown. So this is actually the practical use of this color theory. But obviously, if we do a variety of patients or we do a lot of international patients, then of course, some amount of color theory is important. So contraindications, basically, if a patient is having allergy to pigment, pregnant and lactating, we are not going to do. Any seropositivity, better not to do. Then history of melanoma, we are usually doing it in patients of cancer who've lost eyebrows because of chemotherapy, or even areola redesigning is done for patients. But especially for melanoma, we don't want to do because this iron oxide can get drained into the sentinel lymph nodes. And many times it's not possible to differentiate between the melanoma cells on histopathology also. So even if you do the histopathology, you won't be able to differentiate whether this is a melanoma cell or is it an iron oxide cell. So therefore, for melanoma, it's a complete no. Then major skin diseases obviously won't do. For unstable vitiligo, children under 18 years, keloidal, so these are the normal things where we usually don't go. So what are the complications? Now, the beauty of microblading is we are very, very superficial. We are at the level of upper dermis. So once we are there, the hardly any pigment is absorbed and hardly any complications are there. So usually it's erythema, induration, tenderness, which will be there for a few days. Infections, if we are not careful. Asymmetry is the most common side effect, or uneven pigmentation. Kibnerization, allergic reactions, mostly to heavy metals, not to what we are using. And contact dermatitis to imla. Sometimes, not known though, but granulomatous reactions, sarcoidal or foreign body, then decorative tattoos have more side effects than these kind of tattoos. And then one important thing is pigment ink diffusion. Like you'd made a thin stroke, the patient comes back to you and she has a broad stroke. The pigment is diffused. This happens when we are deeper. If we are superficial, this will not happen. So this is technique dependent. And if you have to remove, you know how to do that. So most important thing is counseling. You understand the patient's expectation. You tell her about the reversal in the beginning also. This cannot be reversed. Written post-procedure instruction, because post-procedure is very important for giving the best results. The post-care for 1 week is very important to give the patient, for the pigment to get retained. Healing process is over 6 weeks and you have to take the pictures in the same angle. So analyze the natural brow of a patient. You can't give them totally different brows. The direction also stays usually the same. Discuss with the patient what they actually want, what you're going to do. You can draw it with a pencil and tell them that this is what is going to happen. Then shape of the eyebrows we've already discussed. According to the face of the shape we know. Then alignment. This is very important. On day 1, the patient will feel, wow, what brows I have got. On day 2 to 4, he will see that it's become too dark. She'll say, doctor, what have you done? It's looking so artificial and dark. And day 5 and 7, it will become patchy, blotchy, and it will start peeling and scabbing. By day 8 to 10, all the pigment would have been gone and he would be like normal, what he was before. So he will call you up, the pigment is gone, the procedure was not good. And then between day 14 to 28, the color will slowly start coming back. And at day 42, you will have actual pigmented brows. So what is the significance of this? One is that pre-procedure counseling, that this is going to happen. Second is that patient will come to you at this 8 to 10 or 14 to 28 days, doctor, do a touch-up, it's gone. You have to tell them to be patient. This is going to come back. And if you do a touch-up at that point, you may do crisscross and whatever, with new. So wait for the touch-up, not before 6 to 8 weeks. So this we have done, how to measure. Then you tattoo them and the touch-up after 6 to 8 weeks. So you have to give sunscreen because it fades if you are out in the sun quite a lot. Avoid sweating for 3 to 4 weeks, like too sweating. And no Botox or AHA, BHA, retinol for a month. So this is the kind of template we have. So you have to practice on this. And let's start with microblading.
So as you all know, microblading seems to be the new fad and everybody wants to get it done. But I think both our speakers have kind of got the point across that the things which look the simplest may not be that simple. And especially because the patient, eyebrows are so important and this is something which is kind of irreversible for that time. So you need to be really very careful. I think this cannot be stressed upon more than is necessary. And you need to be sure of what you're going to be doing before you start to do it. So thank you. Any questions? No. Okay. Okay. So now the hands-on session is going to start at the back of this hall, and all the people who have registered for the hands-on can go to the back of the hall for the hands-on training, while the rest of you can keep sitting here for the live demonstration because that's going to be shown here on the screen. Thank you.
Recording stopped.
There's a request to all the candidates that please be patient and be seated on your own tables. Okay, don't rush to every table where Dr. Umesh and Dr. Monica are. It is like a sequential thing. They will be coming to every table. Okay, so it's not like your turn won't come. If they are not on your table, please be seated and by that time try the strokes. Okay, they'll come in some time to your table. Okay, the arrangement is already there. Okay, but please don't move on every table, otherwise it will be difficult for the faculty.
Recording in progress.
Miss Priya, please arrange a table for 3 more candidates. इधर कोई है? किसके साथ?
मैडम प्लीज पीछे थोड़ा
हाँ कैमरा वो साइड रखो ना फेस दिखना चाहिए This is my basic structure.
चेयर हटवाओ ना अभी तो इधर आएगा थोड़ा सा इधर लिया
Flexible scale. This distance should be
थोड़ा इस साइड आ जाइए तो सेंटर में आ जाएगा
and the lower side is 7. If you consider the flexible scale, उसमें 3 आप देखोगे 5.5 पे आ जाए वो भी एक easy तरीका है. So it always. Now we have this. This is the edge. I know this is the highest point for this. This is my first. Okay, bye. Now, if this we know is 5.5, this should be 0.5, and this should be totally from here.
This is our first horizontal line. Then you take, now for her, if I have to do, I know that the eyebrow for her is very small, so I have to thicken the eyebrow. At least I'll make it 0.5, at least. So I can take the measurements and I can make it here. So her eyebrow is going to be at least this much thick. And then I take the last marking from the arch. Obviously, will change. Now you make your broad outline So this is like a comma. This thing is going to be like a comma. This is the arch. From here you go. Right? So I am going to microblade inside. For example, she wants a little thicker eyebrow. Then I go a little. Right? No, tail, if it comes a little low, it cannot be lower than this. Same plane. But this is according to this, if you look at it, it's fine with her. No, this length is fine. Slightly more you need, that's all. So that's how you draw the basic. Now, how you start with microblading. First, take your blade. एक pigment भी दे देना, please. So you can all open your blades. You can see this crisscross. So you have, this is your now what we are going to do is just, have everybody taken out their pens? Exactly. But so you open this, you can see this opening, right? And then you just open your blade. Always wear gloves when you're doing it. So this is a slanting. Now you put it straight into this. Open this, put it straight into it. Okay. And just put it at 155 degree from the thread, from the blade. So this should be the direction. नहीं ऐसे ये जो लंबी साइड है 155 so the बाहर की साइड है जो लंबी साइड the bigger needles have to be at the point of 155 degree. So this is how you put the load your blade, right? And now we'll start microblading. So we've made an eyebrow. Have we? Okay. पहले इसको थोड़ा सा फिक्स करो, हल्का सा खोलो, इसमें आप अंदर डालो, इसको 90 डिग्री पे अंदर डालो और थोड़ा सा टिल्ट करो और नीचे से स्क्रू कर दो इसको. बहुत अंदर नहीं डालना है क्योंकि आपको वो काम करने के लिए चाहिए, बट जाना नहीं है. हाँ इतना. So you leave some space, मतलब for working. हाँ it is, see this 90 and 55. नहीं 90 and 155. 65. I think it's correct.
It's not bending more.
This is fine. Actually, the idea is that when you're holding it at 90 degrees, it can curve. If you make it 90 degree, you can't curve, na? Because this is 90, you can curve it from the wrist.
Just explain like the
Longer one is towards 155. Outside. Because आपका position ऐसे होगा और आप ऐसे करोगे. Longer end is towards 155.
Like this.
So the already templates are there, no? Yes, because we can't be, bending over the page. Can somebody give me the pigment? Now, please outline your mic. You can see the eyebrows on the fall skin. You've all loaded your blades. The blades are loaded. I'll just tell them how to. First, let me just tell them and let them start doing. I'm coming to you. So you open your pigment. No kit and no pigment. Oh. Is there I need something to.
Something can.
Ma'am, just hold it.
No,
No,
each one of them. No,
I need some
spoon kind of thing.
A small toothpick to mix it. You have to mix it now because it's a suspension. So we can do it with this pin. Right? So we have mixed the pigment. We can put it here a little. Okay. You can put it in your cups also. Right? Okay. So next thing, take your blade, just dip a little. This much, very little. Because if you want neat work, if you put too much of pigment, what is going to happen? It's going to smudge around. So you won't know where your strokes are. Just put very little. And then, as Dr. Umesh explained, there are 3 strokes. Normally, patient this will be 90 degree. This strokes. Look at each other's eyebrow. And you can't make this area too dense. This body will be dense and tail will be moderately dense. So here you are going to hold it, the longer needles from where the root of the hair comes. Okay. And then you go like this. Right. I'm coming. अभी इनको मैं कर रहा हूँ. हाँ, मैं निकल रहा हूँ इससे. Okay. So all of you, they will try now. So you start. Now you start. You can take this blade or I'll take this blade to other people. So you start first to see how you are able to do the strokes, the basic strokes, right? I'm just going to the other table. You don't have my number? 987 334 2872 2872 I'll give you a missed call. I have it. We met in Russia. We were together. Okay. Right. I think can 2 tables come here so that. अच्छा वहां से pencil, get the pencil and the vernier caliper from here. Okay. So you want to see the marking also? Yes. Do you want to see the marking? Yes. Mapping. वहाँ पे vernier caliper and pencil. Okay. So who is becoming the let other? Okay. So if you are the model, come here. Pencil भी है ना? White pencil नहीं है? White pencil. अच्छा. Okay. So. Can you just record so that I can also see? Okay. So one thing is there. What we are going to do is remove. You'll have to remove your mask. So first thing is whether we have to see the nose is broad or small. If the nose is broad, then you take from the medial ala. If your nose is broad. So there are a couple of lines we make. First is medial ala, lateral ala, right? So first, before we start, pinch the skin and mark the center. Okay. In the center, make a line. Okay. Or will you remove it later? Okay. Now she has a broad nose. So I cannot give her from the medial ala. So I, like for example, yours, I have to do from the lateral ala because otherwise medial ala will be kind of very close. Okay. Right? So here is this. So this is the beginning line of my eyebrow. अच्छा वहाँ पे वो भी है blade. So another blade नहीं blade.
Ma'am, if you have a narrow nose, we do
No,
from this
sharpener.
angle.
I need blade. Sharpener need blade.
No, from this. If you have a narrow nose, we'll do it from this angle.
From the, if you have a narrow nose, then go from the lateral.
From the lateral.
If you have a broad nose, then go from the medial.
Because if we go from this side, the color line will be a little broader.
So you have to take that consideration. You will see in some patients, this thing you have to consider. Right now, there are 3 points. Number 1 is I've made the beginning of the eyebrows. You look straight at me. This pencil has to be sharpened in a particular way. It has to be sharpened flat, like this. Right? If you make a tip, which it has, वो tip कम होती जाएगी, जैसे हम लिखते जाएंगे, ये sharpness नहीं रहेगी. So if you sharp it flat, even if वो होता जाएगा कम, it will stay flat. So you have to sharpen it as a flat pencil. Okay, which I'll show you just now, which can be done only with a blade and you have to go reverse. Okay. Now, second thing, look straight. If you are going from here, then you have to go from the center of the pupil. If you are going from here, then you go from the edge of the
nose.
Edge of the nose, then you go on the lateral side. Otherwise, you can take this one marking from nose, lateral end of the ala, lateral canthus, and this line. So this is my eyebrow, right? These are the 3 markings. Now, normally, this distance is 0.5 to 1 centimeter. This distance is from 0, 5.5. This distance is 7.5. 7.5 from the center is the length of the eyebrow. Now, 3 horizontal lines. First, you note where is my superior end of the orbit, and that should be the line where my eyebrow starts. Okay. Then you make your other line 1 centimeter above, because her eyebrows are very thin. So we will have to give her a thicker eyebrow. So that would be like 1 centimeter. So this is going to be the thickness of my eyebrow. Then where the arches are, I draw the 3rd horizontal line. Okay. And that is how it is. Then you join the lines. So this is my, it's like a, so this is almost a parallel line. Almost a parallel line, but इसमें आपको थोड़ा कॉमा बनाना पड़ता है. ऐसे आया, इधर थोड़ा कॉमा बनाया और ऊपर की तरह का है. Okay? अच्छा, whenever you are marking, stretch the patient's skin. Stretch the patient's skin and then do the markings, right? And the highest point of the upper eyelid, upper eyebrow, is going to be medial to the highest point of the lower eyebrow. Okay, so this is going to be the highest point of the lower eyebrow. This is going to be the highest point of the upper eyebrow. See, this is the highest point of the upper margin. The lower margin, the highest point, thoda sa lateral. Okay? See, horizontal lines, you measure this. This is the superior part of the orbital rim, which you are feeling here. You know, the edge. Wahan se dusre side, one line. Then 1.8 centimeters above this, your second line, which is the total breadth of the eyebrow. And then third is where the 2 arches are. Okay? So these are the 3 horizontal.
As a particular case, she needs broader eyebrows.
Broader, yeah, she needs a broader eye. Okay, right. So now look at the shape. Here, it will never be dense. Here, you have to keep your eyebrows sparse only. Don't try to make this area very dense. If you notice in most people, you can see individual hair. And then this thing you see, ये आपको एक dark seal ऐसे लग रहा है ना? This is the spine of the eyebrow. यहाँ पे 90 है, यहाँ पे 45 है, यहाँ पे नीचे की तरफ 45 है. ये जो transition है ये smooth होना चाहिए. तो इसके लिए we draw the spine of the eyebrow. Spine of the eyebrow is this. So this means, can I have a picture? So this means if this is your eyebrow, this is your eyebrow. So 1 centimeter, this is your head. This is your body and this is your tail. So you make this. कईयों में क्या होता है? Spine extends to the tail. In some, it starts from 1 centimeter beyond and ends like this. So what you do, you make this 90, right? Then you make this 45. And then this comes down, right? And then, so in her case, you can clearly see. Dark area, this is the spine of the eyebrow. Agar mujhe iska karna, I have to look at her shape. So this I will make as 90. Then I'll go 45 here. Along the spine, upper fibers will also converge. So this will be like this. Downwards, you know. So these are the converging strokes. And that will give it a slow, and then here you will do this. So first pass mein you make the mother strokes. Then you make finer strokes. So mother strokes start from the start of the eyebrow, go to the end of the eyebrow. Matlab both the margins. And जो other strokes होते हैं, midway से start होके ऊपर जाते हैं. So अगर आप दो strokes ऐसे करोगे, it will look very unnatural. So you have to have each में these strokes so that it kind of looks natural. Okay. So now
can you just explain
one patient, another.
So it might also like start from here and end up like in the.
So it will start somewhere beyond the head, just 1 centimeter distance. क्योंकि change तो वहीं पे है ना? तो
Basically, it's a converging point, right?
converging point,
जहाँ पे
which is a
density ज़्यादा हो जाता है.
transition. हाँ, it's a transition. Spine आप किसी में बता सकते, because I was not able to see. See, इसमें नहीं है. See, if you see. Asha, you put the pencil. Okay, like in her case, what you are seeing, there is a darker thing and it's coming like, there's a line which is coming like this. So this is a spine. So here you see, you can, for example, in a patient, if you're doing microblading, आप इसमें 2-3 strokes कर सकते हैं, but आप इसको ज़्यादा dense नहीं कर सकते हैं. ठीक है? Then you go to this spine. थोड़ा सा ऊपर देखो. आप देखो, इसको ऐसे करोगे ऊपर. But ये ऊपर के fiber नीचे आ रहे हैं. So this is going up, this is going down, and this is that spine. तो spine पे converging strokes आ रहे हैं, and 90 से 45 से downward 45 में transition smooth होना चाहिए. Otherwise, ये spine हुआ मैम. ये darker है. So it will always start 1 centimeter. मतलब head जहाँ से body start होती है, almost it will start nearby that. And sometimes in some people it can even go up to. Now, for example, in her case, you see the direction of the hair in the tail. And so they are outwards. So you have to be very careful, because in her case, you have to keep the direction in the same way. If you try to change the direction, it will give a crisscross effect. So
we have to give two things. We go like this and again this way also.
Yeah, but very light and gentle, and no stroke should no merging. Now you've loaded this. All of you have loaded this pen.
How do we do that?
So first you take this. Take this. The longer needles, keep them towards the outside, like this. Put less than half of your, maybe half of this, and just rotate. First put 90, then turn it a little and rotate. Longer needle outside. Okay. So this is your 155 degree from here. Okay. Just do this. You turn it and it doesn't move, you know. Now we take the pigment. So all of you try on the skin. You will feel a that avaz. See, a lot of good pigments are there. There are a lot of
mixing also, right? Like so there is like coffee color and brown color and black color.
See, I will tell you, I use only one color, and that is dark brown. And most people you require only dark brown. Never use black. Never use black.
Mixing black and brown.
Black will give you a very dark. Black is not recommended at all.
It gives a greenish hue later.
You can't use black. All
Brown, black is ideal. Brown, black.
dark brown.
Dark
Dark
brown.
brown. You can
Black and brown? Or
don't
maybe black and red?
you in dark brown you won't require to mix. It's what we have. Black is the kind of thing which people from Africa have. Total black. You can't give that color. So the best color to start with is dark brown, and it suits 99% of the people. So you don't need many colors in India, and we practice in one region, so you know. So now this is a suspension. It's not a solution. Mixing of the pigment before use is very, very important. So you can't just pick it up and use it. You have to mix it. Right now, we just need very little pigment. This is a very small blade. The root of the eyebrow. And I'll tell you a trick in the skin which you can do. This is the eyebrow which is drawn here, right? This is the eyebrow. So you have to start from the root. The root will have this. So it's so you will go like this. So here I have to be least dense. Least dense. And I think you have to go a little on the head of the eyebrow. See, check your friends. Every fiber is clearly visible. So here you can't increase the density. And then after the stroke, you will come back for the next stroke. And then once you've done your first pass, you have to put a color mask. Color mask is you take the color and rub it and leave it for 10 minutes. And after that, you remove it with Vaseline. Don't remove it with water or saline because that will wash away the pigment. So take Vaseline petroleum jelly and remove and clean that area. Because for 7 days, you have to tell the patient not to put water, splash water, but it has to be a quick washing or just use a wet wipe and dry it off completely. So here we are doing like, so basically not a very, so whenever you buy, so this is going to be our 90-degree here, 45-degree here. So if we draw a spine like this and then this, the blade, should not be so thin. Otherwise, it will not kind of, it has to hold also. No? So your movement has to be this, it has to be curved. This is not a good quality blade.
How deep do we go?
It has to be, you hear the crux sound, but it is superficial dermis.
There should be no bleeding there.
No bleeding. So that can also change the color of the pigment. So, and then it will cause diffusion. So blotchy eyebrows can happen. So,
number of blades to
12 to 14 is good.
Man can start
With 7, 8 से start करो. थोड़ा needle थोड़ा thicker होगा, better होगा, and then you can do this. Amazon, I think I buy. We may have to use more than one blade. So here I use Prima blend, वो मिलता नहीं है यहाँ पे, but there are a lot of this color is also Dr. Umesh is using this. So these are also good colors. Achha, when you do on skin, there is another trick which I'll tell you. You clean it with wet wipe and then you kind of see like this. You will be able to see your strokes, what I'm saying is जब आप इसको करते हो ना, मतलब इससे मुझे किया ही नहीं जा रहा honestly इस blade से. So like this is 45 degree, your movement is like this, you make this. Then you go from here downwards, which continues like this. What I'm saying is once you do on skin, get better blades. You get very good blades. And then you on the skin, you can always fold like this and clean it. clean it with saline. You don't need the pigment, and see the depth of the strokes you have made. And when you do them many times, you will see that your depths are uniform. So that is the benefit of, you just fold it and you will be able to see the cuts that you have made, how uniform they are, right? So that's how it is. So loading of the blade, the strokes. So all of you start practicing. Let us
And after the second pass, is again the same way?
see. Actually, I'll tell you on paper how is it, because this is not comfortable. So this is your this. So here you go few mother strokes. So these are basically from the base here. Then you make a spine, which is like this. Then this is at 45 degrees. So you make these strokes. And from here you start, making these ones. And then it will go down like this, right?
How do you make the spine?
Spine we don't have to make, it's already there.
Sir, maybe
No, because see, you see the direction of the patients here. The upper here are coming down. So for this thing, you will have to start your hair stroke from here, because this is the root. So you will start from here. This is your spine, and that is the gradation for the how the follicles will come from 90 to 45 to downwards.
Any specific
It's body, yeah. See, first stroke, don't keep the density high. Then you clean it up. Then these are the mother strokes, which are basically from the one end to another, bigger strokes. Then you make the smaller ones to fill up in between, right? Second pass and the third pass also.
How do we
Three
hold
passes.
this? How do we hold this way?
No, I hold it like, see, you have to find this.
Our
If
own
I,
comfortable way.
see, for example, I sit at the back of the patient, and this thing has to be from the root. So my direction is like this.
Okay.
Right? So the bigger pin should be at the root of the hair. So this is the root of the hair. So when I go here, I turn my chair and then I go like this.
Okay. The origin of the hair should be with the bigger needle.
Bigger needle. Because the capillary action sucks in more pigment there. So that is how it gives a 3D effect. Same pigment.
Can you repeat that needle length?
नीडल लेंथ में क्या होता है ना, जहां आपका रूट है, बिगिनिंग है, वहां पे यू आर गोइंग टू रूट ऑफ द हेयर शुड बी वेयर द बिगर नीडल इज. तो आप रूट को ऐसे करोगे, राइट? And this is not a good blade, so you will have to get a good blade to practice. Otherwise, it's not as difficult.
And when you say bigger needle, means a bigger part.
Length. And then, so you start from the root and go. So because of the bigger needle, the capillary action, the pigment is more. So it gives a 3D effect.
Can every time we have to do 3 passes?
No,
As a rule?
when you become an expert, you do it in one pass.
Otherwise, to begin with, should we give two?
Because if you, in the first set, you will know how much I have done. Lot of strokes will be uneven. So somewhere the pigment would not have come.
Always better to fill them.
And
Right.
how do we judge like do this way? I mean, I've seen some people doing. So like normally strokes are there, how we fill with the eyebrow pencil, no? So some people just take the pigment and just fill it this
But
way.
that won't give
That is
you
not this way.
So you can do ombre brows, but that is also not pura filling. So in ombre brow, you have a needle with 1500 to 5000 oscillations. So when you do like this, very superficially, so it gives a dotted appearance.
Yes.
So that's an ombre brow. So that is a second step. But this is what most people need. Ombre brow gives a little bit of makeup look. It looks good. Achha, for example, somebody has absolutely low density eyebrows. You cannot give so many strokes. It will look clumsy. So you give strokes and then do the ombre.
And how do we judge whether the pigments which we bought are? How do we judge, ma'am, that we bought certain pigments they're working or not? I mean, they're good or not?
do it on your family seat color. And they should retain.
And they should not.
They should retain. Matlab, they should retain.
For 6 months or something.
Definitely. No, for 1 year if you're using it. Vegetable.
Thank you so much.
We will ask everybody who wants. Okay. So you have all the things. Okay. Have you done the mapping? Okay. So let us ask one person. You've seen the mapping? You haven't seen it. Okay. Model. Okay. Somebody.
Do this on him.
Whom? He wants to learn also.
Okay, no problem.
I didn't. Which blade? Me. I have. So somebody who already knows, we can do it on that person. It's not. You don't need it. See, first, what you have to do, you'll have to take off your specs, and you'll have to take off your this. Right. Now, first thing is that you have to, before we map an eyebrow, we have to mark the center. Pinch the nose and mark the center. The pencil has to be sharpened flat, like this, point नहीं होना चाहिए. थोड़ी देर में point blunt हो जाएगा. So we need to like sharpen it it should be flat, not like this. Okay, that you can do with the surgical blade. So now first we have the center of the eyebrow, right? Now second thing is we have to mark 3 vertical lines. So first vertical line is from the medial ala. So this is the beginning of the eyebrow. Second is look straight at me. You can do it from the medial ala. This is her medial ala. This is her lateral ala. Okay. So from the medial ala, center point, center of the pupil, this is an arch. From the lateral ala, from the outer canthus, this is her eyebrow. Then we have 3 horizontal lines. You see the supraorbital rim. The highest point is here. So that should be the beginning of the eyebrow. Right? Mark the point. Right? Then my eyebrow width has to be 0.8 to 1 centimeter. So depending on what kind. So if I want, what is the length of the eyebrow I want? So I want it, let us say 0.5 or 1 centimeter. So I can keep it 0.8. So this is my 0.8. So this is my second line. My third line will be where we have the arches. Right? So this is where the arch is. This is where the eyebrow will start. And this is going to be the breadth of the eyebrow. Okay. Now these are almost parallel lines, but almost, not actually. Then you go here, you make a little round here. This is like a comma. She doesn't need a. When you are marking, you have to stretch the skin. Otherwise, you have to stretch the skin and you just join all the points. So she could do with a little less tail. If you have a very long and a downward tail, it gives a tired look to the patient, right? So if I tell her to remove this part of her eyebrow, so when you are counseling the patient and you are telling her what shape, that time you can tell her that, ma'am, actually this point and this point, these 2 points should be at the same level. If your tail is lower than the beginning of the eyebrow, it gives a tired look. So you can thread this part and come to me when you are coming, because she has to do the threading before she comes. Okay. So that is what you have done. And then you can start microblading. Now there are 3 directions in which we go. So this is my eyebrow, right? So this is 66% of your eyebrow is your head and body. 33% is your tail, right? That is the proposition. Now almost 66. So this is the head, which is almost 1 centimeter. Then this is and the tail. So what you do is this is always 90. But 90 doesn't mean this. 90 means you have to give it a little curve, like it starts. So mother strokes are those strokes which start from one edge and they're long hairs. So you can start with few mother strokes. In your second pass, you can do some, filling strokes or the secondary strokes. And this head should be not dense. You should be able to see each individual strand. It should not look like a blotchy bulge of pigment. So even when you're doing this, just stick to, you can even do in your third pass, filling in with these, but not more than that. Now, this is where you start going 45 degrees. So this is 90, but an arched 90. So it can't be sudden 90 like this. It has to be a gradual arch. Then you come to the body. Here you are going 45 degrees. So this transition has to be smooth. It can't be sudden. So for that, what you do, you see the density of the fibers, how they are. So you will see that there is something called a spine. Spine means where the hair follicles are converging with each other. You will, and this is usually like this, right? 40% upper part. So what happens here, you will start making these 45 degrees, right? Here you will see that it's coming down like this. So your root is here, okay? It's coming down like this. And in the tail, it's downwards. Don't make fish tail until patient has it. Fish tail is like this. Some patients have this. So this is, you will have to follow the pattern of the hair only, but normally like this. So where you have the maximum density, so this way it is a smooth transition from your 90 to 45 and then downwards. Okay, this is the direction of the hair. Now, when you are doing on this, there are a couple of advantages of doing on this. You have the template already there. You can see the template. This is the template which is already made. Now you take the blade. Now, this is your blade. And you fix it. So how do you fix this? Okay. You open this up and you put the larger needles, the longer needles on the outside, right? On one side, both the sides are outside on your right hand side, and then 90 degrees, and then you turn it at 145. Metallic needles, and then you just turn it towards the right, and when you can't move it, it's fixed. Now, when you have to start doing the pigment, mix the pigment well, okay? Because the pigment, mix the pigment well, because as I said, it's a suspension. So you have to properly mix it and take it in your cup and take very little of the pigment. Okay, only don't take too much of the pigment, otherwise the pigment spreads. And then you put it at 90 degree and curve. Like this is the movement of your. So you have to stay. This is not a good blade. And then you go like this. First, you make the bigger strokes. So you're starting from where the hair arises to, you keep touching it, and you can go make it with
making the
mother strokes, and then it's coming down from here. So you can do a little bit here, and then here this is it, and then you can just, so you see where the spine is. And then you keep doing this. So whenever you're buying the blades, you'll have to do a lot of, don't crisscross, touch. The patient will bleed, the results will not be good. So here you go. And then here, these ones, you have to go slow the gradation. This is not a good blade for me. You know, अपने blade की आदत होती है. So then you go down. It's a very flexible blade. And you go to the edge. And then you clean this up. So when you are practicing on the skin, you will clean it with a wipe. It will come off. And then you check what kind of strokes you and you give and whenever you are doing it, there is a crack sound you hear. So that's normal. There is some kind of a. And so one more thing is position of your hand. So when you are doing it, you have to stretch the eyebrow, which you will not be able to do on the artificial skin. And this finger should be stretching the skin. You know, other fingers should stretch the skin and then you should be doing it. So what happens with that is the skin has to be properly stretched. If you don't stretch the skin, the result will not be good. Okay, so now what you can do, so what I'll advise you is the pigment should be good quality, the blade should be good quality. You have to see which blade you are comfortable with. Some people are comfortable with 7, some are comfortable with 14, so sometimes people are doing with 18 also. Flexible is the blade to go because rigid blades go deeper. And you have to be very superficial. The amount of pressure has to be very uniform kind of a pressure, right? So you are doing this. It has to be uniform. So first you make the main strokes, clean it up, see how it is looking, then go for the other strokes. Okay. So you can all load your this and see if you can do. Head end. That what is comfortable because from the front, many a time, see, I sit on a rotating chair. So when I'm doing the lateral part, I go on the side of the patient. And then each time sometimes you'll have to come in the front of the patient also because you can't do everything from the back. But like from the front, you somehow feel you are kind of on the patient. So sometimes that is little. Actually, I think it is more comfortable from the front because front कैसे? See, नहीं आप मुझे बताओ जैसे मैं ऐसे आप पे कर रही हूँ तो ऐसे करना कितना मुश्किल है पेशेंट का हेड ये है आप पीछे से स्ट्रोक करोगे ना I think you have to decide. Some people like it from, but I like it from the back. I think post doing a lot of patients, you get confident that you will decide your own methodology. Because there's no set rule. Yes. You have to start from the root and come to the hair follicle, whichever way you are comfortable. So I feel comfortable from. And there's one more thing. Here we are doing it on plain paper. Normally, patient has got some eyebrows, right? Not all patients come. That's easy. That's what becomes very easy. We know that what the direction we have. Exactly. Okay. Thank you so much. Topical you have to give. EMLA has to be applied. Without that, you can't do it. Which number of days should we use? I think start with 8, 9. And we take otherwise also workshops now. Not started. A lot of people keep asking, but obviously we can try. I wanted to ask. So a lot of people, Indians who go abroad, and when they get the eyebrows done, they get these center part removed, and somehow they look better because the center part of the forehead is more visible. So should we do it so much from inside, or should we do the microblading from a little bit far away? You mean to say making the gap a little bigger? That can be done. See, actually depends upon the profile of the patient. Like we do ombre brows or something. Why do we do it? Because patient wants to, have a little makeup look, as if she's used pigment pencil or something. So it depends on, actually the face, how it is. You can't have the, see, thank you. I have a small video I'll show you. It's in my.
Can we have everyone in the front rows, please? We are moving on to the next session. So microblading is a technique which has a very slow learning curve. So like you do the strokes, you'll learn it with time. You have to practice, and again practice. So in a short span of around 1.5 hours, you can check your interest in microblading and then you can go ahead with it. So microblading kits, you can easily get it from Innovative Surgicals. That is a company run by Dr. Manjot Marwa. So if anyone is interested, they can contact at the counter of registration. They will tell you the number of Innovative Surgicals, how to procure the kits. I would request Dr. Monica and Dr. Umesh, please come in the front rows in the faculty seats. Dr. Monica. Now to chair the session, I would like to invite Dr. Jasleen Kaur, Dr. Vinay Keshamurthy, and Dr. Prashant Agarwal.
Dr. Meera James is well known around the circles of aesthetics. So I invite her to give her talk on use of threads.
Hi, good evening. So how many of you are doing threads? Very few? So I'm actually not going to give you any PowerPoint presentation or anything. So I would like to know what exactly do you know about threads? By now, everyone would be very familiar with threads, the thread lift. So you know there is already botulinum toxin, filler injections and everything. So why do we need thread lift? Can anyone tell me? Or what is the interest in threads? As we all know, botulinum toxin works for the dynamic lines, fillers helps to fill up, contour, but whereas threads actually work to give a lift. So when we insert the threads, we see an immediate lift because the thread passing through the tissue gives a firmness. Then it being a foreign material, it induces collagen formation and that leads on to further enhancement of the effect. So does any of these techniques replace the other? That is, can you do a thread alone and get as good as botulinum toxin and filler? What do you feel? No, because when you are here for a thread workshop, you should have at least some idea, no? What are you expecting to learn from it? No expectations? You're sure you don't have any expectations? No expectations. Nobody has any expectations. So I think, Sahil, we can cancel the workshop because they don't want to have anything to learn. What exactly do you want to learn from this? Any one of you can tell me. Well, yeah.
Like between 35 to 45, I would say, who are looking for a slight, lifting of the sides of the face or maybe even forehead. Whereas like fillers are completely for the volumization, firmness, and it can be done at any age for that sake, but it's more like preferred for like people who are aged more than 50. But thread lift is something which works really good like in the mid-age group, 40s.
That's one aspect of looking at it, but we can do threads for any age. So ideally, we have to combine and use. That is the one that gives best result. So there are doctors who first do botulinum toxin and thread lift and later do the filler injections because fillers happen to be the costliest of these treatments. So in our Indian scenario, many times, many of the patients won't be able to afford that much of fillers because many of these workshops, you must have heard, to get good results, you need to inject almost 3 to 4 ml of fillers, and how many patients would afford that? So in those cases, we can actually combine these techniques and give best results. So today you will be getting a hands-on on the mono PDO threads, and I will be giving a demo on cork threads too. So initially, if you haven't started with the threads, it's always very easy to start with a simple mono threads. It's a very easy procedure. Anybody can do it. But the most important thing is to design the procedure. Because when we are trying to inject the threads, what are we trying to correct? We are trying to work against the gravity as well as the force of the neck muscles, which are actually pulling the skin down, giving that sagging. So you must have seen, like, okay, I know all of you watch YouTube videos to all these videos where people insert the threads in multiple directions. But whenever you are trying to put in the threads, always try to put in them in a superior lateral direction. Why? Because we have got a cheek apex. So we are trying to correct the cheek apex. The same way as when we inject the fillers. If we are putting the fillers in this cheek apex area, we get a better correction. The same way we are trying to put in the threads directed in that direction. So we get a better lift. And then we can put in more fillers or whatever needed. Yeah. That's what I was saying. Nothing replaces the other. Ideally, we have to learn to combine. Each has its own role. Thread actually gives a lift. It gives a better definition. But for something, we need that contour correction or filling. We do need fillers. So ideally, we have to learn to combine them. I always do a botulinum toxin injection and a thread lift in the first sitting, call back the patient after 3 or 4 weeks, and then do the filler injection so that I can place the filler correctly, as well as the amount of filler that you need is much less. I think with that, we can move on to the demo, and then I'll call you as batches, and then if anything is needed, we can discuss. So I already had a patient waiting there with the Prelox cream applied. Whenever we are doing the cork threads, we actually make an entry point because these cork threads are available with blunt cannulas. So we, same way as we use any other cannula, we make an entry point and through that we put in the thread. So we can even do without a local anesthesia, but there are doctors who even give anesthesia along the line of insertion. So what we usually do with the cork thread is we can either insert it from a single point near the cheek apex, or we can use 2 points. That is one at the cheek apex and one at the mandibular angle. So here I'll be doing from the cheek apex area, and then like, okay, you wanted to ask something?
Ma'am, I just want to ask about the entry points, right? I mean, which entry point is good? Is it temporal or is it from the scalp? I mean, I know it's for different indication like jowl, this lifting, you will have different.
No single patient has the same kind of features. No, so for some patients we need a better correction of the jawline, whereas for some we need a better like augmentation of the cheek. So depending on what we want to correct, that's what, like, okay, we can choose a point as a person grows older. It's always better to choose a point for the lateral because most of these patients would be having little hollowing of the temporal area. So, and there would be sagging of the skin. So we can place the entry point more laterally, more posteriorly. Yeah, and we can even choose 2 points. That is one at the cheek apex and one here. So that also depends on the patients. But most patients, you just need a single entry point. Don't even think that like, okay, you need to have cork threads to get the best results. I am still a huge fan of simple PDO mono threads because by the time most patients come, they're so afraid of threads. The moment you tell the patient, no, doctor, I have seen the videos of so many needles, I don't want it. But when they take it, they feel so comfortable. And you can just put in the thread, they don't even know about it, and it doesn't produce any complications except every time make sure the patient is not on any anticoagulants. That's the only thing. Sometimes the patient had been coming to us for years. They must have started on aspirin or something. I had a patient like that. So she had been coming to me for years. So once she came and we put in the thread, she developed a huge hematoma. But always be assured, even if they develop a hematoma, it's very much okay because it induces formation of more collagen, and that's what we are anyway attempting. So we should be able to assure them. So simple PDO mono threads you can do, and you don't need huge number of threads. That's another thing you always hear. If you're using a simple PDO mono threads, you need to put in like huge number of threads to get good results. That's why I was saying, when you're orienting the threads in a proper direction, you don't need too many threads. Even with 5 or 6 threads, you can give good results. So you should be knowing how you are placing it. So we will discuss further as we go ahead. So video threads are always absorbable. The same one we use for surgeries, that's one.
What are the different indications of these different types of thread? Thread, cork thread, monofilament thread.
The thing is like the screw thread is nothing. That is, the thread is actually winding along the needle, whereas the simple monothread is a simple filament. The cork has multiple small barbs. The barbs can be either unidirectional or bidirectional. So when the barb is there, what happens? It actually clogs more to the tissue and it induces more formation of collagen. So there would be more correction of sagging. That's the thing. So the amount of thread, that is actually the amount of foreign material. And we know it's simple physiology. That is the amount of foreign material. When it is more, there is more induction of collagen, and that gives a better firmness. And another thing is like you would all have heard, like the collagen formation, not only the collagen formation, the texture of the skin as such increases, and there can be even lipolysis. The adipocytes also get degenerated. that actually lasts for around 6 to 8 months. Most cases you have to repeat. So initially, if you are doing around 12 or 18 threads for a patient, maybe after 6 months or 4 months, you may have to put in 1 or 2 threads additionally and may have to repeat the procedure that actually varies from patient to patient. No, it doesn't. It actually becomes better. So whenever you are repeating the procedure, most of you don't need to put in as many threads as you needed in the first sitting. But the thing is, like, every one of us is aging every moment. So the skin is also going on sagging. So some patients may need more threads. Some patients get maintained at like small number of threads. I have a lot of patients who come once in a month and get 1 or 2 threads put in, and they're so happy. So that actually varies with our practice. So once they get used to that idea, they themselves come asking for, I want to lift this way. So allow the patients to see that. Always give the mirror to the patient and tell them, like, okay, what exactly would happen and what they want. So gradually the patients would come and tell us, Doctor, I want to lift this way, I want to lift this way, I want this to be pulled like that. And remember to put in the threads always on one side, give the mirror to the patient and ask them to come back so that they can make out the result immediately. So the amount of tissue which you can pull freely on one side, the side where we have put in the thread would be much less than the other side. Yeah. The collagen, the laxity happens because the collagen gets denatured. So that denaturation wouldn't be completely happening in 6 months. The collagen gets denatured like slowly and gets destroyed. So you are not going to go back completely into the original phase. Okay. So we can move to the demo. So I'll be doing it from the other room. Maybe few of you can join, not everybody. Like, I hope 3, 4, or 4, 5 can come with me. Yeah.
I think it would be better if you sit there. Yeah. Since it is screen.
That's how you assess. Many a time, even though we say it has to be mid-dermal level, we won't be able to exactly assess it. So very easy way to assess is, we are not seeing the thread, but we can actually understand, okay, the thread is moving. That is how we. Oh, it's. Hello, it's coming. Yeah. Yes. I have to. I'm so tired after waiting this long. we put the threads in the dermal plate. So the main thing we have to make sure is, if we are too superficial, the thread will be visible. But even then, after some time, the thread gets absorbed. But the patient would be panicking. Okay, the puckering. If there is a puckering, we can actually always massage along the thread so that the puckering disappears. How many days? Like, okay, you have to tell me. 6 to 9 months. Yeah. No. Till then, that wouldn't be visible. It would be visible for. Yeah. And then it starts getting degenerated. So it's visible, no? I hope I am audible as well as visible. So what happens is, like, okay, we can see his face, actually the other injectables had been done. So there isn't too much of sagging, but even then we can see the nasolabial folds as well as we can see the laxity. So both sides you can see, and this in, like, okay. So whenever we are using the threads, as we all know, like, okay, there are different threads, or the length of the thread is variable. So the thread always, have you seen the thread? Like, okay, take one thread. Yeah, the thread is like this. The thread actually, one thread, so that, no, the small video thread. The thread actually loops around the needle. So that thread is always longer than the needle. And the thread goes and it is actually guarded by a small white guard. So whenever we say the length, we have to either say it as the length of the needle or length of the thread. So if it is a 25 mm length of the needle, the thread length would be somewhere around 38 mm. Or if it is a 50 mm needle, the thread length will be 60 mm or 70 or something. So that actually, yeah, this is the. No, the length. See, this is a very small thread. See, this is the needle size itself is very small. This is a 25 mm needle. So this is the length of the needle. Yeah, 30. Yeah, 30 mm. So you can see, okay, see, you can see the thread actually going, and then, like, okay, the guard actually holds it onto the needle. So whenever we are actually putting in the thread, we put in the thread so that the guard actually comes down. So finally we hold on to the guard and withdraw the needle. So here we will be first, like, okay, I'll be doing a demo of the cork thread, and I always find it comfortable to stand on this side, whether I'm doing thread on this side of the face or the other side of the face. So here we will do cork on this side. So whenever we are doing a cork thread, can be like, okay, but it's always easier because whenever we are doing a botulinum toxin injection or a filler injections, we always change the side. If we are doing on that side, we usually go and stand. But for the thread, somehow it's more comfortable doing it from one side. So if you are a left-handed person, maybe you find it comfortable doing from the other side. So for the cork, this is what I was saying. Like, okay, we create an entry point around the cheek apex. So this is, you can create a point here or even further posterior laterally. So depending on how much lift you want, or you can create one point here and one point here at the angle of the mandible. Since he doesn't have too much of sagging, we need to create only a single entry point. So we can do it somewhere here, and we can actually put in thread from here. You have like, okay, marker or something. So the threads are put in such that, like, we always try to put in one thread from here, and then another thread from the midpoint of the nasolabial fold, and another thread we can put to the jawline. So 3 threads through a single entry point. You can put it. Usually the packet comes as 4 threads. So maximum you need to put in 4 threads and it's a small end. Then you create 2 endpoints. Hello? Or can you get one of those mics? Yeah. Yeah. No, I don't need it. So here, if we are planning an entry point here, like, okay, so we can plan an entry point either here or we can plan it the posterior laterally and we can have 2 entry points like this. So suppose we are having the entry point from here, we can actually put in 1 thread in this direction, then 1 in this direction and 1 this direction. So this is what we are trying to correct. So here we are trying to correct the cheek apex. So putting the threads in this direction. So there is a main difference between a PDO mono thread and this coke thread. So whenever we are putting in the simple PDO thread, we actually put it in a superior lateral direction as I had already mentioned. Whereas with the coke thread, what we do is we are putting in the threads in this direction and then we are pulling the threads. So we are always trying to exert that pull. So can you take the scope threads? I need the local anesthetic and the yeah, or even spirit is fine. Yeah. So clean the spirit something. No, both the simple mono as well as the coke threads are made of PDO, but now the polycapronolactone threads are also available as well as the combinations are available. So all these are. That's what, like, okay, in the initial sitting, you can do botulinum toxin injection and the thread lift, and then call the patient after 3-4 weeks. By then, the effect of the thread would have set in because the collagen deposition starts after 3 to 4 weeks, and then the botulinum toxin, the dynamic wrinkles also would have started disappearing, and then put in the fillers. Am I audible now? Yeah. And we need less filler then. That's what, yeah, less filler. Yeah. So the thing is, like, if initially we assessed the patient and we felt like, okay, we need 3 ml of filler, after thread, we would need like we can do, but I always find, and that's what I was telling, like, okay, different doctors have different ways of treating. There are doctors who actually do filler and then thread. I always prefer combination. Suppose the patient doesn't have time, the patient is actually residing abroad and the patient wants everything to be finished in a single sitting, then you can do everything together too. Depends on the, yeah, and their budget too. Yeah, individual preference. Different. See, sometimes when you observe the patient, what we can see is like a 40-year-old or 45-year-old, two persons wouldn't be having the same kind of sagging or same kind of skin type. So depending on the patient, we have to vary the. You can, but the number of threads you need is more and the number of sittings also more. So I'll give a local injection here. Yeah, this is for the entry point. Landmark, you can actually mark a point that is near the psychoma arch. So that again varies from a patient to patient. That's what I would say. Somewhere around the cheek apex would be the ideal point. Yeah, make it. Yeah, so that's what, like, okay. Here actually we don't have to bother too much about the vessel, but for some people we may need to actually go a little further posteriorly. Here, since the patient has already done so many procedures, that's why, like, okay, we won't get an exact idea of the sagging because there would be a little bit of inflammation and all these things. That's why I'm just going at the cheek apex point. Can you give me the? Yeah. So this is the needle I'm going to make the entry point. No, there is nothing like that. You don't have to actually specifically mark a specific point or anything. It's a visual assessment. Okay, so the I made the okay, hold this. So these are the cope threads. You can see here the thread is actually coming out through whereas the other thread what we saw was like the thread was completely inside and it was actually looping around and it is much longer. So here you can see, if you look carefully, the ends of this cannula are blunt. That's why we are creating an entry point. No, this is again PDO, but it's thicker. It has got polydioxanone. So you can see threads is not Can you actually lower this a little more? Yeah. Yes, a little more. So you are okay, no? Yeah? Yeah. You are actually going in. Since it's a blunt cannula, it actually needs a little pressure to put in it. I think I need it to be a little lowered. It's not, the position is in. Yeah. And this like okay, a little more bend. Yeah, that's fine. Oh, sorry. No, it's very difficult for the cope thread to be inserted like that. The other thread we can insert in whatever position because we have to hold the skin and then slowly insert it. So we should be able to go in there. That is what. It's okay. Yeah, it's okay. I can manage. No, it's okay. Okay, so now you can see it's going in. Yeah, see. See. Yeah. I also want somebody to be here. Yeah. Otherwise, we are actually making a cutting movement. No, we cannot just put it in like that. It's a blunt cannula. That's the reason. So see, I have reached up to here. See. Okay. So you just go in as much as you can. And since it is a blunt cannula, you are not entering any vessel, you are not damaging any vessel. That's the advantage of the blunt cannula. The same way as we do with the filler, like, okay, the cannula. But honestly, for the filler, I don't prefer using a cannula. This one, even if you are in the, that's what I was telling. If you are in the subcutis, you won't be seeing it this well. That is the one. Like, okay, otherwise it's very difficult for us to assess because each person's skin thickness also differs. So you put it in, like, okay, maximum this distance we have got, then just pull it. So the thread remains here. Okay, so this is a very long thread. That's why it's remaining here. Then we put in the second thread through the same point, but we are angulating it into a different direction. So here we can actually go up to here, or we can put it in this way. Since he has through the same entry point we are going in. We are not making another entry point.
you're in darkness.
Yeah.
It does not matter.
Yeah, that's why. Like, okay, you don't have to be like with this thread, you find it very difficult to go actually superficial. But the PDO, simple thread, we may go very superficial. When you're putting it in, like, okay, sometimes accidentally it can go very superficial.
You should not be.
We shouldn't be like because we shouldn't go very superficial because we want to go at the dermal level. Then only collagen deposition happens. So here you can see we are going at a different level. So it's okay. Like okay, with experience, like okay, once we start using the threads, no, we can actually like make it and go.
Which threads do you become super clear?
The mono threads.
These are not mono threads.
These are the coke threads. See. Yeah, that would be definite. Yeah, and this is not a needle, no, this is actually a blunt cannula. So the blunt cannula wouldn't easily penetrate. That's why I have to actually exert that kind of movement, and then only it just goes in. See. So we have reached up to here, and then we can pull it out. See. So we have put two threads going in through the same point, and maybe if we want, we can put in another thread also. Not exactly, because now the filler actually helps to see. Even after these threads, you would notice a little bit of volume deficit. So for the volume deficit, you have to actually put in filler. That's the thing. Can you lower it a little more? Because this way I won't be able to go. Yeah. No, I want this to come. Like okay, the headdress to. Yes, sorry, sir. Yeah. I hope you are comfortable, no? Yeah. So we can put in one more thread through the same point. So we can. Yeah, definitely. So after all this story, now you realize.
You'll get fullness here on the cheek. This can become
We are actually with the thread, we are attempting to correct sagging, not fullness. No? So when you want fullness, we actually need to do fillers. That's it. So this is it. And then we are moving on to the symbol period. Okay, so the third thread I'm actually putting in a downward direction. Different?
Wrong plane, we can say that.
That's what I was saying. Like, okay, if we are seeing the thread, that means we are very superficial. And we shouldn't be able to see the thread. We should be able to only appreciate the movement of the thread. We are going. Thing is like what actually we have to know is like we should be able to appreciate the depth. So we should be able to just see the thread movement. That's all. Like okay, we shouldn't be seeing the thread as such. That's the only thing. Since he has like yeah, that's the thing. Because he has actually already done too many procedures. That's why it's not going that easily. Yeah, otherwise, yeah. It it's actually becoming very difficult to go in. See the needle got bent. So that means like okay, since he had done so many procedures, that's otherwise it should go in easily. So what we'll do is like we will actually pull this thread. See, that's what we do. So we are pulling the thread and then we just cut it off.
Dislodging at the tip, if in case like you're vigorously putting it and then like at the tip of the thread
It doesn't come out. Okay, don't worry. Yeah, they have actually attached it that well, so it wouldn't come out. Okay, so I think we can start with the hand sole. So
we can not also at the entry point to put the maximum pull.
Yeah.
We can give it.
note. But what happens is, no, initially when the threads were introduced, we used to give notes, but for some people, it actually produces a nodule here. So I have stopped that practice because sometimes that nodule would be visible for a long time. So it's always better not to give that kind of note. Just you can pull the thread and just cut it off. So I think we can start with the hands-on. So monofilaments, yeah. So what we will do is I think each of you can start wearing the gloves, and then okay, we'll start here. Yeah, definitely. Here we will do mono we can. I'll just show for this patient. So we'll do it later. So I think we'll start with the mono. Yeah, you can start wearing the. I think okay, we can actually have the other table, and Dr. Jesslyn can also. Yeah. So I think on the. No, that actually the patient can be taken there, and Dr. Jesslyn is there, so she can start on the. Yeah. So. Yeah. 6.5. Oh no, there is a ma'am is there okay, yeah, ma'am, you can go with him, yeah, to the other table. So can you please announce in the and start with the hands on. What happened?
He's asking to your volunteer or hands on.
Hands on.
Hands on. I wanted hands on.
Yeah. Okay. Don't worry. Yeah. Please come. Okay. So here, okay, since I have done the cog on this side, we will do the more number of mono on this side. Okay. Nicole, so okay, she has, Mira James. Yeah. I thought okay, finish the hands-on for them and yeah. Whichever way, okay, yeah. Yeah, whichever way. Yeah. Yeah. Okay, don't worry. Yeah. Okay, whichever way, it's okay. Okay, plan it. Yeah, we'll just. Yeah. Okay. So you have already worn the gloves, no? So yeah, you can start. Yeah, just. Yeah, don't worry. Okay, we can finish it. Yeah. So this is yeah. Sorry. Yeah, clean. Yeah. Okay. This side also we have clean, no? Yeah, we have clean. So what we'll do is you want me to put in the first thread and show? Yeah. That was the cork thread. This is the symbol period thread. Okay. So what we'll do is yeah. So who all are there? Okay.
Check.
So 1, 2. So these are the 5 people.
Mono threads. Anybody's done mono threads or not? Okay. So you can come in groups of 5 or 6 at a time. So we'll clean. So what we do is in this case, mono threads basically is to build up the collagen. They won't give you lifting effect, but they will only, make your texture of the skin better. They'll make
okay. Yeah.
So basically, when you see the skin is loose, there's a lot of sagging. So they won't lift the skin, but you can feel that the skin is firm, tight that way.
Yeah, that's
so
it.
What
that
we do is
better.
we apply topical anesthesia for 30 to 45 minutes. Then we cleanse the face. Make sure this is not to be done. You should not be covering
come.
Eyebrows with the tapes because it should not any aesthetic procedure. It should not be uncomfortable.
I think you have seen the cork thread. Everything is clear. No more doubts. Yeah.
patient should feel very, very comfortable. So this is because this is.
So we'll
workshop,
start
if
like,
you
okay,
do this
first
to
I'll
your
just show
private
you,
patient,
like, okay, this is the
patient
symbol
will not
mono
come
thread.
to
This is a
you.
very small thread. Since this is a
So
very small
always
thread,
make
we need
sure
lot
that-
of threads. Otherwise, for a normal face,
first
like, okay, I would
clean
be
the
using
face.
50
Your
or
aseptic,
60
you have
mm
to
needle
maintain
size ka
aseptic.
thread.
That is
So
very,
that
very
would be like,
important.
okay, somewhere
So
around
you
70 or 90
like
mm would
first
be the length
clean
of
it with the dry
thread.
tissue, then use
Okay,
a
so
wet
these are
tissue.
very small threads.
Then
These
when
kinds
it
of
is
threads we
totally fine, then
usually
you
use for the
your alcohol
eyebrows.
swabs or
Or
betadine. You can
eyebrow.
use, first alcohol swab.
This is
then
actually
betadine, then
30
again
mm
alcohol
needle.
swab.
So the
This is
thread would be only
double, triple
38 mm
cleansing.
or
This
40.
type of cleansing is
Okay.
required. There should be no bacteria on the skin.
The
skin
video
should be
threads which we should use for the cheek should be
clean.
either 50
Then you
or
wear
60
your-
mm
first
needle.
you wear your
So that
gloves and
means
then you
the
do all
thread
these
size would be
things.
somewhere around
Then you
90 or
insert your
100.
mono threads.
Yeah.
Mono threads are
So here, like, okay,
inserted
if you're using this thread,
they are
like, okay.
inserted into the deeper duct. If they go into the subacute, they'll be wasted. So your plane should be very, very correct. When you're holding the thread should be such that you should not change the plane while inserting. Your plane should be uniform. So suppose you insert at this point, pull the skin and make sure that your hand is stable. So slowly you like with this comes with practice, of course. So mono threads are basically put in a crisscross. Like you put 5 threads. It comes in a box of 10 threads maybe. So you put 5 threads like this, 5 threads like this. So make a crisscross. So this will make a mesh work which will tighten your skin, and the texture of the skin would improve. It's very good for double chin also. No? So basically this will help in dissolving the fat also to some extent. So because it will release inflammatory. Basically, it works on the principle of wound healing. So when inflammatory mediators are released, so the skin would feel tighter. So this here also you would put 5 threads here like this and 5 threads like this, whichever way. So the direction does not matter. In cogs thread, like we were saying, direction matters. We have to see the vector. So we have to pull up the skin. We cannot put like this and pull. We have to put like this and then pull in this way. In mono threads, it does not matter. You put whichever way. So idea is to make collagen. They'll go into the skin. They'll initially up to 7 days, there would be release of inflammatory mediators, then slowly starts healing, start stimulating the fibroblast and produce collagen, and the skin would be formed. So this is how it is. So we'll first clean the thing. Is 6.5. Check. Okay, no problem. एक थ्रेड डालना है सबने वो बाद में और आ जाएंगे ना अभी अपनी हाँ आप एक बार ही खोल ठीक है Any questions you have about the thread, you can always ask. Post complications, if done properly, are not many. Only thing is there could be bruising because it's a blind process. So there are blood vessels all around. Of course, you are into the dermis, so there are no major blood vessels. All the blood vessels are deeper down. So if you hit deep, you can hit an artery or like vein. And the only complication would be if you're in the normal pain. First complication is pain. Patient would feel pain, little tightness, little soreness for a few days, and then bruising. But try not to bruise because for fillers, Dr. Arthur says if you bruise it, you lose it. So a person would always remember that there was so much of bruising. So make sure that if there is a social engagement, you make sure that you do the procedure at least 7 to 10 days before the social engagement. Suppose a girl is getting married in 7 to 10 days, avoid that procedure. So all aesthetic procedure, at least 15 days gap should be there from the D-day. Always make sure. So otherwise, so I need an alcohol swab. Alcohol swab है हमारे पास. Sterilium दे दो cotton पे लगा के मुझे so that because I have the habit of cleaning before putting. Yeah. For cog threads, you have to go to subcute. For subcutaneous, for cogs, you will go to subcutaneous plane. See here, for mono threads, we'll just clean the area. We'll pull the skin and then These are the mono threads. Threads किधर है mono? Thread दे दो. These are, we are not doing cork threads. Cork threads were done on the screen. Now we're doing mono threads. Mono hai na? Mono threads we can put whichever way. They don't need to be cut. Mono threads, they stay inside. We take out the cannula, and it is basically this is not blunt cannula. This is like sharp needle in mono threads. Blunt cannula is there in cork threads. There's a sharp needle. So what is, you can tell इसमें कितना है ना, 5 threads है, needle का size कितना है और thread की length कितनी है. So there are different lengths. These type of threads are also good for eyebrow lift also. So you can
29, 8, 25.
So then I'll show you. See, this is the length of the thread. Over there it is written 35. So this is, this is a sharp needle. All of you can see. Okay, and the thread is coming out. So you will put the needle inside. You'll spread like this. The bevel should be up, and you have to be intradermal. See, you can see the thread. You can see the needle. So you just keep a hand here and take it out. The thread would stay in. Needle has come out. Okay, and here is nothing. Sometimes you might see little thread visible. You can just cut it off. Okay. So one thread is gone. Now you can try. Whoever wants to try. Mono threads don't give much lift. They'll give firmness to the skin. Okay. So you can make a, for the purpose of the lift, you have to do cork threads. But they are very good. Suppose there is crisscrossing. There is a lot of you can say chicken skin kind of thing, open pores. So basically, they give a nice texture to the skin. Okay? Yes, we can. For eyebrows, they will help. So you can put threads like this. Okay, you can make like this way. Okay, so they will. For the neck, you would do 1, 2, 3, 4, 5. Then 1, 2, 3, 4, 5. So you can make a crisscross. 5 like this, 5 like this, or like this, whichever way. This way is better. Okay. So whichever way you comfortable. I am more comfortable doing this way. So I do this way and this way. Okay. So like you should be very comfortable while doing the procedure. You can go in any direction. We are not doing the lift here. For cork, the direction should be where our vector is going. Suppose there's a nasolabial.
Yeah, you may need
we want to reduce
more number of threads.
So our direction would be go inside, we'll pull it from here, it will be like.
The barb threads would stay longer because they are thicker. No? The barb threads definitely, the cork threads stay longer. Yeah. Yeah. Yeah, you haven't done, no? Come. You both can come this way. Yes. It's okay. It's fine. Goes. It's okay. Yeah. You have to? Yeah. No, the thread has. Sometimes you may see a little bit of thread projecting. Don't worry. If try pulling it, and if it doesn't go out, if it doesn't go in, you can just cut it off. Yeah. Now you have to like. Okay. You are going to put it. Yeah. You are a left-handed person. Yeah. Just okay. Whichever way you want to. Yeah. Okay, so you actually need further more pull here, no? Yeah, you can. Yeah, you can do.
This way or this way?
This way. Like, okay, so that again you are trying to pull it up. You want to come this way? It's okay? Yeah. You want... Okay. Yeah. Now you can. Yeah. So where will you like to put it? Okay. Yeah. You are a left-hander. You want to go that side? The size of the bigger one. Here they have only the smaller ones. That's why ideally when you're using for the cheek, use a bigger one. Use either 50 or 60 needle so that the thread length is either 90 or 100 because we need that much. It should be something covering the entire face. Okay. For the forehead as well as like you can even put a thread on the nose. It actually gives wonderful correction. Yeah. You can, sir. It's okay, no? Yeah. Nothing. It gives fantastic results even with like fillers. So this is the like okay, sir. Sorry, sir. Yeah, you can see still like okay, maybe we can actually put it like okay here. For actually there are no specific entry points or anything. You just need to give a proper pull. So just try pulling the skin and see which way it goes. Yeah, so you can see, no? Yeah, that's it. You are not seeing the needle, but you can see the movement. Okay. Yeah. Yeah. So. Yeah. 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 No, like okay, we are just sending the amount. Okay, don't worry. Yeah, finish it. Where? Oh. Okay, yeah, sure. Okay. Right. Yeah. So here already they have put in 3-4 threads. Here 3-4 threads. So now like okay, when you here we have done the coke, no? So we can see with the coke this correction has happened, but still we can see there is some kind of fullness happen. See, even the so this under eye also is better corrected. So here we can actually try to pull the under eye skin. So we can put in the thread here. Yeah. Okay. Good. That's the ideal way. Like, okay, you shouldn't exert too much pressure. Just put it in a like slender motion. Yeah. Yeah, you can put in the thread. Okay. Yeah, come. Yeah, we can. Yeah. The direction of the needle. Like, okay, he actually inserted this way. Yeah, and then pulled it out. No. That was actually the coke thread, no? Yeah. Yeah, you got that thread, no? So where do you want to put? Under eye. So under eye, you are not actually going too near the eye. Like, okay, always too near the eye, it's better to do the filler and Botox. So here you can actually try pulling the skin and do it here. Yeah. Actually, for the thread, there are no specific minimums or maximum. It's our common sense that works. So we know, like, okay, under there are so many blood vessels. So if you're going to, like, okay, poke and we are going to can injure on that thing. Even if there is an injury, sometimes it tends to remain that bruising can remain for long. Otherwise, there's no problem. Yeah. 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 Okay. Yeah, you can see the thread, but like, okay, you can see the movement, but you are not actually seeing it. That's a correct step. Yeah. Fine. So depending on minimum charge, so how much the company is giving for you, charge double or charge double or triple. That's it. Yeah, it no. Always yeah.
We are running short of time.
Okay. Yeah.
Those who have done, you can send someone.
Yeah. Yeah.
45 candidates. वो session पे चल रहा है.
Yeah, just see like if there is someone outside. Yeah, this is fine. Yeah. Yeah. Okay. Yeah, that's fine. Yeah. You don't have to never try just like okay again putting in the cover because that's a time when you actually tend to injure yourself. You should always have a thermocol piece there. Stick the needle into it. Yeah, that's the safest way. Since like this is a very small thread, there is actually I'm not giving any spacing. Otherwise, ideally, if it's a bigger thread, you can actually space it into. Okay, since it is a very small thread, try inserting as much threads. Fine. Jawline, you can actually insert along the jaw. That's that also again depending on you can insert above and below. One above, one below, one along the jaw. Also you can do. I do PDO. Like okay, you can. Yeah, superior lateral. Yeah, you can put in. That again depends on your expertise. That's the most important thing. So whenever you start with a thread, always start with a simple PDO thread. See, and like okay, once you get the proper experience of putting in the thread, no, then you start with the core. Yeah, that's it. Now you yeah, withdraw it. Yeah. So here, like okay, you want to give a pull this way, no? Yeah, you can actually put in the thread like that. Yeah. Multiple threads. These are the kind of threads which we use for the double chin or the eyebrows. For the face, you need a bigger thread. Double chin, you can do the crisscross. Like you can put one thread this way, one thread. Yeah, this is fine. Yeah, the plane is fine. Hold on to the guard and pull it out. You can put in one thread this way and from both the sides. Yeah. Okay. The NLF, you can actually put in one thread along the NLF and then threads crossing the NLF. How many are there? 2. Yeah. Send them also in. Yeah, send them also in. Yeah. Yeah. NLF, like okay, see, you can actually, what happened?
Guard has been pulled out.
No, sorry, give her another thread. Don't try to manipulate it. Yeah, just like okay, uplift. Give me one more thread, one small thread. Is there? Yeah. Yeah. So just no need to touch the guard. Like okay, you can just always make sure, just see it. Yeah, so you know it. So if you specifically want to correct the NLF, you can actually put in a thread along the NLF and then put in threads to cross the NLF. Okay, so that way you can correct. So since I have done one thread, like okay, for his eyebrow here also I'll do one thread. So you can see like okay, you hold on to the eyebrow and you can start from the eyebrow. See, just you go in like this. Yeah, you can see the thread going in, but you are not seeing the threads. Just pull it out. That's it. That again depends on the sagging of the eyebrows. Yeah. So next. So where would you like to put the thread? You have to decide. We have put in cork here. We have put in lot of like okay mono here, but still when you compare, you can see this. You can see this part of the face is looking. See and like decide. Left like okay. So left like okay. So we need actually more threads in this area. No? So you can put in from here. Yeah, this. Yeah, thread, that is the thing. Like you get an instant effect because the thread passing through the tissue gives a firmness. So that kind of firmness we can see. That's why I said always do on one side and give the mirror to the patient so that they can pull and compare. Cork thread. Because it has got the cork spokes which is actually attached, anchored to that. Yeah. Okay. Okay. I think they both can put in and then we'll discuss. Yeah. Yeah. We were thinking okay, we want to pull here, no? So you can put in here. Yeah. Yeah. Don't exert too much pressure. Just put it in a simple sliding motion. Yeah. Put it in. You're going in the correct direction, correct plane. Yeah. That's it. Hold on to the guard. Pull it out. Yeah. Pull it out. That's it. Sometimes some of these patients may have that kind of dimpling or something, massage along it. Sometimes some of these threads may come out. If it comes out, comes out. If it's slowly like a symbol end is projecting, you can just cut it off. Yeah, you can. So where would you like to? Yeah, okay. The thing is, normally it's not like that, but since this is a simple small thread, no, that is why. It's okay. Yeah. No, that's why okay, we have a guard holding it there. That's why it's not like a. Yeah. Go. Okay. Yeah. Just you are going in. Yeah. Hold on to it. Pull it out. What can happen? What can happen? It has to get dissociated. It has to lead on to collagen formation. That's what we want. So there's nothing to worry. It's not like the filler getting okay displaced or anything. Let the thread be there. It induces collagen formation. That's it. We can do definitely. Yeah. This is simple mono thread. Yeah. This is a very small thread. The usual thread we should be using should be 50 or 60 mm needle size. Okay. I think the hands-on is done. Yeah. Okay. No. The 50 or 60 mm, if you are doing it, always put in the first thread from the corner of the mouth in this direction. Then put in one thread from here to here, one thread from here to here, then one thread this way, one thread this way. So you are actually directing all the 5 threads towards the superior lateral cheek apex. And then you get a better lift. Then see if any other areas need to be specifically correct, then correct those areas. Entry point, yeah, okay. So one from the corner of the mouth here, one from the mid nasolabial fold, one from the mid narrow neck line, and then 2 from the jaws. Okay, that's fine. But if the patient has more sagging, we definitely need more number of threads. But this is a basic thing, and on that we can actually further work and increase the number of threads. Okay. That's why you see an immediate effect, but the full effect would be set in when the collagen gets deposited. And how many days? Yeah. So it would take, anyway, the effects start appearing between 3 to 4 weeks. However, sir, it's fine, no? Yeah. So now see, okay, we can see. Now both the sides look almost the same, no? Since we put in so many number of threads here. Yeah. So, yeah. When we give photos, we don't give in this area. Why we can't give in that area? We just avoid the mid-pupillary line. That's only. Otherwise, we can see. Yeah, that's. Otherwise, this area we can give. And if you're so worried, you can give the mesobotox, the microbotox, dilute it further.
Sometimes the lines are prominent. Sometimes this area the wrinkles show more.
Yeah, there you can even. Yeah.
So we can put threads here.
You can put threads, or you can use microbotox. Better. Mostly threads actually work better for the skin sagging, the looseness of the skin. Yeah. So, okay, I need to clean these markings. Yeah. Age group for? There's no cutoff. There's no such thing. You can start in a 15-year-old or even a 18-year-old whatever beat. Okay, because what exactly is the thread? This is actually polydioxanone, which we use in surgical suture. So surgery is done in all the age groups. It's the same way. Yeah, 50 mm or 60 mm needle size. The smaller? These smaller ones we can use for the double chin as well as for the eyebrows. Best. Agar.
MRP of mono thread is 6,000 and single packet is 4,500. If you order in quantity, you get better prices.
$9,000. So you can charge the patient. Yeah.
If you go on quantity,
That is 4,500 for a packet of 10 threads. That means 450 for a single thread. So you can tell the patient like, okay, 1,000 for one thread or something like that. That makes your job easier. So it's easy to calculate it. Yeah. So I always tell the patient the amount in like, okay, the number of threads. So that actually makes the calculation. So they also get a better idea. So the next time when they're doing only single thread, okay, just pay like, okay, 1,000 or 2,000, that's it. If you feel like, okay, the patient had like, okay, chance of, so thank you. Yeah, it's done. Okay. Yeah.
How long does it take?
The effect lasts for 6 to 8 months. Months. Yeah.
And the results are after how many days?
The results, if you see a fullness now, which would be better in like, okay, in a 3-4 weeks time, and it would, yeah, and it sets in finally like in 3 months time. Okay.
जब जहां जहां पे हम सही जा रहे हैं बिल्कुल कोई ब्लीडिंग नहीं है, कुछ नहीं है. जहां पे हम थोड़ा ऊपर नीचे, देन देयर इज अ साइन. कितने हो गए? हो गए. चलो, आई थिंक वी आर हो गया. बस और तो नहीं, एक और लॉट है अभी. बस ठीक है, ठीक है, ठीक है. फिनिश ना. थोड़ा इंस्टेंट लिफ्ट आता है. डालो डालो. हाँ, overall generalized face rejuvenation. These are basically for rejuvenation. Your face looks, करो करो निकालो बाहर. Face looks rejuvenated. आजो. Yes. We can do it again after 6 months. Rejuvenation, collagen building, tightening. Tightening as in firmness to the skin. Firmness to the skin. The skin would feel better, firmer, supple, all those things. Pore tightening, less open pores, less acne. Yes, it works for open pores because skin stretch हो रही है ना. Lot of open pores क्यों होते हैं? Loss of collagen है ना, तो collagen बन रहा है तो open pores कम होंगे. Yes, definitely will help. ठीक है, डन. एनीबडी लेफ्ट? आ जाओ आ जाओ. इधर डाल दो, यहाँ डाल दो, ऐसे डाल दो. पेरीओकुलर, वो अरे थ्रेड्स ही खत्म हो गए. थ्रेड्स ही इतने थे. अब यहाँ पे डाल दो, यहाँ पे डाल दो. फॉर बिगिनर्स इट विल बी लिटिल डिफिकल्ट, इसलिए मैं करवा नहीं रही. यहाँ पे डाल दो. Periocular, you can do threads, but there would be a lot of bruising. So there are so many blood vessels. So it is not safe to do threads around the eyes. So I normally stay outside orbital rim. ठीक है? Stay outside orbital rim. बेटा थोड़ा सा बाहर रह गया. कोई बात. हाँ जी. 5 here, 1 centimeter के डिफरेंस पे डाल दो. 5 से ज्यादा भी डाल सकते हो. 10 इधर डाल सकते हो. आपके पेशेंट की अफोर्डेबिलिटी पे डिपेंड करता है. यू कैन से मिनिमम 10 ऑन ईच साइड. मिनिमम 10 ऑन ईच साइड. आ जाओ. आपका प्लेन गलत था, ज्यादा सुपरफिशियल हो गए थे आप. आ जाओ. इधर से डालो. हाँ जी. नेजोलेबियल फोल्ड में कॉर्क थ्रेड फिल करो, नॉट दीज थ्रेड्स. हाँ जी हाँ जी, कहीं भी डाल दो. हाँ जी डालो डालो. एक बेवल करो नीचे. बेटा इसको पहले पुल करो. ठीक है ना. पुल किया, इसको एक बेवल अंदर डाला है ना, और स्ट्रेट हो गए. हो ही नहीं सकता गलत अगर आप ऐसे जाओगे तो. कितने आराम से जा रहा है. एंड टेक इट आउट. चला गया आपका थ्रेड. ठीक है ठीक है. Whoever is left, I have to rush back to Amritsar. Bhai. हाथ डालो फटाफट. Done. नहीं बिल्कुल भी नहीं. मैं भागू अब. हाँ जी बस ये एक ही रह गया. Done. ठीक है बिल्कुल ठीक है. Put it hand here, put a finger here and just quickly take it out. See, it's right. Up डालो.
There was a feeling that if I cross the skin, that won't happen because it is flexible, not like that.
No, it's a flexible thread.
वो
देखो ना. अपने ही घर वालों को टॉर्चर कर रहे हो कॉन्फ्रेंस के लिए. देखो कितने वो दुष्ट हो तुम. दुष्ट नहीं है बहुत ज्यादा. नहीं अच्छा मेरा बड़ा प्यारा बच्चा.
लास्ट में सब भागे, फैकल्टी भागे, सब भागे. मैं क्या करूं?
देखो आपने मेरे को ना वो करा दिया. मेरी मदर इन लॉ से अब मुझे डांट पड़ने वाली है बहुत जबरदस्त कि रात को मुझे 10 बज जाने घर पहुंचते हुए. चले जाओ स्ट्रेट. बस ठीक है. इस पे फिंगर रखो. That's it. अल्कोहल स्वैप से क्लीन करो एंड वी आर डन. ठीक है बाय. हो गया.
थैंक यू सो मच.
थैंक यू.
फोटो तो हमने ले लिया ना.
मेरे को जल्दी से एक चाय दे दो प्लीज. चाय एक जल्दी से दे दो. आई टू रश बैक.
Facial artery. So sometimes you can go in through the facial artery. What can happen? Sometimes there can be bleeding. Sometimes there can be hematoma formation, but nothing major. It will just. Go full length. Yeah. This is transverse would be better. In a horizontal direction would be better. Okay. Now, like okay, 2 of you, 3 of you. Okay. So this direction. You can see one thread this way, one thread this way. So you can maybe put something midway like yeah. Everything, it's done now. Done. Everything done. Yeah. Yeah, we can do. Why should we? We don't have to actually. We can even do one on top of it. Nothing is going to happen. You don't have to be so specific about it. Yeah.
You overwrap the thread.
Nothing. It gives a better collagen formation. Okay. You wanted a video? Yeah.
Suggest to my neck actually.
At least, please, 1 minute. Don't talk. Like, okay. You're like, yeah, it's fine. Yeah, after that, we'll talk. Okay, take it out. What are you worried about your neck?
Neck I require threads only or something.
Actually, you don't require anything.
Photographs are very bad. Neck
No, the thread would actually make the more collagen deposition, but your problem is not exactly looseness. You have got more of those horizontal bands. Yeah, you can like okay, you can go this way. Okay, done.
Local anesthesia is needed.
Actually, you don't need. Topical is enough.
No, topical is needed.
Yeah, topical. Some people wouldn't need it. Okay. You all are from different places. You're from Bangalore, Chandigarh, Chennai. You both are from Chennai. You're from Kerala. And you're from Bangalore.
Thank you for the wonderful session. I hope they got like double chin it's not.
You don't have a double chin, please. You have got a little bit of body dysmorphia. You don't have any problem. Come on. You don't have it. Okay. So, yeah, you can put in one thread. Yeah. Your chin would vanish. Yeah. Yeah. Okay. You just put one in the center. Okay. Yeah, that's correct. Medicine. Yeah, okay. Definitely, please come. Okay, yeah, go. Yeah, it's fine.
It's just
No. Sorry. It's okay. Yeah, okay. Yeah, hold it up. Yeah, please. Nothing is going to. The only thing is like we get a proper effect when we are at the correct depth. Yeah. So I should remove the gloves. I think please click a picture with all. Yeah. Sorry. Yeah, your neck is done. Yeah, you also be this. Yeah, come. Yeah, I think you can click a picture. You also come. Yeah, Dr. Aishwarya also come with us. Yeah, all of you can just please don't fall down. Yeah, please do join us for check. Yeah, come. Yeah, okay. Yeah.
Thank you.
Yeah. And okay. Yeah. You should all start threads. Then only it becomes like okay. Yeah. Yeah. So, oof. I think it's all done, no? Yeah. Done. Everything done, no? No, maybe I'll take it home.
Recording stopped.
Thank you all for your patience. So finally, we begin the award paper session. The PG students have been waiting since a long time, but we had a very tedious day with very long workshops, and we had to extend the time for the workshops because SODC believes that every candidate who is chosen for hands-on should definitely get some hands-on. If it is a filler, he should get the feel of the product. If it is Botox, they should at least inject 10 to 15 units. And if it is threads, they should at least insert one thread. So finally, I'm starting with the award paper session. So I have the superwoman which has turned up since afternoon, who has helped SODC. And I guess it has been very hectic for ma'am, but ma'am is the only and deciding factor and the judge for all of you. Ma'am is very strict in marking. So what are the rules for the award paper session? The total time duration is maximum 8 minutes. There will be a reminder after 6 minutes. At 8 minutes, the screen will go blank. There will be always a soft corner for the aesthetic papers. This was always informed. We have accepted some papers which were clinical, but there will be always in SODC a soft corner for the aesthetic because it was SODC aesthetics. So first paper, we have Dr. Amisha Mahajan.
Good evening, everyone. I'm Dr. Amisha Mahajan, and I have a clinical paper here on warts, a problem which we face so commonly in our practice that we have these warts which are recalcitrant and recurrent despite everything we do. So I did a study on studying the efficacy of intralesional bleomycin in warts. So there have been a few studies on intralesional bleomycin which have been found to be effective, and they have also been found to be effective in treating the periungual and palmoplantar warts. So bleomycin is an anti-tumor, antibacterial, and it has antiviral activities. So how does it work? It works by preventing cell replication. And there's this enzyme, bleomycin hydrolase, which causes its degradation, which is present in very little quantities in skin. So that is why, even by using very minute quantities of bleomycin, we are able to treat warts without a lot of side effects. And the bleomycin, it penetrates the cell membrane poorly. So what we do is the stock solution, we dilute it with lignocaine. So it gives us the benefit of decreasing the pain as well as giving us better efficacy. So the aim of the study was to assess the efficacy of intralesional bleomycin in common warts. It was an open-label, uncontrolled, non-randomized study. We took 50 consecutive adult patients of common warts who had warts over the dorsal aspects of hands and feet, palms and sole, periungual areas. We did not include anogenital, plain or filiform warts. We included all the recurrent and resistant warts in our study. Pregnant and lactating women, patients with apparent skin infection on the site of warts, and history of Raynaud's phenomena, they were excluded from the study. So bleomycin comes as a 15-unit vial. It's a dry powder which is dissolved with 5 ml of distilled water. So that is a stock solution which is made. That stock solution, it can be preserved at 2 to 4 degrees in the fridge easily for 1 to 2 months. So we took one part of the stock solution and diluted it with 2 parts of lignocaine. So we reached this concentration of 1 milligram per ml. And after, cleaning the warts, we injected the warts with bleomycin until we reached blanching of the lesion. So the sessions, they were repeated after 3 weeks for a maximum of up to 4 sessions, or till there was clinical or dermoscopic clearance if it was present earlier. So the results, they were evaluated by comparing the clinical photographs, and the dermoscopic evaluation was done. The patients, they were followed up for up to 6 months for any recurrences. Any side effects, they were noted. So our criteria, our clinical criteria of complete clearance was complete disappearance of warts, and the dermoscopic criteria of complete clearance was return of the skin markings. So these are our results, in which we had 2.1:1 ratio, male to female ratio we had. We had these number of warts, which ranged from less than 5 to more than 10 warts per session that was done. We had 96% clearance, and there were only 2 patients who did not respond. 1 patient was a complete non-responder, and 1 patient was a partial responder. There was 1 patient who had recurrence after 2 sessions, but this patient did not reach complete dermoscopic clearance and did not follow up. But when we did further sessions of bleomycin, even for this patient, so his warts completely cleared. So these are the clinical pictures in which you can see that the warts have cleared up. In these, you can observe here, there's no wart present dermoscopically here. Another patient who had been putting corn caps and not responding to any treatment. So with treatments, there was a complete clearance. These are a dermoscopic picture. It's not very clear here, but you can see the dotted blood vessels which are present. So they were not present after 2 sittings. The side effects we observed, there were more immediate pain. There was a scar formation which came after 1 to 2 weeks, and resultant post-inflammatory hyperpigmentation which resolved over the due course. So when we compared it to rest of the studies, we had a higher male to female ratio. The different studies, they showed cure rate ranging from 74 to 96%. My study had a cure rate of 96%, and we went up to a maximum of 4 sessions. Other studies, they varied from 2 to 5 sessions that were done. Pain, as you know, earlier we have this thought process behind bleomycin that it is a very, very painful injection. But what has been found in recent studies is that it's not that painful. There is an immediate pain which can be taken care with the local anesthetic, which is mixed to improve the penetration of the drug. But post the procedure, most of the, like in my study, none of the patients complained of a pain after 1 to 2 days. And even that was not very significant. In my study, none of the patients required administration of diclofenac or paracetamol to help them with the pain. So to conclude, intralesional bleomycin is a highly effective and safe treatment option in common warts. There are high cure rates, no significant adverse effects, and most importantly, minimal chances of recurrence. The limitations of my study were small sample size and a lack of control group. So I hope all of you who are facing the same problem in your practice, in which you have these recurrent and resistant warts, you can go back and give this a try and get good results in your practice. Thank you.
So I just got the message from the lobby that the iPad has arrived. So next is, why is everyone surprised? The best, we have only 1 award, and the best paper will win an iPad. So the second is Dr. Ajay.
Yeah, good evening, everyone. My name is Dr. Ajay, and I'm going to present this glutathione as a skin lightening therapy in cosmetic dermatology. Introduction. Many countries in South Asia and many countries in South Asia and Southeast Asia, glutathione gaining more popularity in the uses of skin lightening agents and a potential antioxidant in Asian dermatology and cosmetic uses. And glutathione is a combination of 3 amino acids, that is cysteine and glutamic acid and glycine. It is involved in the detoxification of the both xenobiotic and endogenous compounds. It's a low level of the glutathione and transferase activity are also associated with the chronic exposure to the chemical toxins and alcohol, cadmium exposure, HIV, and macular degeneration, Parkinson disease, and other neurodegenerative disorders. Glutathione directly scavenges diverse oxidants, superoxide anion and hydroxyl radicals, and nitric oxide and carbon radicals. Glutathione catalytically detoxifies hydroperoxide and peroxynitrite and lipid peroxides. And it comes to the mechanism of action. It inhibits the tyrosinase, that is enzyme for the melanogenesis, and direct inhibition of the thiol group binding with the copper and copper-containing active sites in the enzyme. Switching production of eumelanin to pheomelanin. Modulation of the depigmenting properties of the other anti-melanotic principles, and direct inactivation of the tyrosinase enzyme. Tyrosinase, that is a key enzyme for the melanogenesis, by binding with the copper-containing active site of the enzyme. And a direct chemical neutralization of singlet oxygen and hydroxyl radicals and superoxide radicals. Vital to the mitochondrial function and maintenance of the mitochondrial DNA. Regeneration of the vitamin C and vitamin E. Regulation of the cellular proliferation and apoptosis. Then comes to the indication of the glutathione in cosmetic dermatology, as many of you are using. One is hyperpigmentation. This is the main. Melasma, post-inflammatory hyperpigmentation, and post-acne hyperpigmentation, and PDL, pigmented dermal lines. This is the conversion, interconversions of the glutathione. This is reduced glutathione to oxidized glutathione with the with the help of ATPs and ADPs. Then when it comes to the doses, it can be given 20 to 40 milligram per kg body weight per day. That is 1 to 2 grams GSH per day, divided into 2 doses for the skin lightening effect. Time duration required for the skin lightening effect may become visible within 4 weeks, but longer duration may be required for the better results. It can be taken as a couple of months and maybe 2 years in the medium or brown skin, dark brown skin, and very dark skin, and black skin respectively. Then comes to learning objectives. Presently, there are lack of robust evidences in favor of glutathione for the treatment of hyperpigmentation. The mechanism of action favors its potential as a skin lightening agent. Few randomized controlled trials have been conducted so far, but the short-term follow-up period. These studies support some skin lightening effect of topical as well as oral glutathione. The safety profile of the topical and oral glutathione seems to be reasonable. Thank you.
So the next candidate is Dr. Arpita Hassan.
Very good evening to one and all. So my work and presentation is going to be on improving the structural and cosmetic outcome in burn scars with combinations of procedure. So it's one of the most difficult scenarios to treat in our clinical practice. All of us know that. So coming to the introduction, burn scars are the most severe form of scarring in clinical practice, associated with significant morbidity in the form of itching, pain, stiffness, and contracture. The functional and psychosocial morbidity remains a major rehabilitative challenge, decreasing the quality of life. The most common scar formed following a burn is the hypertrophic scar, and the prevalence of hypertrophic scar is as high as 70%. So the mechanism of hypertrophic burn scars goes like this. So the wound healing mainly occurs in 3 phases, all of us know, that is inflammation initially and then proliferation of the cell. Again, it gets remodeled, like, whatever you don't need excess in the body goes off, and whatever needs to be there, that retains. Whereas in burns, so there is a dysregulation, there is activation of deep dermal fibroblasts. So these are the larger fibroblasts, proliferate slower and produce large quantities of collagen and inflammatory cytokines such as transforming growth factor beta and synthesize less collagenase. So as a result, there is disorganized bundles of collagen which are cross-linked tightly, while type 1 collagen expression is reduced and type 3 collagen is over-synthesized.
So the aim of the study is to improve the structural and cosmetic outcome in burn scar with a combination of intralesional steroid and CO2 fractional laser and platelet-rich plasma therapy. So the methods were like this. 7 female patients and 1 male patient aged between 24 to 48 years were enrolled in the study. So duration of the scar was ranged from 2 to 3 years, and assessment of the scar was done including the history, site of involvement, and Vancouver Scar Assessment Scale in terms of pigmentation, vascularity, pliability, and scar height. So this was the Vancouver Burn Scar Assessment Scale, and so this was like before the start of the treatment. So the most common areas involved were chest and neck, and also the hands, and in some people, back was also involved. So coming to the methods, intralesional triamcinolone was given in the dose of 20 to 40 mg every 3 to 4 weeks for about 2 to 3 sessions till the thickness and the hyperpigmentation of hypertrophic scars was reduced. The procedure was carefully carried out to avoid injection to the atrophic and hypopigmented areas. So that's very important, because otherwise inadvertent injections of steroids, you end up having more atrophy and hypopigmentation. After 3 months, once the hypertrophic areas were stabilized in the form of thickness and pigmentation, fractional resurfacing laser, that is CO2 laser, was carried out. So before the laser procedure, topical anesthetic cream EMLA was applied 1 hour prior to the procedure. A combination of CO2 laser in Fraxel in the energy, the fluence, that is 18 to 22, and stack 1 was done over the scarred areas along with PRP injection, that's about 0.05 ml. 0.5 centimeter apart, like that is what, like slightly closer injection, and the half the dose which compared to the normal PRP you do. The procedure was repeated every 4 weeks for minimum of 3 to 4 sessions. And there were also additional procedures which were carried out, like manual dermabrasion and microneedling was done in the areas where there was predominant atrophic and dyspigmented areas. So in sometimes you also have like there is no hypertrophy, but you have like some hypopigmented atrophic areas, and you have just plain hyperpigmented areas. So where this procedure was carried out, the abraded fragments of the epidermis, we did not like wipe it off. In fact, like it was spread over the whole area, and the platelet-rich plasma was topically applied to these abraded areas for providing a scaffold for cell migration, and the areas were covered with collagen dressing. Okay. So the treatment of scar bands was also carried out, like, the contracture scar bands, these also like, they pose a significant psychosocial morbidity. So this was ablated with CO2 laser in ultra pulse mode to enable healing and blending with the surrounding skin. So you can see the pictures. So where in the margin of the scar bands have done the ablation, here you can clearly see. So the results goes this way. All the patients completed study at 24 weeks. Vancouver Scar Assessment Scale showed significant decrease in hyperpigmentation from a mean value of 1.75 to almost 0. Improvement in pliability from a mean value of 3 to 1, and scar height, that is the scar thickness, from a mean value of 1.25 mm to 0.5 mm. There was significant decrease in the baseline. I mean, this was the overall score. So decrease in the score from mean value of 10.2 to 2.8. So this is before, like the red line is before, and then the brown line is after. So just to go with the before and after. So this is before and this is after. And this is before with a lot of contracture, hyperpigmentation, hypertrophy. So that was during the procedure. So this was after. So this is where I did derma abrasion along with like PRP dressing and collagen dressing. So this was before, and this is after. So you can notice that the atrophic areas have completely subsided. There's significant improvement in the pigmentation. And also this is before, like in the hands, and this is after. So the summary, intralesional corticosteroids are thought to modulate many aspects of hypertrophic scar development, including decreasing collagen synthesis, attenuating proliferation of fibroblasts and keratinocytes, reducing oxygen and nutrient delivery via vasoconstriction, enhancing the collagen degradation by activating collagenases within the wound. So the fractional CO2 laser columns, with fractional CO2 laser, columns of abnormal scars are ablated, allowing new collagen to form in a controlled manner with the rapid reepithelialization of the surface. Recent studies also showed that in addition to apoptosis of fibroblasts in these microthermal zones, the hypertrophic scars undergo upregulation of matrix metalloproteinase 1 with alteration of type 1 and type 3 procollagen, which is altered, we know, okay, and downregulation of transforming growth factors. So platelet-rich plasma, as all of us know, it is rich in growth factors, leukotrienes, and other inflammatory mediators, which help in regenerating new cells, alter dermal collagen in a more effective way, helping to restore normal skin and subcuties. So in conclusion, combining different modalities in a defined sequence to address specific pathological component allows the provider to manipulate the burn scar and improve the specific characteristics such as thickness, redness, and stiffness, which in turn improves the subjective findings of texture, itching, pain, and pliability. So, so that's all about my presentation. Thank you so much. But I think the greatest thing what the burn scar victims say is like, the kind of happiness and the gratitude so they express towards you is the, major factor. Thank you.
So next is Dr. Arnav.
Good evening to all of you. My topic of presentation is comparative evaluation of therapeutic efficacy and safety of intralesional injection of triamcinolone acetonide versus intralesional injection of interferon alpha 2b in treatment of keloids. A keloid is a benign, well-demarcated overgrowth of the fibrotic tissue, and it extends well beyond the original boundaries of the defect. It is cosmetically distressing and sometimes can be painful or pruritic, and there is need for adequate and effective therapy, and researches are ongoing for the same. My aim in this study is to compare intralesional triamcinolone acetonide with interferon alpha 2b. So triamcinolone acetonide works by reducing collagen synthesis as it inhibits inflammation, and inflammation is implicated in modulating the collagen synthesis. It also reduces collagen synthesis by altering glycosaminoglycan synthesis and also reducing production of inflammatory mediators like IL-6, 8, 18, and fibroblast proliferation. Interferon alpha 2b works by increasing collagenase level by inhibiting metalloproteinases as it implicated in the collagen production. It is anti-fibrotic and anti-proliferative activity also. 20 patients of keloid were included in the study, and they were randomly divided into group A and group B equally. Of these, 12 were males and 8 were females. Group A was given triamcinolone acetonide intralesionally in a dose of 0.5 ml per centimeter square every 4 weekly with the help of insulin syringe for a total of 24 weeks. And group B was given interferon alpha 2b intralesionally in a dose of 1 million unit per centimeter square to a maximum of 5 million unit every week for a total of 24 weeks. Follow-up was done post-interventional at 6-weekly interval till 42 weeks, and evaluation was done at every interventional visit in TAC group and every 4th week in the interferon group, and also at every follow-up sitting by POSAs, that is patient and observer scar assessment scale and photography. Grades of improvement range from 0, that is no response, to very good response, and it corresponded to the reduction in the POSA score. Improvement was seen in both the groups with very good response in 5 patients in the TAC group and only 1 patient in the interferon group. Good response was seen in 3 patients in the triamcinolone group and 5 patients in the interferon group. Moderate response was seen in 2 patients in the TAC group and 3 patients in the interferon group, and mild response was seen in only 1 patient and in the interferon group. In this line diagram, where we can see the response of both the modalities, blue line is depicting group A treated with TAC, and red line is depicting group B treated with interferon. We can see the rapid and sustained fall in the triamcinolone group in the interventional period in the POSA score in comparison to the interferon group. But this trend, it like plateaus in the follow-up period for both the modalities. And same difference can be seen in the numerics in the right side in the table. Adverse effects were seen in both the groups, with atrophy was seen in 2 patients in the triamcinolone group only. Flu-like symptoms were seen in only interferon group in the 7 patients, and pain was seen in both the groups, and it was twice more common in interferon group than the triamcinolone group. And ulceration was present only in 1 patient. recurrence was seen in only 1 patient in the interferon group and 4 patients in the triamcinolone group. These are my pre and post follow-up photos, and the blue column showing the effect in the triamcinolone group and red column showing response in the interferon group. So to conclude, there was a greater mean POSA score difference in group A as compared to group B with respect to baseline, and adverse effects were seen in 4 cases in triamcinolone group and 8 cases in interferon group. Pain along with flu-like symptoms was the main side effect observed in interferon group, and so in the end, interlesional triamcinolone acetate has a better efficacy and safer profile than interferon alpha 2B with favorable effects seen in form of less recurrences in later group. And also interferon alpha 2B can be an alternative to TAC in uncontrolled diabetes mellitus and also as a steroid sparing agent. Thank you.
Next is Dr. Divya.
Good evening, everyone present here. Today, I'll be presenting a case series of autoerythrocyte sensitization syndrome, a syndrome which is not usually very well discussed, and usually it will produce a diagnostic dilemma in most of the cases. So what is this syndrome and how it is diagnosed? We'll be learning through this. So a brief introduction about the disease per se. As the name itself is self-explanatory, autoerythrocyte sensitization syndrome. In this syndrome, patients will be having sensitization against their own RBCs. It was first described by Gardner-Diamond syndrome, so it is named after them. And it's also known as psychogenic purpura because of its bruise-like presentation and associated mental illness in most of the cases. So how it is present? It presents with multiple painful edematous infiltrated skin lesions which can be either induced or can be spontaneous and isolated or multiple. These lesions will progress to ecchymosis during the next 24 hours, and the lesions are usually preceded by an episode of severe stress or emotional trauma, slight mechanical injuries, surgical intervention, and strenuous physical work. But in most of the cases, they can be spontaneous in development also. It is mostly seen in the women, like most of the cases that has been described are in women only, but isolated cases have also been reported in adolescent and males also. So now aim of the study is to describe the clinical presentation, psychiatric profile, possible triggers and response to therapy in the patients who were diagnosed with psychogenic purpura. It was a retrospective case series which included 9 patients suspected of Gardner-Diamond syndrome, and the baseline blood investigations were done to rule out any abnormalities. Additionally, coagulation profile, bleeding time, clotting time were all carried out for all the patients, and all the patients were subjected to intradermal testing with autologous erythrocytes. So how it is done? In intradermal injection, 0.1 ml of autologous washed RBCs was given on the flexure aspect of forearm, and on the contralateral forearm, 0.1 ml of normal saline was injected as a control. And at 24 hours, if the patient presents with a typical Gardner-Diamond syndrome like lesions, purpura edematous lesions, and then progressing to ecchymosis, then the test was considered as positive. So in the first picture, as we can see, on the left forearm, RBCs were injected, and on the right forearm, normal saline was injected. And we can see, and after 24 hours, there was presentation of purpura at the site of RBC injection. And the picture on the right, the patient had the symptoms on left thigh. The patient had lesions of Gardner-Diamond syndrome, and after that, autosensitization test was done in both the forearms, and it was positive. So the patients, total patients were 9 out of them. All were females, and the average duration of illness was 4.8 months, and average age was 28.4 years. And 4 out of 9 patients had concurrent psychiatric disease. 2 had depression and anxiety, and 1 patient had borderline personality disorder. History of psychological stress before the onset of lesion was seen in 2 out of 9 patients, and 7 patients complained of prodrome of pain, pruritus, or burning. Intradermal test positivity was seen in all patients except 1. And few patients also complained of other symptoms like abdominal pain, nausea, and headache. But interestingly, none of the patient gave history of trauma as a trigger factor. And a point here to notice is that routine investigations and coagulation profile was normal in all the patients. So these patients were treated including psychotherapy and SSRIs in 3 patients and psychotherapy in 6 patients. And post that, there was improvement in all of the patients. Now, coming to the discussion part, although there have been multiple theories that have described for Gardner-Diamond syndrome, the exact cause remains unknown. It basically is thought to be an autoimmune vasculopathy that arises due to sensitization to a component of RBC membrane, that is phosphatidylserine. And it is considered a rare disorder, and around only 200 cases have been reported in the literature. As I said, there are multiple theories that have come. One of them is autosensitization. Initially, it was thought that it resides in the RBC stroma, but the confirmation that what exact the molecule is, that was given by Glocketol. And other theories is that the disturbances in the kallikrein-kinin system will lead to the tonus irregulation of venous capillaries. And it also may be noted that abnormalities in the coagulation system or blood vessel development are usually not involved in the pathogenesis. But how, like most of the patient will tell that a psychological stressor influences that, but how it influences the physiological process and changes the immune reactivity with the formation of erythrocyte autoantibodies is still unknown. So how to diagnose this disorder? If the patient is a woman with a typical history of stress, trauma preceding onset, and typical lesions, painful erythematous, and ecchymotic lesions with systemic symptoms, and there is a frequent association with mental disorder, and positive intercutaneous test will be seen. Patient will be having normal coagulogram, and histopathological changes are not specific, so usually it is not indicated. So soft pointers of diagnosis: the recurrent episodes of classical lesions with psychiatric disease with absence of hematological and coagulation abnormalities, and positive intercutaneous test will help reaching the diagnosis. So treatment, no method of treatment is actually sufficiently effective in this disease. It's been described in the studies that initially, if we give oral corticosteroid along with the symptomatic treatment, that can help in patients. Plus, the patient, as I said, there is mental illness in most of the patient. So for that, we can start with TCA and SSRIs. There have been reports where there is complete remission of Gardner-Diamond syndrome occurred after the antidepressants. So overall prognosis is quite good, and the patients can have relapse and remission in later life, and may last for several years, and severity may considerably fluctuate as well. So the take-home message is that the syndrome is rare. It is said that only 200 cases have been described till now, but we can conclude from this presentation that possibly it is not so rare, and maybe it is underdiagnosed and underreported. Because most of the times what we will think, patient will be having mental illness, and when we will think that the patient is either malingering or the lesions are self-induced. So we will mostly ignore, and most of the cases, patient will also be following it up in other department and undergoing a lot of investigations for their purpura, and there will be a lot of unnecessary investigation would be done. So what we need right now is we need a higher index of suspicion, and whenever a patient comes with painful recurrent bruises without any history of trauma and with all the negative hematological and normal coagulogram, we should think of this disorder, and the patient actually needs both psychiatric and dermatology consultation for the same, and the patient should be treated accordingly. Thank you.
Next is Dr. Nivedita.
Good evening, everyone. Respected chairperson and my dear colleagues, it's a privilege for me to talk on collaboration over competition, how integrative aesthetics can achieve a patient's goals. The most common reasons for patient dropouts from aesthetics is the therapeutic fatigue. Patients often say, "Doctor, till when do I have to continue the treatment?" Exhaustion of resources. In case they have to repeatedly do temporary treatments like injectables, they feel like it's not worth it. Inability to predict the end of the treatment. If we can call it a therapeutic endpoint, I don't think it exists in aesthetics. Introduction. The integrative aesthetics involves a combination of non-surgical and surgical approach to the patient's management right from their first visit. It's like having a combined dermatology and plastic surgery OPD for patients who are seeking long-term solutions to their aesthetic concerns. A very common non-specific complaint which comes across for us in our OPD is about looking dull. But this dullness is not attributed only to the texture or tone of the skin, but also to the underlying structures and anatomy of the face. There is a discordance between a patient's personality and how they look externally. Often the patients, they say that their face does not match their personality. They are very happy, chirpy people, but the face is little sad or unhappy or angry kind of look. So if we chart out the aesthetic goals in the first visit, it gives them a roadmap and approximate expenses incurred over a period of time. I present a case series of 5 patients in whom our approach was integrative aesthetics from the first visit itself. Ours is an integrative aesthetic practice where selected patients are booked for combined consultations and they are presented with both surgical and non-surgical options in the first visit itself. We also emphasized on performing the most effective first step in improving their appearance. It could be either surgical or non-surgical, and so that it gives them a confidence and it makes sure that it is worth their time. Case 1 is a 22-year-old female whose primary concerns were dark circles. She was unhappy with her overall facial aesthetics. She was a self-confessed geek who did not like to look in the mirror. In fact, it was her first aesthetic consult for anything. She had not even gone to a parlor before. And her mother had brought her saying, please give her some cream so that she will look better and it will increase her confidence. So the counseling in the first visit that we did, it was about full face optimization with the fat transfer. We wanted to inject a little lip filler to rebalance the lower face. She definitely needed a rhinoplasty and overall skin tone improvement with laser toning and peels. We told her that we are going to follow up with maintenance with topicals and antioxidants. This is 6 months after the first session of full face optimization with fat transfer and bi-monthly laser toning. So you can see a lot of difference has happened in her face and she's looking much better. In fact, she was so motivated that she went on to do rhinoplasty after that. And this is the look after 1.5 years. She has a new outlook towards life. She's self-confident. She has signed up for more procedures like LHR, lip fillers, laser toning, peels, and she has become our biggest fan. Case 2 is a 29-year-old female whose primary concern was acne scars. She couldn't opt for multiple sittings of lasers and she had to join a new job in a new city within a month's time. So she needed maximum possible results before that. So we performed an acne scar subcision and we did a facial fat transfer on the mid face, on the chin, and we did a micro and nano fat transfer to the acne scars. After 20 days, we also did a retinol peel for facial rejuvenation. She has not allowed us to show her entire picture, so we are just showing the part in which we've treated the acne scars with integrative aesthetics. Case 3 is a 32-year-old female, a mother of 1. Her primary concern was she complained of looking older than she was, a disapproving, angry look, which affected her chances of getting a job. She wasn't getting a job in the front desk or hospitality industry because of that. And she had a few acne scars. What we did for her was an upper and a lower blepharoplasty, a buccal fat pad removal, and a fat transfer to the mid-face, temple, chin, along with CO2 laser for textural improvement. So what we can see is a softer features, slightly more pleasing appearance, skin tone and texture is improved. And even she is happy. We've not changed a lot of her look, but overall appearance has improved. Case 4, her primary concern was acne with PCOS. She had a depressed look on her face, which did not match her exuberant personality. The first step was management of acne and PCOS. So we made we did counseling for lifestyle modification, and instead of only going for the tablets, we told her that exercise, lifestyle modifications, supplements like myoinositol, they started clearing up her acne, and only some PIH was left. But what happened is now she knew that the theater of deformity is quite glaringly visible. So this is post-operative day 7. We have done an upper eyelid blepharoplasty. We have done under eye, mid-face, perioral, and chin fat transfer. And she got a very good response. After 3 months, there is a little bit disappearance of the fat. So she may need another touch-up session for under eye fat transfer. But this is the results. This is a case 31-year-old single mom wanted to restart her career as an anchor. She felt like she looked older than her age. Forehead skin showed sagging. So lower blepharoplasty, mid-face, temple, and chin fat transfer showed overall rejuvenation with micro fat and nano fat transfer, CO2 laser for wrinkles and under eye rejuvenation. These are showing us natural appearing results, and we did a long-term follow-up with topicals. The disadvantages in practicing integrative aesthetics is that it is time consuming. So we used to plan the consult in the morning or during non-rush hours. It was overwhelming for some patients in the first visit, and there is a difficulty in availability of both the doctors at the same time. The conclusions are that integrative aesthetics, like combined management, can create a paradigm shift in achieving the patient's aesthetic goals, and it reduces the therapeutic fatigue. Patients can plan their downtime, their resources, and their social calendar with a clear-cut game plan to achieve their aesthetic goals. Collaboration over competition, so that we get the best of both worlds amongst dermatologists and plastic surgeons, and we can use each other's strengths to give the best possible results. In fact, combined consultations can provide the patients with varied options. The realistic expectations can be aged with a combination of best rational treatments. Emphasis should be given on what the patient needs instead of only what the patient wants. It is cost effective for the patients who want to avoid temporary treatments over a period of time, because fat transfer and they are permanent solutions. Thus, I would like to say that integrative aesthetics can create sustainability in achieving patients' goal within the resources. And as we are moving towards a more sustainable outcome, these are the patients who are going to go out into the public and recommend us, because we have given them a more natural, holistic, and long-lasting look. Thank you so much.
So next we have Dr. Neetu.
A very good evening. A very good evening to respected dignitaries, judges, and my professional friends. Today, I am standing here to present on my study, that is comparative evaluation of therapeutic efficacy and safety of mandelic acid peel versus salicylic acid peel in mild to moderate acne vulgaris. Acne is not only a cosmetic deformity. These are also the bumps on the soul of the patient. Various modalities have been used, including chemical peeling, which is an effective modality, especially when the patients are not willing for the topical messy preparations and oral acne medications daily. My study is to compare mandelic acid peel with salicylic acid peel in terms of efficacy and safety. Chemical peeling works by doing injury of the skin at the required depth, leading to the stimulation of epidermal growth and fibroblast modulation that results in collagen production and remodeling of skin. As all we know that salicylic acid reduces corneocyte adhesion and is keratolytic. Because of its lipophilic properties, it penetrates into the sebaceous follicles and hence is helpful in acne. Talking about the mandelic acid, it is not only comedolytic and exfoliative, but it also has antibacterial properties. In our study, 40 patients of mild to moderate acne vulgaris were included. Out of these, 35% were males and 65% were females, and they were randomly divided into two groups, A and B. After doing priming with glycolic acid cream for 2 weeks,
The chemical peeling was done using standardized procedure. Group A received 30% mandelic acid peel and Group B received 30% salicylic acid peel every 2 weekly for 12 weeks. The endpoint in case of Group A was mild erythema or a time period of up to 5 to 6 minutes. And in case of Group B, it was pseudofrost formation or a time period of maximum 5 minutes. Neutralization was done using soda bicarbonate in case of Group A, whereas it was simply cleaned with plain water in case of Group B. Evaluation was done photographically and with GAG scoring every 4th week till the end of 12 weeks and every 6th week till the end of 24 weeks. This slide depicts global acne grading system scoring that was used for the assessment of improvement. In this, local score was calculated by multiplying factor that is specific for the particular site with grade that depends on the type of lesion. And after then, the global score was calculated by the sum of local scores and were graded as mild, moderate, severe, and very severe. In my study, patients up to a score of 30 were included. Grades of improvement were determined by reduction in the GAG score. That is before and after the treatment, and were graded as no response to very good response. These are the trends in GAG score, which decrease with treatment in both the groups. Percentage decrease in GAG score was 60.49% in mandelic acid group, which was comparable to 63.68% in salicylic acid group. And the pinnacle of improvement was seen after 4th sitting of chemical peeling. These are the pics before and after the treatment, and there is a moderate to good response in acne. Also, there is a reduction in the pigmentation as well as scarring. Safety-wise, both the peels were safe. Side effects like transient burning and erythema were nominal, easily manageable, and subsided within few hours to few minutes or to few hours. The side effects in the salicylic acid group, like post-peel dryness, visible skin peeling, and post-inflammatory hyperpigmentation, were not seen in case of the mandelic acid group, justifying its place among the already known crowd pleaser salicylic acid. In the nutshell, we can say chemical peeling is an easy, economical, and effective procedure. Both the peels are comparable in efficacy. And also this procedure can be combined with the oral treatment, and this makes young patients psychologically more satisfied and confident. Smaller molecular size of the mandelic acid lead to the slower penetration of this molecule, which makes this molecule gentler on the skin, and it is like a game changer for the clients who have acne prone but also have dry and sensitive skin. Thank you.
And the last candidate is Dr. Varsha Gowda.
A very good evening to one and all present here. Myself, Dr. Varsha Gowda, presenting a topic on study of metabolic syndrome in patient with acrocordons. To begin with, the term acrocordon is derived from Greek. Acro means top, cordy means string. These are also known as skin tags, soft fibromas or fibroepithelial polyps, which is soft, small skin color to dark brown sessile or pedunculated papilloma, commonly occurring on the neck. The incidence seen is about 46 to 50%, and it is equal in males and females. There are three types of acrocordons. First one is, which is most commonly seen, small furrowed papules of about 1 to 2 millimeter. The second one is multiple filiform of about 2 to 5 millimeter. And the third one is the large one, which is least commonly seen on the other, like on the lower part of the trunk. To know a little about the etiology, friction, which which activates tumor necrosis factor and activation of fibroblasts and keratinocytes, leads to formation of skin tags. Hormonal, like growth hormone, estrogen and progesterone. Infective cause like HPV virus, and most commonly metabolic syndrome, which is associated commonly with skin tags. Metabolic syndrome is a clustering of risk factors that are metabolic in origin and are associated with increased risk of cardiovascular diseases. It includes abdominal obesity, atherogenic dyslipidemia, elevated blood pressure, and raised blood glucose. The metabolic syndrome seems to have three potential etiological categories, including obesity, insulin resistance, and constellation of independent factors. Metabolic syndrome has to be taken care of because it is a burden on overall health, increased frequency of myocardial infarction, and increases mortality. What was the need for the present study? As a cardiovascular risk conferred by metabolic syndrome is higher than individual components. A very few studies have been documented so far. Furthermore, there is insufficient information regarding the relationship of number and size of acrocordons with the association of metabolic syndrome. Therefore, the present study was undertaken. The aims and objectives of my study were to study the association between metabolic syndrome and acrocordons and the correlation of metabolic syndrome with number and size of acrocordons. It was a non-interventional hospital-based cross-section study, included 100 patients of skin types with 100 age and sex match controls. We included patients of age more than or equal to 18 years with one skin type. Exclusion criteria were many diseases found to be associated with metabolic syndrome, history of endocrine diseases, pregnant women, patient with history of smoking and alcohol use, and many others. This was the structure of my study, which started with informed consent, detailed history, and waist circumference was measured at the midpoint between lower margin of last palpable rib and top of iliac crest and end of normal expiration. Blood pressure was recorded as the average of 2 readings, and the number and size of acrocordons were measured according to Kahana et al. Classification. According to number, it was few, moderate, and many. Size included very early, small, medium, and large. According to color, flesh color or skin color, hyperpigmented or mixed. According to side, eyelids, neck, axilla, trunk, and others. Venous samples were done after overnight fasting. Metabolic syndrome was diagnosed by South Asian Modified National Cholesterol Education Program Adult Panel 3, which included 5 points: waist circumference, fasting triglycerides, fasting HDL cholesterol, blood pressure, and fasting plasma glucose. According to the values, if 3 or more criteria points should be present, data was analyzed using SPSS software. These were my results. The first table depicts the age and sex distribution. We included 44 and 56 males and females respectively in my study, and age ranged from 20 to 87. These were the results. The mean and standard deviation in body mass of body mass index, waist circumference, fasting blood glucose, fasting triglycerides among cases were more than controls. Hence, the probability or p-value was significant in these parameters. However, in systolic blood pressure, serum cholesterol, and high-density lipoprotein, the mean and standard deviation were more in cases than controls, but the results were insignificant. This is the bar diagram depicting the same. We found 55 out of 100 patients had metabolic syndrome, and in controls, we had 24 patients out of 100. Hence, p-value was significant. Here, the number of subjects with metabolic syndrome versus size, we found in patients who had metabolic syndrome, the size of the acrocordon most commonly seen was medium size, that was 0.5 to 1 centimeter, and the color was most commonly with metabolic syndrome, hyperpigmented type was most common, and without metabolic syndrome, mixed variety was most common. Distribution, as per previous studies, most commonly it was seen in neck, followed by axilla and trunk. To begin with the discussion, it all started when Torren started to know the association of metabolic syndrome with acrocordons in 1951. Since then, a few clinical studies have been conducted. The left side shows the components of metabolic syndrome, and the right side, it is showing the dermatological disorders associated with metabolic syndrome like psoriasis, lichen planus, SLE, acne, rosacea, and least likely skin cancer. These are the previous studies, just to compare with my present study. In the first study, Epkinar et al. Saw increase the association among the fasting triglycerides and HDL cholesterol. He found 52% of the patients had metabolic syndrome. The next, Shah et al. Had 110 cases in controls. He found 52% had metabolic syndrome. The other study similarly showed 61, 72%, and 70%. In my study, we found 55% out of 100 cases had metabolic syndrome. Limitations were the small sample size and time-bound study. The conclusion, The acrocordons may represent a cutaneous sign for impaired carbohydrate or lipid metabolism and liver enzymes. The high prevalence of metabolic syndrome in patients of acrocordons reiterates the need for counseling of patients regarding healthy dietary habits and regular exercise, and the need for large-scale community-based programs for health awareness and lifestyle modification. These were my references, and thank you.
So next we have Dr. Faizan.
Good evening, everyone. The topic of my study is prevalence of cold-induced dermatosis in Kashmir Valley. Agar firdos barru hai zami ast, hami asto, hami asto, hami ast. Amir Khusro has rightly said, if there's ever a heaven on this earth, it is this, and it's this. Often quoted as the heaven on earth, the Kashmir Valley is home to beautiful gardens, pristine streams, and stunning landscapes. The abundant precipitation and snowfall in Kashmir, the sub-zero temperatures in winters, predispose the people of the valley to peculiar dermatoses, which are not generally seen in the predominantly tropical and subtropical region of the Indian subcontinent. The aim of our study was to determine the prevalence of cold-induced dermatosis in Kashmir Valley and also to study them as a comprehensive group. The study was a community-based study. For the purpose of the study, Kashmir was divided into 3 zones. One district was randomly selected from each zone, and 1 block was randomly selected from each district. All the villages in the block were line listed, and 2 villages were randomly selected from each block using probability proportional to size or PPS method. 200 subjects were selected from each village. Thus, the total number of cases were 1,200 with 602 males and 598 females. The most commonly encountered cold dermatosis was perniosis with a prevalence of 12.2%, followed by asterotic eczema, Raynaud's phenomenon, frostbite, cold paniculitis, cold urticaria, and levator reticularis. In case of perniosis, the gender distribution was skewed in favor of females, with more females being affected as compared to males, and the difference had a statistical significance. A family history of perniosis in a first-degree relative was seen in majority of the cases, and the difference again had a statistical significance. The age-specific prevalence of perniosis was found to decrease with increasing age. Thus, perniosis was found to be predominantly a disorder of young age. The age at the onset of perniosis or the first episode was less than 18 in majority of the cases, again with a statistical significance. The most common presentation was in the form of erythematous cyanotic swelling, followed by vesicular and bullous lesions, ulcerative lesions, targetoid and maculopapular presentation. So here we can see cases presenting in the form of erythematous cyanotic swelling in case of perniosis, bullous lesions and ulcerative lesions in cases of perniosis, maculopapular presentation of perniosis, targetoid or edema multiforme-like lesions. The mean BMI in cases of perniosis was found to be lesser as compared to controls, and the difference again had a statistical significance. Here we can see a case of superficial frostbite with waxy appearance of the little toe, and another case of deep frostbite with necrosis of the toe. Cold-mediated vasoconstriction in the case of Raynaud's phenomenon. The distribution of Raynaud's phenomenon was again more common in case of females as compared to males, and the difference had a statistical significance. Here we can see an elderly male with asterotic eczema showing the classical crazy pavement appearance. The age-specific prevalence of asterotic eczema increased with increasing age. Thus, asterotic eczema was found to be predominantly a disorder of the old age. Here we can see a case of cold paniculitis involving the cheeks. Cold dermatoses were found to occur more commonly in case of females overall. The difference could be attributed to the genetic differences between males and females as well as the hormonal differences. It has been seen that estrogen has a potentiating effect on the alpha-adrenergic mediated vasoconstriction. Thus, it is believed that the female hormones affect vasculature or the vascular system in such a way as to predispose them to vascular disorders and also to cold-induced disorders or susceptibility or an abnormal susceptibility to cold. Perniosis was found to occur more commonly in children and also had a family history in majority of the cases. Thus, it could be postulated that the abnormal sensitivity to cold may have an inherited component. It may have a genetic background. A person may be born with an abnormal susceptibility to cold. A lower BMI was again found to increase the susceptibility for perniosis. This was again expected, since the purpose of subcutaneous fat is to protect the core body temperature and to provide an insulation to the blood vessels. So a decreased BMI means that you have lesser body fat to protect your core body temperature, and thus you have an increased susceptibility to cold induced effects on your skin. Raynaud's phenomenon was again more common in females, especially in the reproductive age group. This could again be attributed to the hormonal effects of estrogen on the vasculature. Asteatotic eczema was a disorder of old age. In addition to the effects that cold causes on the skin, with increasing age, the level of lipids, proteins, amino acids, and keratin in the skin decreases, and the water holding capacity of the skin decreases with increasing age. Thus, older people or people in old age are more predisposed to develop the harsh effects or the adverse effects of cold exposure. In conclusion, cold weather can have a multitude of effects on the skin, and these can be confused with many commonly encountered skin disorders. The prevention or treatment of these is very simple, and an association with an underlying connective tissue disorder has to be ruled out in all the cases. So that would be all. Thank you so much.
So the last candidate now is Dr. Sukhpreet.
Good evening, everyone. My topic is dermoscopy of facial hypermelanotic disorders in a tertiary care hospital. Facial hypermelanosis is very common, especially in Asian skin. It has broad list of differentials which can be unspecific with naked eye. Dermoscopy, which is a non-invasive digital technique, has helped to define and ascertain certain differentials. Aims and objectives are to evaluate the dermoscopy of facial hypermelanotic disorders, excluding melasma, presenting to the dermatology OPD from December 19 to October 2020 of a tertiary care hospital. The study incorporated various patients which were examined clinically, and with the help of dermoscope, detailed history was taken. Differential diagnosis was made based on clinical as well as dermoscopic examination. The photographic documentation was done using camera of iPhone 10, which is 12 megapixels. Demographic data. In the first picture, on the right-hand side, the x-axis represents age in years and the y-axis represents number of patients. Most of the males were in the age group of 40 to 60 years, whereas most of the females were in the age group of 20 to 40 years. In the diagram on the left-hand side, we can see most of the patients were of lichen planus pigmentosus, followed by pigment contact dermatitis, facial acanthosis nigricans, further followed by ashidermatosis, nevus of Ota, and pigmentation due to vitamin B12 deficiency. The first picture is of patient of lichen planus pigmentosis. The dermoscopic findings that we saw and data reported in literature are perifollicular pigmentation, as we can see in the magnified view on the left-hand side in black, blotches in green, dots in blue, perifollicular sparing in red, and bluish blotches in yellow. Next picture is of dermoscopic analysis of pigment contact dermatitis. In this case, it was due to dye. We can see the dermoscopic findings are in the red, concentric arcuate structures, in the green, blotches, in the yellow, dots, in the blue are concentric annular structures, and in the black, dot inside an annular structure. Next are dermoscopic findings of pigmentation due to vitamin B12 deficiency. To my knowledge, till date, there haven't been any published reports of it. We clinically suspected vitamin B12 deficiency in this patient, which was later confirmed by very low levels of vitamin B12 in this patient. The dermoscopic findings that we found were perifollicular sparing as seen in red, perifollicular scales as seen in yellow, and periacrine pigmentation as seen in green.
Next is dermoscopic analysis of ashidermatosis. In this, the findings are dots as seen in red, blotches as seen in yellow, dots arranging themselves into arcuate pattern in green and into annular pattern in black. Next is dermoscopic analysis of facial acanthosis nigricans. The findings usually seen are dots, which are represented by the black circle, perifollicular sparing as seen by blue, crista cutis as seen by green, and sulcus cutis as seen by red. Next is lichen planus pigmentosis. The most common findings reported are perifollicular pigmentation as seen in green, perifollicular sparing as seen in red, dots seen in yellow, and hem-like pattern seen in blue. Next is dermoscopic features of pigmentary demarcation lines. We can see the demarcation between normal skin and the hyperpigmented skin. The dermoscopic findings in the hyperpigmented skin are dots as represented by blue circle, perifollicular sparing as seen in red circle, and white clots as seen by green circle. Discussion. Specific dermoscopic findings, they help in diagnosis due to correlating histopath features. The brown dots and globules, they represent cluster of melanophages in dermis and around follicular openings. Arcuate and annular structures, they represent increased basal hair pigment. Hem-like pattern represents dermomelanophages. Crista cutis and sulci cutis, it represents papillomatosis in the form of finger-like dermal pigmentation. Coming to the conclusion, dermoscopy is an important tool to distinguish various hypermelanotic disorders, especially when skin biopsy is refused by the patient. Also, it should be routinely used as an adjunct to examination with the unaided eye so that diagnosis can be confirmed and mismanagement of the patients can be avoided. There is a dearth of studies on this topic upon which it was presently explored. These are my references. Thank you.
So at backstage, we can have compilation of the results. So during that time, I would request Dr. James to distribute the certificates to the participants. So first is Dr. Amisha Mahajan. Dr. Amisha Mahajan is not here? Okay. Next is Dr. Ajay. Next is Dr. Arpita. Next is Dr. Arnav. You guys should clap for each other, no? Next is Dr. Divya. Dr. Divya is there? No? Next is Dr. Neetu. Next we have Dr. Nivedita. Next is Dr. Varsha. Dr. Faizan. And Dr. Sukhpreet. So we are in the process of compiling the results. So any guesses?
To be very frank, all of you presented really well, and it was actually a tight competition. So don't consider that one was lower than the other or anything, but we have to actually choose a winner. Very honestly, it was a tight competition. It was really difficult for me to, because there were like a couple of presentations which I really loved. So I was trying to score on multiple things. So based on that.
I would like to invite Mr. Deepak Srivastav from KLM, who has sponsored the iPad for you. So the winner is Dr. Arpita Hassan. So here we conclude SODC 2021. Honorable dignitaries, respected faculties, dermatologist community, and all our loved invited delegates, especially the young minds, young PG students, and people who have just finished their practice. It's my privilege to have you propose a vote of thanks on this occasion. A lot of hard work went into the organizing the conference and deliver the best to all the participants. I would like to thank all our SODC organizing team members for making this conference the most exciting and covering scientific sessions, workshops, quiz, award paper sessions, and especially the hands-on. It is a special note of appreciation to Dr. Madhuri Agarwal for her immense contribution and involvement. She has been the guiding force from day one of this conference. Please accept my sincere gratitude, Dr. Madhuri ma'am. I must mention a deep sense of acknowledgement for all the faculty members for putting in the efforts to give the best professional expertise through the hands-on workshops. Especially further our earnest admirations to Mrs. Suniti Iyer for being the strong pillar of support. It goes without saying that we are very thankful to Mr. Jatin Batra and from Dreams Event Conference Management and all his support staff, including Mrs. Priya, for the tremendous help and support in making this event a grand success. We are very grateful to all the team, all the man behind the back, and I thank all our sponsors and everyone present in the conference for making this event today a memorable one. Lastly, but not the least, my sincere gratitude to the team that worked behind the scene. I'm sure these 2 days would be etched into your heart and make a profound impact in your chosen professional fields. Meet you all in Amritsar in the 3rd week. We'll visit the Wagah border, we'll visit the Golden Temple, and we'll do the hands-on once again next year in April. See you guys.
Recording